Good morning. Menzil, Azmi here. Can you hear me? Good morning. Good morning, Menzil. Just try to communicate with him. Go to washroom for a while.
Monjil, good morning. Are you listening to us? Hello, are you listening? Monjil? We're not listening here. We see you, but we are not listening. Monjil, are you listening to us? This is Orlando here. Monjil?
Good morning.
Good morning.
Good morning. Nice to hear you.
So we're here.
Okay, let's start the conference. And I want to wish you all good day and first patient on the table.
So Azmi
The
is
patient
Dr.
is 28 years old.
Okay.
Yes, and it's good that you are here. I want to explain to Rene and Alberto, but I will explain to all of you. And now we are online.
Yes, please, Mazin.
In the control room, we have colleagues from the national tele channel, Kazakhstan. And the patient is 28 years old. It's unruptured brain AVM, and the patient has a headaches and nothing special on MR. Because of the seizures, patient went to MR, and on MR, this arteriovenous malformation was found. On MR, it's the same callosal AVM, and it's a Spessler-Martin grade 4. It's more than nearly 5 centimeter. Deep venous drainage. Also, we have some superficial drainage to the sagittal sinus. And this is indirect stuff from the PCA territory. And less visible left PCA territory, but I think there is also collaterals coming from behind. And we took 2 guiding catheters. Both are Neuron Max, 6 French guiding sheaths. And this is the right side, and this catheter placed on the right side. I already done a super selective injection from the right pericallosal artery. I think there is no connection from the MCA territory. All is from the anterior cerebral and the posterior cerebral. And this is the venous drainage. And yes, it's all went to deep veins. And this is again PCA territory. We have nearly two compartments. The front compartment here, and the compartment close to the internal cerebral vein. Yes, this is more illustrative, left side. It's look like more indirect. It's going to the front part of the vein, the first vein. And at this point, AVM is joining to the main vein. It's a big AVM, and we discussed with Alberto, it's not two-session AVM. Usually we do 4 or 5 sessions, and maybe at the end it's a transvenous approach or gamma knife. Rene, what is your opinion? Yes, it could be finished by embolization. Yes. Yes, it's a 4 or 5 steps. Yes. And now I will go with the Sonic 1.2, 1.5 certified to the left side. And let's discuss with Rene and Alberto. This is now, it's a super selective injection. It's more direct, both ACA, yes. And left ACA more indirect than right side. This is more proximal, and there is a branch. Let's see the vertebral arteries. It's more, yes. This part goes to the beginning of the vein, and this part goes to the middle part of the vein. And I think we need to start to attack from this point. But PCA is complex to access. Yeah. Maybe we can reach it from left side.
What
Yes,
material you
it's-
want to use today, Menzil? What embolic
Yes, yes,
material?
Khairul. Yeah.
Yes, Khairul, yeah. What embolic material you want to use? Obtura, onyx, squid?
We will see, we will see.
Guiding, can we do a combined injection from anterior and posterior?
Anterior posterior.
But, I mean, combined the delayed, no? We first start to specific.
Okay.
Good morning, Menzil. Tariq here.
Joint.
We need a left AC or right AC?
I think
I need to decide.
PCA. One PCA and one ACA to understand what the vein comes
Which
from
ACA?
here. I don't know where the posterior vein comes from. It's the one I see the less. The other one's what do I do?
Which AC? I don't know. Which ICA?
With the right ACA and one PCA.
One PCA. Okay.
Which is the last PCA? Is it the left or the right? The right, because here we've got a lot of washout.
Let's see. Yes, and I need to announce the second patient we prepared for today, MCA aneurysm. She had some heart problem, that's why we will finish with this case, and we have time of 2 operations. But Rene and Alberto has time till 11 because of the flight. Let's see. When it's
Oh, you see, go back. The last one, you did a selective view. We see another vein here.
yes, it's a
So the one before, you could see 2 veins getting up. The one here. On the lateral view, we have the one vein getting to the straight sinus. There's another one getting up that I did not see before without a selective view.
Good morning, Rene. Can somebody give a microphone to Rene to hear what he's saying and understand, be part of the
Just a-
discussion?
Роман, можно будет вторую петличку одеть? Вторую петличку Рене одеть.
Saying that you have to compare with
Okay. Okay. You need without Zoom. You need without Zoom. Okay. It's Zoom. Yeah. Okay. Zoom transmission. Okay. Let's see this. Yes, it was already the vein going up.
now you see it.
Yes. And then going to the deep drainage.
It would be good to see how veins effect. Like how far can we go today?
Okay, let's see the right vertebral artery before moving from the left IC territory. This is the left side. Right vertebral. Yes, this is better, huh?
See, here are 2 veins.
Yes.
The inferior was a caudal and the cranial one. And how is the connection between the caudal and the cranial to the other vein? Maybe it's a double injection we allow to understand.
But there is also information from the left side. Just a second. It's super selective. And this is Toshiba, yeah? Yes, this one. It goes like this.
Where are both guiding now? Both ACA?
This is on left ICA.
Uh-huh.
This is on right ICA.
Okay, so let's make a double now.
Double now.
With 3 seconds delay, that we can see first one vein then you can treat that one.
Meningeal system.
So wait for the previous phase of one before starting injection of the other one.
Stop. Just a second. Алдымен сен жүр, содан мен жүрем. Так, тұра тұр. Давай. Все, стоп. It's a 4D. 2D and 2D. 4D.
How many pedicle you want to tackle for this session for today, Menzil?
Just a second. Khairul,
Yes.
we just started and now nothing is clear. That's why we are doing 4D.
Yes, understand.
Yes. And the important thing is vein. I think there is a vein 1, vein 2. There should be 3 veins. 1 vein, second vein, maybe this other 2 veins. Yes.
Can we do it first and the second one to see if the vein is the same
Just
one?
a second.
So
I will leave it like this.
we started with right.
It's left. We start with left.
Okay.
Yes, just a second. I will put it on top. Just a second, and then
Okay, let's proceed. Okay, one back before. One back. One. Okay, here we see veins, and we see mainly this structure here.
just a second. And it should be some stenosis in the
Right sinus, yes.
sinus.
Explaining, you see, come back. Because of the stenosis,
Yes.
we have Petrov injection of the veins here.
There is a stenosis in straight sinus, yes. That's why this patient is very...
So we don't care of these veins. Huh? These are going to disappear
Yes.
as soon as the shunt volume will reduce there.
The patient is under risk of rupture because of straight sinus stenosis. Okay. And this is the, yes, there are different veins. Huh? The right side is mostly
It's similar, same vein, huh? Same vein. No,
same vein, but it's joining the upper one. It's look like it's joining more
Here,
proximal
here.
upper
Like
one.
this, there
Yes.
are two different veins. One is there, and one is here, and one is there.
Yeah.
See here, one is there, and the other one is up there. But still, they're around the same one, so we must not go beyond this point by injecting from the artery. Okay, same thing with posterior.
Okay.
If one could be replaced,
I will take the right one
yes, the one where you don't have so much.
because the right one is more proximal. Yes, Alberto. Or
The
the
right
same?
one.
Right, I see. This one is right. This one is right.
Yes,
And
so
it's more-
keep the right one.
Right one is in place.
Yes.
Okay.
Right one. Left by CH.
Left IC to PC. Left IC I will put on right. Right vertebra. Person. Роман, мы Рене дали микрофон? Do you have a Rom? Петличка есть еще одна? It's a Neuromax. It's more soft than coronary guidings. Now, Abu, the same. Just a second. No. Keep going here.
Dr. Orlando, how you manage this type of AVM in your center?
No.
This is an incidental AVM. I would consider strongly radiosurgery if that's a possibility, unless that we have to, because I think open surgery is very complicated and embolization is not easy, but over there in US, most likely we send it for radiosurgery. What about you? What do you think?
Yeah, I feel the same thing like with you. Maybe if the intervention or endovascular roles for this AVM to reduce the
We will
size,
have three veins, yes,
and then
from the
maybe
left side.
radiosurgery will do the rest of the job. How about you, Fabian?
Yeah, so interestingly, I'm going to show a similar case in my presentation today. It's almost similar, so you will be able to see how we manage them.
Okay, thank you. Keep it.
But see if Minzilkia does the same today. I think this type of AVM is very well manageable by endovascular embolization. For radiosurgery, it's large, so the risk of radionecrosis here is to be taken into account. But I think this AVM is a lot about the patient. So what is the patient age? And has there been a bleeding? A patient in an older age category, incidental finding, I would say leave it alone. A younger patient with a bleed, active management.
But in another situation, you could say, if you see very well, distinctively, that you take this primary vein and do all that part from right here.
The small one.
Transvenous.
But I think here we've got an arterial access, so it's probably better not to do arterial. But if you have a 6D, where
It looks like there is an aneurysm also there.
recognize, no, it's a loop.
Look, okay.
The same that this one.
That's a primary vein, and I think that is that primary vein the same that
Yes, it's
was
look
there.
like
I
that.
think so too.
Don't know.
In your practice, after when you do stage embolization, what is the duration between each embolization? How many weeks you call back the patient?
So I would say 3 months, 3 to 6 months.
Okay.
You see what I mean?
Yes,
You,
yes.
you need to have the legs of the vein to see it very precisely. Here probably could be a plan to go for stage venous, because what we see here are mostly anastomoses.
Yes.
But if we are not able to differentiate, we need to occlude everything. If you're able to differentiate, you just can go from the vein up to the shunts without doing more.
So finally, it would be like this. The two ways with the main vein and one like that, which is this one. So you need to go there to this and then leave this one.
Tariq, what's your strategy for example for like this case young with pericolossal AVM, colossal AVM? What your strategy of management patient? For example, like this is a big size, more than 5 centimeter.
We were discussing just Orlando and I was discussing about this. Probably we think there is a weak spot in the posterior compartment. There is intranidal aneurysm, probably
leave it in the
looks
vertebral
very
and-
ugly on that
I will
aspect.
take
So I would go with the posterior compartment the first, knock down as much as the sector embolization of that part, and anterior may subject to a SRS session. That's probably what we are.
I mean,
I will replace this one for the working artery. Now I will replace my neuromax from right vertebral to the left ICA. Because for me, it's comfortable to work from this guiding. It's only reason. Okay. It's 8F guiding, yes.
This is 6 French or 5 French guiding?
Neuromax 6 French.
Neuromax.
Neuromax 6 French is 8 French guiding catheter. And this one I will place to the right vertebral.
Okay.
Okay. And from right femoral, we went with the sheath, 11 centimeter, and then we placed the neuromax. And from the left femoral, we went directly with the neuromax as a sheath from the femoral artery. Okay. Just a second.
Do you give heparin for this procedure?
No, no heparin.
No heparin.
Нематоп промывку добавьте, пожалуйста. Нематоп қоссаңыздар 8 мл. Әрқайсысына. Айман, әр мешоктың ішіне 8 мл нематоп. Қосылып тұр ғой, да? Бәріне қоссаңыз, бәріне. Нематоп.
Fabian, do you heparinize your patient for AVM treatment?
Yes, just one dose.
One dose.
The question is heparin, Rene. Do you use heparin for the AVM cases?
No.
Yes, sir.
Really.
I think it's a placebo effect, yeah?
Because I experienced without heparin, I need to do thrombectomy, MCA, the guiding, if you're not flushing well.
Not all the time. Not all the time. If you are flushing all the time, then should be no problem.
Yeah, but I counted the problem.
Yes.
What's the blood pressure control for this case? Usually your for AVM embolization in your center?
Sorry, Khairul.
But blood pressure control.
Blood pressure in our country, if you ask anesthesiology team to give a general anesthesia, then your blood pressure all the time is 70.
Okay, good.
Okay, and at 11:30, just after coffee break, we have a live case from Visakhapatnam, and Siba is, I think
Siba is
he's
waiting.
going to be ready. Maybe Uday or Rajeev may contact with, or Tariq. Or Tariq Martin may contact with Siba and.
Yes,
Yes,
Tariq.
I already sent him the Zoom link.
Just make sure Siba is aware that Menzil or this send the Zoom link. Prepare
Yes, I
for
already sent the Zoom
case.
link.
Yeah.
And thanks to Kirill Orlov, he gave me the medal, and he noticed our influence
That's
with our
very, yeah.
YouTube transmission, Sunday live cases. Yeah? Thank you, Rens. Rens is a Russian endovascular neurosurgery society. Unfortunately, he couldn't come, but Nikolai from the team was on gala dinner, and he's in the room. Хабр, я сейчас слышу. Гибрид.
This is Sonic 1.5 or 1.25?
It's a 1.5, yes.
1.5. What's the detachment line?
Detachable length is
3?
we are used to use Apollo.
Oh,
That's
okay.
why we're asking our bulk distributor to bring all the time 35. It's comfortable length because we learned from the beginning how to use the Apollo.
I prefer Sonic because Sonic have a little bit curve at the end. So I think it's
But
categorized
the
well.
length of the Sonic 35 is 5 millimeter longer than Apollo. Yeah?
Yeah.
I connected with the Siva. Siva is Khairul. Siva is ready in another half an hour.
Okay.
Okay. So
Great.
he's trying to prepare. It's half
But
an hour.
I think we will be ready to connect with him at 11.
When you want to connect him, Menzil? Very soon?
With the schedule 11:30 after coffee break.
After coffee break.
Uh,
The primary vein training, the question is, do we
Just
accept
for a discussion,
to put this vein or not?
any
No.
difference you feel between an
It's
Apollo and
unfortunate.
the Sonic?
Primary vein,
It's possible.
if we're able from this vein to go to get the
Yes.
other outfit. Not from
What you, how you feel Sonic and
Yeah, it's
Apollo?
okay. So for deep pile
Zamira.
work, we have the
Ana,
Sonic
niye
1.2. I mean,
de
it's
altı
an
digens biraz var.
outstanding
Yapmak
catheter.
istemiyorum.
Then the Apollo cannot match. Then of course we have the larger Sonics also, and I would say they are quite comparable. The difference is that the Apollos only have a mechanical detachment. The Sonic has a chemical. It has a mechanical detachment and glue. So the detachment of the catheters is a little bit different. The Sonic you might need some DMSO to work on the glue before you can safely detach. The
Kişi
Apollo is
adil
straightforward.
soru. Son ben de
Any
koysun.
input from you? So, Sonic, I completely agree. It's more navigable. We have got two options of 1.5 and 1.2. But we have seen a lot of leaks coming from the thing where we are navigating too much or doing too many of manual traction. The leaks in the Sonic, do you feel the same?
So is it the leaks from the
Detachment,
part,
yeah.
The detachment part.
Yeah. So the Sonic 1.2, it's more fragile, and 2, I mean, working with that in the external, in the meninges, doing tough work, of course you can hurt the detachment zone and have a proximal leak of onyx or squid, yes.
In fact, 2 points I got to know. You are not allowed to inject Sonic with a 1 cc syringe. It's written in there.
Yeah,
because you develop too much of pressure and you can weaken the thing.
And it also says that you are only allowed to use the 007 wire with the
yeah.
Sonic in the IFU.
1.2.
In the 1.2, yes.
The 1 point. But with the 1.5 also, I'm told.
I don't know, the 1.5 you can probably use a larger wire, but so in the IFU, yes, you are not allowed to use for the 1.2, which is the one I use, you're not allowed to use the larger guide wire, the 008, but it is okay to use, I think, and also I use it with the 1 mil syringes without any problem. So.
In fact, in one of our case, we have seen the pressure on the detachment and the detachment got leaky because we used the very distal axis of the wire and the harder part of the wire was near the detachment zone.
Yes, that is a good point. You have to be careful about that. Yeah.
Okay. It's very much more.
Yeah, I still prefer for intracranial work with sonic, with combination with their own wire, hybrid wire, because they can go very distal and easy to navigate.
Примерка барода, она гибрид.
Of course, they have to be very gentle to prevent early
Medical
detachment.
team son birini açsanız. Bir gibrit, bir medik. Новый вот, да? Гибрид кережок, magic болса болады.
What's your technique, Tariq, for plugging? You have pressure cooker arterially or plugging technique? How you create the plug fast? For me, I will use first fill as a plugging, followed by penetrate with squid 12, 18.
We do use 18 most of the time, unless until we expect probably will require a 12 or a high fistula or change to a 34 something. If it is just not a coil plugging, not a pressure cooker plugging, then the initial injections are slightly fast, and the cast has to become completely black so that we know, yes, the plug has formed. Because unless until there are some transparency lying there, probably you have not found a good plug. So the initial injections are where the plug is going to come in. That's slightly with the more pressure.
It's very challenging case with multiple feeders and posterior choroidal, very small.
Anyway, we can start and then we'll see by controls.
Can you go back to the right side, right injection, or is it back to the right side?
As the AVM is all the time teaching cases, yeah?
You will always...
You never know when this is different one.
Can you do one more proximal? Yeah. Or
Just a second.
Okay, it's a different way, no? So same primary.
yeah,
It's a different way. It's a different. I think we can. Okay, this location is okay for headway. Yes.
Situation is okay. I think we don't need to control indeed the right here.
Okay.
The right here uses a different vein.
Yes.
It's good that we control the posterior because this is getting rather to the same vein.
Do we need magic in posterior?
So what is your final decision now, Menzil? With the team there, with Rob Rennie?
Suddenly we'll put the vein independently and try to navigate. It will be more difficult to understand. Now we understand how the anatomy is.
Okay, and now we prepare magic 1.2 F. There are two kinds of magics. One is F, one is FM.
Oh.
This is F.
What's the different F and this now, the SM?
FM, the length of the soft distal part. FM, I think it's a 3 centimeter distal soft, and the F is 12 centimeter.
Using hybrid wire now?
Yes, hybrid 7. Also through the Magic 1.2 possible to push the hybrid 8 with no problem.
Okay.
I think we need emulation.
Tariq, do you have experience when you cannot detach sonic or any detachable catheter during intra-arterial embolization? And what you do in that kind of cases?
Yes, just leave it in the artery. Yes, and another technique I already explained before, I have seen from Zsolt Kucsár, I think. It's possible to place the microcatheter, the second one proximal with wire inside. And then it's possible to retract the detachable microcatheter. It's releasing the pressure on the artery.
Okay.
Okay, I will go distally, and then with super selective injection, we can check which one is which. Так, проект спецперсонаж стал бы. Проект. Сам здесь. Yes, and my assistant is Abu Bakr. He's a neurosurgeon. René. Okay.
Here, Magic is dedicated in the right CA in order to understand how the arteries are getting there, because we have the impression, we cannot confirm by 100%, but we have the impression that the drainage of the compartment from the left ACA is the same drainage from what is coming from the right PCA. So, worst case scenario, by transarterial embolization to the left ACA, we occlude drainage of the left PCA. And then we would have to do a transarterial embolization. But better before to analyze how the arteries are, and now we're beyond the arteries feeding the AVM. We're to the arteries.
We can't hear René here clearly for some reason.
Не слышно. Роман. Just a second. We will ask René to repeat the comment.
Hello? Does it work?
It's not still the same, still not clear.
Oh, it's okay. Just a second. It's coming. No problem. No, just. Есть, да? Just a second. It's on the way. And I was saying Kazakh language. Қасымда тұрған екі жігіт, Альберто мен Рене, дүние жүзіндегі мальформация емдеуден жетекші эксперттер. Сондықтан мальформация емдеуді үйренетін кісілер болатын болса, осы екі мықты специалисттен үйренсеңіздер болады. I'm talking about your experience in brain AVM, Alberto. Okay. Now let's kill
Hello. Does it work now? Yes. Can you hear me?
Yes.
Slightly better.
That's marvelous. Marvelous.
Okay, Orlando, can you hear me?
That's excellent.
Yes, perfect, perfect.
That's perfect.
Okay, so
Could you please explain the plan for us to understand?
So we've been trying to understand how the drainage of each compartment is, and it's not so easy. So as we cannot play with colors, we've been playing with simultaneous injection or slightly delayed injection from the different feeding arteries. There are three feeding arteries: right ICA, right ACA, left ACA, and right PCA. It seems that the drainage of the right ACA, the right pericallosal, is different than the drainage of both left anterior, right posterior. In other words, left anterior and right posterior seem to have a similar drainage. To confirm this, microcatheters are being placed in the left anterior cerebral artery in position to embolize because it's the best position. But the risk here would be if we over-embolize, not knowing exactly where to stop, because you cannot see exactly where the common vein starts. We have to continue proceed embolization from the posterior cerebral artery. So before starting embolization from the anterior, now we explore all arteries from the posterior to know how to get there. Because access is not so simple. Access from the anterior is the easiest. The different branches of the posterior are more difficult. So this is the first goal. The second goal is when we have the microcatheters of anterior and posterior in place, then we will be able to analyze the vein much better by the selective injection. So Mitchell is now just found one side branch of the PCA, which goes to the medial cortex. And soon we're going to have a simultaneous injection from the selective feeder of the PCA and from the ACA.
Fabian, this is especially for you.
So this is the anterior, and this is the posterior. So anterior cerebral artery, and look at the A projection. The AP projection, you see a vein which looks horizontal. Next picture. Next. And here we realize that it's probably a different vein of drainage from the posterior that we look at now and from the anterior, which was just before. So it's good because it means that if we further embolize up to this primary vein, we will not compromise the outflow of this artery. Anyway, the microcatheter is in place, so we'll be able to control during embolization to make sure that we don't compromise the outflow. Here's the AP view, shows a vein which is horizontal.
Yes, we can see the row, yes.
And this horizontal vein, if you look at the selective outflow from the posterior circulation, you don't see it. which means when we embolize here, we will be allowed to occlude that vein.
Вот маска же слышишь?
Because we did not see it from the right ACA, and we don't see it from the left PCA.
Just a second, I understand you. Just a second. No, it's okay. Yes.
So Minchil just made a roadmap
Yes.
from one artery, and then he's going to inject the other one. And it will show that the same vein is not being used.
Yes, different veins.
So now we have the confirmation.
It's a history. It's a history of 6D. Yes.
Exactly.
So it's clear.
How many Ds total? 6, 8.
No, as we cannot fuse here the rotational angiograms, you can do it this way. It's just that it's additional efforts to put the microcasters in place, but we need this analysis.
Okay, I will place coil. For the you see, but
So we keep the magic in the posterior because it's good to have an understanding from inside. And now Minchil is starting the
okay, we need general anesthesia.
pressure cooker from the ACA.
Yes, maybe I need to pull a little bit the microcatheter. Yes. This one, how do I do
But
it?
the position of microcaster number 2 to the plug is a bit too distal because we could see some feeders to the AVM originating just from the origin. That's why he's taking it slightly back a few millimeters.
But there is a branch
Here,
going to
yes.
the. Okay. We have a glue, Alberto. We can use. We can mix with glue today.
So the advantage of two microcatheters, one is in place, where you had to do potentially a lot of efforts to bring it in.
Okay.
You want to know what is
avoid mistake, I will
front, what is
put it here.
behind. And the second catheter shows you how much reflux you can tolerate, where to place the plug. Otherwise, you have to take it back and potentially you lose your difficult access. So we're looking mainly here at the unsubtract screens. I don't know whether you have them.
Yes, they have.
Okay.
Yes, we can see 1,
Yes,
2, 3, 4,
Khairul,
5 markers.
You have four?
Yeah, we
Four
can see.
screens?
How many screens do you see in the room? 2 or 4?
Khairul.
Yes, how many dot? 4.
Two.
On the top, 1, 2, 3, 4, 5. Lower posterior 1 dot on the lateral view.
Okay.
Very clear.
Then you see as well as we do.
Yeah, we can see glue. This is glue, right? Injecting, yes.
No, it's a coil.
This is
It's coils,
coil.
coils.
So to pressure.
It's a microplex coil 3x6. And the next coil will be 2x6. Zamira. Big delta. Yeah, optimal coil. And usually I'm joking in the cat lab. I'm saying it's the best coil in the world.
Optimal.
No. Andrey. Yes.
You deliver through marathon, this one?
One more coil and then glue.
Yeah, we can see that.
Замира, бана бір тюбик ташысаңыз, и жоқ, ана жерде тюбик бар ғой, соны ашып.
So both cooks are Minchil and Alberto.
Yes.
Minchil is cooking with coils and Alberto is cooking with cocktail.
And thanks to Cheki, he brought the Istakil.
Thank you, Cheki, for Intra-arterial, which is not distributed by bulks as far as I know.
Yes. We need sugar. Okay, this is a Kazakh pressure cooker without glue. But it's faster when you add some sugar and it's a dense packing, huh?
What is your glue concentration for this plug?
I think 50%, huh?
50%.
Yes,
If
50%.
you dilute more, the chance for the glue to be unstable.
This was the best coil in the world. Yeah. The second one.
The Optima.
Optima.
Minchil used an Optima, which is an extremely soft coil, which is easy to compact.
What's the diameter for this Optima, Wenzil, for this vessel, 1 mm?
Small one.
The first one was 3x6 microplex, and the second one was Optima Super Soft 2x8.
2 by 8.
Yeah, there is a branch little bit proximal, huh?
But it's
But you
okay.
can cut it with the
It will diffuse.
pressure with glue, huh?
It's okay.
That's okay.
So the goal of the coils is to realize a filter, so that injection of concentrated glue.
If you will wait 10 minutes, coil will thrombose and artery will block.
Yes, with potential drawback, and if it's thrombosed, the glue you inject goes immediately back.
Yes.
You have less
Then we
filling of the
can.
whole artery.
Okay. Alberto, we are ready.
If it's alone, then it's better to do
Yeah.
to wait. If you want to do glue and with NBCA, better not wait.
Glitado. You need glitado or it's a glucose? Huh? Yes. This is sugar. Ah, you're old man. Yes, we all need glasses for hypermetropy. Lipidol, кишек жир.
You want to get with this or too much?
No, it's too much. Let's take this syringe. No, we can do it.
What's for the heat?
Глюкоза, он буфер, чтобы клей не застыл. Да, буфер.
Take it to the pig.
Интра-артериал, да. А там всего чуть-чуть. Это не был. Это была спираль. Хорошо. Мы будем работать 2 часа. Рассчитайте, чтобы 2 часа был глубокий наркоз. И давление нужно 60-70. Да. 80 можно. 70-80 можно.
Very good, no reflux.
Yes. Just a second. I'm okay. Now I couldn't check, and I need the 10 cc syringe. Yes. Now artery is starting to be blocked. Yeah. It's electricity in detachment system, and when you detach with electrical detachable coils, blood pressure is 90. Now they will decrease till 70. Okay, thank you. This is a glue. It's a classical pressure cooker technique. When you place one detachable and another is non-detachable, place coils, and then 50 to 70% of MBCA. Okay. And today we have a lot of room, and it's okay to inject with the roadmap. And yesterday it was a posterior fossa and a very short distance for the reflux. And as Alberto commented, it's better to inject NBCA before the obtura.
Okay.
NBCA may go into the obtura and it may mix, yes.
Now it's fluid going out.
Yes, it is occluded, no?
No, it's okay.
Should come back, not too matter.
Now it's occluded. Now it's occluded. Okay. Left olsun. Şüphesini aldı. Romatik kütlesini bulup. Okay.
That's good. Very nice.
I hope so. And there is a small branch proximal. Yes, we can go later. Okay. Okay, let's. Now it's a classical pressure cooker.
Okay.
You create plaque and then you can do injection. Yes.
Then she is washing out the microcatheter, and then we'll start with Obtura. Today is Obtura 20. We'll see if in the course of embolization we'll reduce the viscosity.
And I'm asking Alberto, I want to do the United Color of Benetton today. You know? United Color of Benetton? We will start with the Aptura, and at the end I will mix with that guy, Squid. One second. Okay, let's start. Мы начинаем вводить эмболизатор. Ага. Да, спасибо. And we need to keep in mind this is a Canon Toshiba. And now I can inject
Obtura, yeah. Obtura 20.
not in Spanish, I can inject faster.
Yeah, we can see that come out.
And this is a Sonic 1.5 and little bit resistance in the catheter, in the syringe, yes, but not so much comparing with the tantalum-based liquid embolics. I think this is going to the vein, yeah? This is vein.
Here, okay.
This is vein.
So we see we arrive quite rapidly to this vein you just saw on A. That's why it's important to have excluded from the beginning that this vein had to be kept or not. You see, very rapidly after the beginning, we're already in this vein.
If Obtura, how many seconds we can inject for the next injection after we stop?
Oh, half an hour. You can leave the syringe and wait 30 minutes.
So now we started to mark the vein on A, on unsubtracted. We know where the vein is.
Okay, yes.
This is another one.
Now it's finding another one. Okay.
Okay.
Which
It is
this is the main
another one.
vein, which is coming from the ACA.
Yes. It goes. This one. You can see the vein going cortically to the sagittal sinus, this one. And Fabian, the button on Philips is less complicated than on Canon. Yes.
Yes.
Also, you need to wait after pressing this button.
Yeah, we know about pushing the button on the Philips system.
Yes, it's quite good, huh?
Yeah.
There is a branch collateral.
It's an artery.
This goes to opens arterial anastomosis. So on B, on lateral view, we had just a little string that goes to arterial anastomosis, or maybe an arthro vein here, but I don't think so. It was too proximal in the course.
Okay.
The vein again, another vein.
This one is the vein going up. And we need to put the timer. Now we took 20 minutes from the presentation, and I'm asking if it's possible we should do live case at 2 p.m. and we will shift that time to this live case. Sorry, it's a event case. It's not word placement. I remember the AVM case we did with René on Icono in 2022 to our OSIN meeting in China, and it took nearly 4 hours. 3.5 hours.
I mean, the end takes
Yes.
several hours. If
Several hours.
the more you want to try to understand, the more you invest time.
And finally, we did another 2 sessions, and AVM was completely excluded from the meeting in 2022. It was a occipital temporal region, yes. I need one more. This is vein.
That's good.
Yeah.
I'm not sure.
This is vein.
It
Yeah.
has to be the vein on
Yeah.
vein.
That patient came from Bishkek, from Kyrgyzstan.
I think it's a vein that comes from the ACA. Yes, yes. We're connecting to the vein of the ACA. In the end, what we're looking at today is mainly when we reach which vein.
This vein. Yeah. It's
Okay,
separate.
no.
Okay.
Here it's a conditional vein, one of the outflow vein that was getting cranially, which was just
Okay, let's wait a little bit. As Alberto commented, the reflux with the Artura is longer creation of the cushion plaque. Yes. Okay. It's like a squid 6, I think, yeah? Not 12. Alberto. think this
He
is
is
the
good.
vein.
He shows that we're feeling arterial network.
But this is look like
Yes, the one which
yeah.
is the most ventral is more vein.
Okay, let's do Andrew. I think the proximal part is using the same way, no? Ah, this is the beginning of the main vein.
Yes.
And then we have a magic, we may go to that point and inject some 30% NBCA or we can take that point for this next session.
That's good here because it's
It's going to be
everything
very
which is here lateral is good. Everything which is medial is less good.
Just wait 1 minute, something like that. Apply suppose that then go to the primary vein. Let's wait 1 minute.
Okay. With the Aptura, it's possible to go to smoke and come back.
If you smoke.
Alberto is smoking, yes. He asked Mario to design such kind of liquid embolic. It's allowed to go smoking.
So Minjil, with the obtura, when it diffuses to the vein, it looks like, for example, when you diffuse to the congestional vein, that it carries a little bit. It travels quite. It continues in the vein quite a distance. Is it because you're pushing hard, or is it the way obtura behaves?
Pushing, yes. Yes, it was a little bit hard pushing. Because of the cooked raw, yes. I pushed a little bit harder and
Do you think any different behavior between squid, onyx, obtura? Feel?
yes, as I commented, it's looked like squid 6.
With 6. Oh, very dilute.
I mean, Phil has a different behavior. Phil is not to be compared with tinidine and alcohol. The behavior of obtura with squid and onyx is quite similar.
Okay, understand, bro.
It's more a question of you don't block the microcatheter because there is no tantalum inside.
And now we did in a pulsatil Spanish way. And Shimon, if he's online, he's also doing tack, tack, tack. Don't CCA phonics.
Yes. Just start to inject slowly, just to make to the liquid embolic agent. So if you control injection, I think it's better from the beginning. But now it's going to the primary vein all the time, so we have to wait. We waited for 1 minute, now we will wait for 2 minutes. Try to go to other compartment of the AVM.
It's a vein, huh? It's a vein. Let's look at my. And then you need to send me the time to do united colors.
So I prefer to inject more rapidly, and the reason is the following. If you inject very slowly, you cannot really appreciate the own kinetics of the embolic agent. It depends on the pressure on your syringe. If you inject with a little higher speed, you can see when you're in your artery that you've got a pulsatile flow, and the embolic agent is moving on the way with saccade, and if it's in the vein, as soon as you stop to inject, it continues to progress in the vein. But I don't have enough experience with Obtura to be able to say if it's the same thing I expect. But here we're getting rather to the vein, so it's a good way to leave it, wait for a couple of minutes.
Let's smoke.
Hi Alberto, hi René.
Make a run in the posterior. Okay.
It's a different vein.
We are sure here that there is no compromise in outflow, so that's good. And of course, at some point, we have to control the right ACA. But the right ACA is well accessible. So if there is some flow which is reduced, it can be done.
У них 4 экрана же, да?
Yes, but we're rather going in the outflow vein of the ACA.
Бүгін кафетерий істейді ме екен? ЛБК. İstemedi onu, değil mi? I think we can go to the coffee break before the airport. Yes, we have time. I hope so. Yes, yes.
I'm Guillermo.
Yes, Guillermo.
Hey, good morning. I have a question for Alberto. I understood that Obtura is always better to inject it with a pressure cooker. Is it right or not?
Yes. Is it right because you control the reflux?
Okay, so it does...
The main problem is that all of us, we are adapted to squid or onyx injection. And as René said, to achieve a good penetration with this liquid embolic agent, we inject fast, okay? Yeah. But when you inject fast, the likelihood to control everything is less, but of course, with this liquid embolic, we did like that. The problem is that now, with pressure cooker, all of us became less patient, so we want to do everything fast and quick, but with this liquid embolic agent, you have to take into account that you have to inject very slowly and take into account everything. It's not always like this. It depends on the architecture of the AVM. In this case, it seems that there is a lot of connections with this primary vein, so I think this is the reason, but it's a matter of waiting. We have to wait, and even 2-3 minutes. We are not adapted to this because we get bored, but I think that is the good recommendation. Just wait until the liquid embolic agent will precipitate and solidify in the structure. We don't want to keep on going, and this is one of the main important things.
So here,
thank you.
This picture, see on the lateral view. Can you give the next
For
one?
us, has been tough also to adapt to this new technique because we all do pressure cooker, and when you do pressure cooker, you don't have patience.
And I don't think that it's related to this.
Yes.
Here it starts being quite large. This must be the main draining vein.
Yes, it's the beginning of the main.
Here I think it's quite logical to take some magic out and to bring the guiding in the ACA. We have a perfect outflow. It comes through veins which are not that one.
We need to check the...
I would like to control the ACA now. I think it would make sense because if you look at the cast shows you a vein which is not so small, and it could be the drainage from the right ACA. So let's control. No, leave him inside. You can put the guiding in parallel.
Right, I see it. Oh,
Yeah, remote verify. So now we change the position of the guiding to the right verge, to the right ACA. Oh, which works even without guiding. And then the same magic can be used to be placed inside the ACA, and it will help us to see what's going on there. Okay. We can subtract here, see where the agent is. I mean, unsubtract, yeah.
A second.
Okay, here, and subtract again.
A second. I think it's using the same right now.
It's still quite large.
Do I need to go to the AC territory?
Why not to bring the microcatheter inside? Replace.
Yes.
So now the magic is going to be placed in the right distal ACA, and it will allow to control what's going on there. We don't see any compromise now on the venous outflow, but still the analysis remains difficult. Any risk that the sonic occludes now? No. Okay, so that's very nice. If you wait too long with a sonic 1.2, if you wait more than 3-4 minutes, the chance for the microcatheter to occlude is not so small. Here we have all the time to bring a microcatheter in the right ACA, and which is even better, so it prevents us from too early injection. Yes, the wire becomes sticky. You see when you're pulling the wire, it's... It was okay, no?
I think it's went to the different branch now. I need to inject a little bit. Now it's better. Yes, now we're including the proximal part. Yes.
Something that's
Okay, excellent. The time that was used.
also to the vein. So wait.
Okay.
We're going to the
It's getting through the BCA. See?
Okay, it was the Прекрасно. Пожалуйста.
So engagement is partially in the vein. See the vein is narrow. So more should not be good.
one more minute.
1 moment, okay. Now I will ask for squid after 1 injection, no? Okay. Okay.
So you tell you that this compartment is not related to the other one, you know?
That's quite big. So interestingly, we were most fearing about the inferior vein on A, which has only a small amount of embolic, and the larger one has got much more. But it's probably a layering. Fill here would behave differently and would be more prone to occlude the vein.
The other explanation is that this part of the nidus, I think we all believe that is connected with the more anterior branch of this left anterior cerebral artery, but maybe they are not connected. This is the other explanation, but of course we all expect more diffusion into the anterior part of this feeder. Like that. There is some reflux between the MPCA and some,
Back to the coils, yeah.
yeah.
But otherwise, it's not bad. It's not bleeding too, so
Some proximal vein as well, but this is not a problem.
What are you injecting now? You change to a squid, or you're continuing with Optura?
It's still Aptura. Aptura 20, yes?
the
Yes,
other compartment
absolutely.
has been done. We opened just before the anastomosis. We could see that when the Optura came through the NBCA and coils, we had some proximal occlusion there, so this is likely to be done.
It's the same Aptura, Orlando.
You know, it was not the main vein, so I would continue.
Was yet? But we want to start into that, that's only the origin of the final age. Take care.
And
Okay.
it's away.
Yeah, this is not so distal, but it's distal. What do you think about going to another feeder now?
It takes the ACA, the right ACA.
But I think we could stop at this point.
Or we can stop.
Yes.
Let's control the right ACA to see how the venous outflow is. If it's good, we can leave it. We wait for the AVM to reorganize.
Yes.
And the microcatheter change. Yeah.
Can you do
It's okay.
complete view?
Yes. Can we make 45 degrees A and B? Now I see more in the vein on this view.
Maybe we need to continue from the right side, no?
Is it the same or not? Is it inside this one? Let's subtract.
Just the beginning. It's joining at one point.
Yeah.
Venous bifurcation. Так, контраст, нет, физраст работает нормально. Super selective? One second.
The vein now is not slowed down, but we don't know how long it will stay. And I think that at some point, thrombotic agent went from one vein to the other one. So we can wait to see how this remains. but-
Angulate finally for A. No. Okay, like this.
This?
No, that's good.
Okay?
Yes, it's what we want to see here at the part.
Right side, no?
So the question now is to stop or not. How much is the outflow compromised? There is some material in the vein, but the flow is good. So either we leave it here, considering that the flow is good and this will not thrombose, potentially giving some heparin to the patient. The alternative is to say, in case of doubt, this is to be embolized without knowing when you do more how it will stop. So it should be rather proximal embolization. If a second one, I think
I will
both
do
options.
with push and then we'll stop.
But the flow is good.
Yes, the flow is good.
So we restart up to R.
Good.
Okay, that
There
thing
is
is
also
flow is
vein.
good.
There's also something in the vein.
It's a little network around the artery, the anterior part.
And also the vein.
I'm not
This-
sure in A. I don't see well in A. Works a lot.
I think we can stop. I don't know
Yes,
at this
yes.
point. Yes. Let's do contra-angel. If everything is okay, then we prefer to stop at this point. Let's say first up tour, one of the first up tour in Kazakhstan, and the result is acceptable, then we don't need to push more. We have time, we can stop. Yes. Yes, we took the proximal compartment also.
So because there's a suspicion of material in the vein, I think it would be quite logical to give him some heparin, low dose,
Okay.
500 units per hour, something like this.
Олег Галина, надо будет приготовить гепарин и вводить со скоростью 500 единиц в час, но после того, как мы КТ сделаем. Я скажу, когда может подключиться. Хорошо?
PCA.
PC. I think we can take out the magic and
Rennie, from here, so we are leaving this compartment of the right AC as of now?
Yes, the outflow is good. So if we,
можно будет зарядить, чтобы на сутки 500,
the chance to
yeah,
have
шприц 20, чтобы было
the
500 в час.
substituted and then the need to continue with the PCA is
500
quite
единиц в час.
important. So the more you do, the more you go to the vein, and at some point, the more you increase hemorrhagic risk.
What
So
we,
finding a way to stage
what
is
we
safe.
understand from here, probably correct me, there was a branching vein that was converging to a common vein, which was draining the left or the right anterior supply. Was it like that?
Yes.
And
That's-
we got some of the material layered in the right anterior draining part, in the most early part of that vein.
Yes.
And
Yes.
we believe that vein, the material is not that occlusive?
Yes, it's some layering on the wall, but there is still a good outflow. There is no occlusion of this vein, so it's probably safer to leave it like this.
Okay.
Otherwise, by treating now the right ACA, the main vein will be occluded with a very high likelihood. So that then you have to continue with a PCA.
But what we could understand from that, the PCA selective control run, the PCA was having a different sector of drainage.
Yes, we presume before embolization that it was the same one, and we understood once it was done that the veins were different. Before, I don't think that with angio alone it was possible to make this differentiation.
But I agree with your point. I know what you are saying, that we can do the right anterior cerebral artery now because it's the same vein, and there is another venous outflow for the posterior cerebral compartment, the posterior compartment. But the problem is that if we reduce the flow of the AVM 60%, say, 2/3 of the flow, the likelihood that this, the main vein thrombose, not because more material inside, but because of a reduction of flow in the vein, can be other alternatives. So I think it's better to wait, to stop here as well.
Okay, thank you.
But then we want to continue with Siba case. It should be now 11:30.
Siva is ready. He has given a call. He is ready with this case.
Let's continue with Siba. Now we will do control CT. I hope everything is clear, and we will join you at coffee break at 11. Yeah.
And another option that can be considered now, we have a nice flow in the vein in the right side compartment, but another option is to wait half an hour and do another run. And if everything is the same, you are convinced to leave it like that. But if you see some reduction in flow of the right compartment, maybe it's an alternative to go. But it could be another intermediate alternative to do a run in half an hour. But I think it's very.
Yes, Alberto, you're right. It's a very good option to take some time to wait and to see how the situation is evaluating. But none of us believes that the vein is going to thrombose.
Training well,
But I mean, this would be a confirmation. I don't know what is the schedule here.
That's okay, it's okay. It's only case for today.
Okay, so let's wait. Huh? We can do the CT.
We have no supply from the left side now, and I don't need guiding on the left ICA. That's why I will leave. Maybe I will replace this guiding. Okay, I will replace this guiding with the regular sheath. Ce să introduci să văd? Svet ce să zici? Doch nie sirk. Şimdi sirk.
How is it connected?
Yes.
I would like to say something else.
Could you hear us? Они слышат нас? Можно будет подключиться? Рон? Слышат? Yes, Alberto will comment. Okay.
I would like to stress that this is an illustrative case about what are the dangers related with AVM embolization, because we were all focused on the right side primary vein, side primary vein, but finally the compartment of what we injected is also related with the main vein through another primary vein which is very small. The problem when you have a primary vein very small connected with the main vein is that you don't realize that it is the vein until it doesn't matter which type of liquid embolic, but until a certain amount of liquid embolic start to show that this is a vein. So this was, I think, the problem in this case. Started to get in the vein from the artery, but we didn't realize until there was enough amount of liquid embolic until we realized that it was a vein. So I think that this is illustrative case to see that we have to control the vein in an obsessive way. And finally we did, I think we stopped in the proper moment, but if you go on with this, maybe you have to go for the whole AVM. So I think it was a nice case to share, and I think that in half an hour everything will be the same and the decision will be the proper one.
Let's wait. Arjun, the introduce to Sandor. I will do control Andrew now from the right side. The left is okay. There is no flow from the left side. Oh, мы продолжаем. Ты туда идешь, Шабу?
I ate for we have a nice way for can control in a 3D way, where a drop of proceeding when we don't want. The guy in the walking Japanese before,
Сейчас КТ сделаем. Please connect to Siba. Nadir. Khairul, Nadir.
Yes, now please, we have live transmission from Dr. Siba from India.
Vishakapatnam, India. Нам физраствор слышишь? Замира, ну физраствор слышишь?
Hello, can we connect to Dr. Siba from India now? Thank you, Manzil, Rene, and Alberto for nice case illustration, how Aptura works, and also detailed analysis, management of brain AVM.
Thank you, Khairul.
Thank you very much.
Let's continue with the Shiba.
Yes, please.
Ром, можно нас выключить?
Hi, babe. Before Siba get ready with the case, I think we can continue our presentation with Fabian now, so that we don't waste our time. Then after that, maybe I can continue for the next lecture. For this session, we need Rajeev as a moderator. Yes, Fabian, you can use your lecture.
Okay, let's get the slides on the screen. So can we get the slides on the screen? No? Hello? This one.
मैडम का फोन के इसमें लगा ऐसे लगा किया इसी में
Okay, great. So we can get going. So this talk is going to be on, I was asked to talk about aneurysms, but why not pick a more interesting subject. So this is aneurysms on AVM talk. Let's talk about management. So thank you for inviting me. I came all the way from Sweden here. This is the hospital I work in. It's Karolinska University Hospital in Stockholm. And what about brain AVMs and AVM-associated AVMs? So depending on who you ask and where you look in the literature, you will have different prevalence. I think we can safely say that around 10 to 20% of the AVMs will have some sort of associated aneurysm, but the true prevalence is reported in the literature to between 2 to 60%, and it mainly depends on how you define what is an aneurysm in an AVM. The natural history of aneurysms associated with AVM is also, depending on who you ask and where you look in the literature, Brown reported in 90 that the annual hemorrhage rate for an AVM with an associated aneurysm is 7% per year. That is a high number. That is to be compared to the relatively low hemorrhage rate for an AVM without an aneurysm, can be 1 to 2%. If you look at Aruba, there were 16% of the AVMs noted to have associated aneurysm, and there were no correlations with hemorrhage. Is this a reflection of the everyday work that we see? No. How to classify? There's several attempts at classifying aneurysms in relation to AVMs. One is to consider some of the AVMs. You can consider the aneurysm to be hemodynamically connected or unconnected. So, for instance, if you have a Sylvian AVM on the right side and the left medial bifurcation aneurysm, that aneurysm is to be seen and as a coincidental aneurysm. But we are interested in the hemodynamically connected aneurysms, and there are several classifications methods. There's no standardized nomenclature, and there's no, what I have found, attempt to look at venous aneurysms. So this talk is on hemodynamically connected aneurysms and also extending to venous. The situation now is that endovascular treatment of aneurysms and AVM is constantly progressing. The visualization of aneurysms and the locations in relation to the AVM is also improving. And with these new techniques and understanding, the risk-benefit scenarios in management is changing, and maybe we need to change how we manage these situations. In this talk, this is no way try to say that this is the nomenclature that we will need. This is a pragmatic scheme for this talk. This is the AVM. We have the remote arterial hemodynamically connected. We have the proximal ones and proximal in relation to the nidus, and the same for the vein. So let's start from remote. We have a ruptured remote feeder aneurysm, and the paradigm in the acute setting is to treat it as a regular bifurcation aneurysm rupture. Do not touch the AVM. The questions are how to follow up and how to treat. This is some of main surgical concepts, right? Treat the lesion and the lesion only. Remote hemodynamically connected aneurysms has equal rebleed risk, some say. This is a man, he's 60 years old, he has interhemispheric subarachnoidal bleed, previously healthy. Interestingly, we have a lesion similar to what Minjilki and René and Alberto is treating at this moment. These lesions, they give rise to aneurysms, and we can see on the pericallosal there is a quite large, ugly, ruptured aneurysm. The question is now, what do we do? Do we treat aneurysm?
Fabian,
do we treat?
Fabian, sorry. They're ready for the live telecast.
Okay.
So if you don't mind, can we go then come back
Yes,
to you?
yes.
Thank you so much.
Yeah, let's
okay,
pause
so you can switch to the live case right now. So we're moving to Vishakhapatnam, which is in the east of India, for a live case by Siba. So Siba, can you get them on screen, please?
Good morning, Rajeev. Usko band kar.
Hi, morning, Siba. We can hear you, but we can't see you. Dinara, can you help us get Siba on screen?
Good morning, Siba. We are eager to see you in action now. Azmi here.
So Siba, while we can hear you, we can't see you. Can you tell us a little bit about the case? Hello, can you hear us? Okay.
Hello, Siba.
Yeah, Adnan is going to tell us briefly about the case.
Yeah, we can see you now. Good
You
morning.
can hear me well? Andrey, can you please about the case?
We can hear you. Now we can hear you clearly in action with the patient now. Good morning.
Okay, great. Good morning.
Please give some
Andrey,
introduction
please
about the
continue,
patient.
please.
Very good evening, respected doctors and senior physicians. So my name is Dr. Arnberg. I will be introducing Dr. Dalai sir's case here. So here we have a 28-year-old male patient. So his index event was in April of 2024. So what he noticed was the patient complained of a sudden onset headache followed by loss of consciousness and two episodes of back-to-back episodes of generalized tonic-clonic seizures. Initial evaluation led to the diagnosis of a 2 millimeter ACOM aneurysm. So a wait and watch approach was taken for the patient. As we have, so the patient was in follow-up with us regularly. He complained of intermittent headaches on and off, sometimes severe, but mostly mild. At his 4th-month follow-up, we had noticed that the patient's aneurysm grew to a size of 5 millimeters. So now we have decided to intervene for the patient. Yeah.
Hello, can you hear us? Okay, Siba. So what's your strategy going to be? So you have a young man with a growing aneurysm in the ACOM, right? Can you hear us? No.
Can we see the screens and see the images? And maybe the camera should be on the other side.
Can you all flip that and get the, yes.
Yes, yes. Good.
So we have discussed about this case in your we taken opinions that how this and be treated. So there were 7 different opinions that come. Some said that we should do a flow diameters. Some said that we should do balloon assisted coiling, and some said that we should be absorbing. So we have taken the new max. Okay.
Is it possible to make the image the full screen?
Every time. One map. All right, so we have discussed about the case. There is an ACOM algorithm which we are going to treat, and we are going to do a flow diagram from the A flow diagram to the epsilon right side. And then we will do an angiogram from the lateral and see how it looks like. That will be
Yeah. What is the size of aneurysm, Siva?
Yeah. Any questions?
No, Kadir wanted to know what the size of the aneurysm is.
This is now 5 millimeter at the base, 5 into 2.75.
Okay, and
Another dimension.
we are waiting for the left ICA runs, right?
No, we have done angiogram. We are not doing it because I said that there's a big arm, and the dominant feeling is from the right side. As I said, we have discussed the cases in a group. So we are going at the treatment from the right side, and at the end of the treatment, we will go and see the left side ICA to the left side. And I have to give them separate sequence. So we put an aided first sheet. Within that, we are taking on Euro max. That's it. Within that, we're taking on cat 5. We are taking the pin of 17 with the straight rows.
Let's sit there. We can. That's easier.
We said that we didn't need a good at the first place. Just launch it about 10 back here. It's about never stop from 115 and 10 times. So I enjoyed Vigil and Professor Radial singing last night. The video posting.
Yeah, Siba, we missed you too in that. So, but there was an alternate Bon Jovi there. Okay, Siba, so the right, yeah, but the right A1 is dominant, right? And the left A1 is hypoplastic?
No, there is A1 classification.
Okay.
If you want, I can share the
Yes, that will be nice if you can share the angio images.
Let's show you. We don't let it go for that time. Stop. Left. Let's see the left carotid. So how can Rajeev audio research to this to all right. Is it okay, Rajeev?
Yes, yes, we can see that. So the aneurysm is filling from the left A1 too. Siba, is it possible to switch off, tell your team to switch off the phones? It's creating some disturbance on our reception here.
Which are all phones. Thank you.
Thank you.
So let's take up.
So you plan to flow divert from the right A2 to the right A1?
Yeah, because that is what looks like right here. What do you think?
Okay, so I think that, it's, if you can magnify that, but I think that the aneurysm is actively, is filling from the left side. I would be hesitant to flow divert only on one side. So I would like to maybe stent and coil it, but I can ask Orlando what he would like to do. Are you there? Fabian?
Hi Siba, this is Fabian from Stockholm. I think to be able to improve, we need. I think you have several microphones on in your lab, so we want Siba's microphone only. So maybe turn off the sound on some computers you have there, so we can hear Siba clearly. But so what we have is ACOM bifurcation aneurysm with filling from both A2s. We would like to see a little bit more have more information on the neck. Is it a wide neck? It looks to be a wide neck.
So that's right.
Go to the Fabian yesterday. In parallel every? Oh no, sorry, it was Vlad's case. Vlad is here?
So phenomenon of ready. Back to the phone.
Siba, there is still a lot of background noise coming from your team. So maybe it's their phone, may not be only their mics.
So I'll ask everybody to leave their phone outside.
Yeah, maybe. And leave only your mic on.
Leave all the phones outside.
So what Fabian was asking is that, can we get more information about the neck? Is the neck more, is it wide and is it more incorporated on the right A1, A2 junction? How is it?
Yes, yes. It's a wide neck aneurysm. It's a both from the right side, both from the right side. That's the reason we are trying to do it on the right. So actually, and the feeling of being so. But
Excuse me, can we see the 3D,
Yeah, sure.
please?
Have you so the presentation it's kind of slides. Have you made your presentation? Okay. Start. Okay.
So what's the plan, Siba? What's the micro you're taking up? Over what wire and what device do you intend to deploy?
I have taken a film 79 Pro. I'm going to apply a safety study.
We couldn't catch that. Can you repeat that?
Selfie studies.
Oh, you're taking SVB, okay.
Fabian, you want to show the presentation?
No, that's fine. I think we want to see if this is going to take this angle or not.
Rajeev was saying that shape micro and how you like to shape your micro in this case.
So, we got the heat gun, something we learned from Rene many years ago, and make a nice, almost like a pig, because that loses some of the shape when we do that, and lead with the micro to hook onto it and then get it through. But now I think the pre-shaped micros are coming in, so that will make life easier. But that really, this is a bad angle. I would go up front with shaping.
What about looping through the aneurysm? This has a subacute phase, looping through the aneurysm.
Right. So, if avoidable, I would try to avoid this. This is a small aneurysm, but it's a 17 micro. You could do that too, but I would shape it up front.
I agree. Shaping the microcatheter could be the best thing. Doing a very tight curve, doing the loops with the manual. Because the aneurysm is not so big to do a good loop.
Yeah, so Pero too wants to shape it really tight. Can you tell him to just all speakers? Siba, is it possible to switch off all the speakers in the room, because the translators here are unable to translate what you're saying into, they can't hear because of the static. So your speakers have to be switched off.
Speakers are off. Yes, sir. Yes, sir. We try giving a little step to the wire. That's fine. So once you can take
So that's synchro you're shaping?
yeah.
A synchro soft standard?
Putting a double angle, Siva, you are shaping with in a curved, or putting a double angle on the.
The problem that I see with the flow diverter from the right A2 to the right A1 is still the aneurysm is going to be feeling from the other side. So I don't think that this is going to be occluded with the time. I don't know. I would do something different, or put two flow diverters, or do something different.
Two flow diverters in the same session or in a staged manner? So probably this. No, I don't think so.
Yeah.
No, Fabian is showing the presentations.
There is no other angle. I mean, it's monoplane.
So the other
Towards them.
aligned with the arterial.
So Fabian, would you go in with this as your primary strategy, a single flow diverter on the right, A2 to A1?
For me, no. I don't think so. Hey.
I can show the voting that we have done. We were having, for treatment of this case, we have done a voting. It's a neuroavic concept.
Yeah. Yeah. Yeah, as Orlando stated, the aneurysm is filling from the left A1, which is very big, so a flow diversion, hard to see how it will occlude the aneurysm.
So you would like to put a Y or a single stent, something like that?
Oh, yes.
I think you can treat this with balloon and coils only, maybe with additional stenting if needed, but it depends on the patient.
But you see the angle of the aneurysm and the thing. With the balloon, the coils, will that be stable or durable? Or if they are adequately packed? Because this is probably a case where it is not an acute rupture. You want to give a one-time solution to this patient.
So I agree, this is a pyramidal shaped aneurysm. I would primarily think of a stent and coils, and he's already across that.
So one stent? So
one stent shoulder and get there.
So now we are coming to Dr. Rennie's thing. Should we push the stent? As you have told yesterday, for a braided stent, not to push the stent. So then this concept of shelving comes in question for that. Can we, suppose we are having a aneurysm, should we push the stent at the neck to form a shelf? Then to do a void? Yeah, is there.
There is no advantage in pushing the EVO because it will not make the stability higher. We have in the situation where we push like crazy, these are maybe the one where we have more recognition, but it's too rare to say. And then you lose access to the aneurysm. Here you've got access from the other side, but there is no interest in doing so. That's why just deliver it without pushing excessively, of course making sure that it opens. And here it's a difficulty because of this angulation. As soon as he will be willing to open more, he needs to push the stent, and pushing more the stent will make him protrude inside the aneurysm.
Probably when we say shelving, we want it to protrude into the aneurysm so that it gives a single stent gives some sort of a buttress support to the coil.
How is the A1, A2 junction left? So I had one the same where by pushing the stent, in fact, it bridged also the A1, A2 junction on the other side. So usually not, but you... Do you feel the aneurysm by the left side? I wouldn't mind placing, having at least a guiding on the left ICA. In case of doubt, you're starting to do something and it's not the way you want. I mean, having a guiding in the ICA is simple. Which stent is it? Okay. Does he hear us if we talk? Okay. Now we're missing the unsympathetic.
So we are at very critical junction. So how your device has opened at the bend, Siba? Can you? So it was nicely.
Is it possible to show us the unsubtracted view?
Can you give us a single shot image? A single shot.
Yeah. Oh, it's not. Yes, yes. So you plan, it's not opened really well at that junction, so you plan to deploy a little more or push, or what do you want to do?
It's opening.
You're resheathing it, right.
How long is it?
What is the length of this Siba?
This is what is
Who has put this? That was the earlier.
Sorry, what is the length of this Siba?
20 minutes.
Let's put the pole.
Like,
Siba,
yeah, which is
good morning.
very good morning.
Good luck. And small comment on the case of AVM. The angiography is the same. The patient is okay, and we finished the AVM case, and now we will continue with you. And you're already placing silk vista, yeah?
Yeah.
Okay, then we can go to the coffee break. Small comment from Alberto.
I would like also to say one words about yesterday case, the case of the cerebellar medulloblastoma. Mingil showed us the MRI that was performed just 24 hours later, the first embolization, showing that with trapping of the pica, there was no ischemia distally in the cerebellum. So this is an important point that we could also do yesterday, and the patient is doing fine, which means that even if 2 trappings has been done in both picas, there is not any ischemia.
Released? The catheter is up there.
So we have deployed the self-stabilities. It's our slide here.
This is the there is a twist.
No.
So the stent is too long, and it has not everywhere a Walter position. So the stent should be half the length.
It's not filling also.
I wonder whether there's a complete expansion of the flow diverter. It seems that it's not. In case of doubt, you may do a rotational angiogram to look at the
Yeah,
wall
there
position.
is. There is a bit of area of the step is actually falling. People are not thinking. You can see that. So might you have to do a bit of the shots. The proximal explainer what area is about proximal Pascal, or next slide. So we're trying to pick up a good side of technical.
So I would like to ask everybody here the planning. So it's a flow diverter from the right A1 to right A2, and the aneurysm is filling from the contralateral side. I would like the opinion of Molchen and everybody. Do you think that this is going to be occluding the aneurysm in the future? Would you do another technique? What do you think?
Yes, Orlando. We already discussed with Siba, and it's possible to step this treatment for 2 sessions. And at the second session, it's possible to place another FD on the contralateral side, and FD across, it's a risk of AC occlusion, which will be jailed. Yeah? And there is another options, balloon assist coiling and stenting. And stenting from one side to another side is also possible.
No, but I was suggesting that we can just put some weight from the side right now. So that gives some kind of chance for occlusion. So I would from the right side, wave 1, and some points from the left side now into the middle.
Sorry, did we understand you correctly? You're going to put some coils into the sac from the left? Is that what you say?
Yes. Yes.
Okay. Okay.
Lights on and give it a transform. So now we will just do a gentle inflation of the transform balloon into the flow diameter. Then you come back to the left side, put a couple of coils and close the case. Yes. What about? Okay.
So is it possible to have maximum zoom and do imaging, just exposed imaging of the flow diverter so we can see their position? Is it fully expanded all throughout?
It is not expanded fully. At one point, we are trying to take the volume. We will show you the mechanism.
You want to do a PTA?
Right?
Okay.
Mine. Siba, can you hear? His mic is.
Hi, Siba, can you hear us? Can you hear us? If you can hear us, you can probably raise your right hand or something, because we can't hear you. Okay, great. Okay, it's good. So your PTA is done and looking good now. So you plan to stop here? So you want to put one more FD on the left side, or as a step procedure? Okay, so Minjil called and said Siba seems to be done, so we will move for coffee now, and we will meet back after the coffee break. So thanks, Siba. Well done.
Hello, good afternoon. I think we can continue our session with lecture from Fabian. We will break for lunch at maybe 1 o'clock. After Fabian lecture, I will continue with my lecture after that, followed by Alberto and Andrew. Please put the slide on the screen.
Okay, so let's, we left this as a cliffhanger. We can go back and see what were we doing. So we had this callosal AVM with a remote feeder aneurysm that had a nasty rupture. And the question is to treat aneurysm or treat AVM or treat both. I think we all agree that the lesion should be treated and the lesion alone. So in this case, in the acute phase, we placed coils in a simple and efficient fashion. Securing the rupture, treatment of AVM in this case is contraindicated by the patient has a slightly elevated ICP, there is hydrocephalus, there is a vasospasm, there is a procoagulative state, there is stress on the collaterals. All of these are risk factors for bad outcome when treating AVM. So this is the final result from the coiling, and the question is now, do we manage this like a regular aneurysm, or do we take any special care? And if you believe some of the literature, this is the same, has the same rebleeding risk, the same recurrence risk as a regular aneurysm. I don't think that is the case. This artery has a very high flow and the stress on the reconstruction is higher than normal. So what is the recurrence risk? I would say probably higher. So let's try to not lose this patient to follow-up, have maybe a tighter follow-up. And the question is then, do we need to cure AVM to cure aneurysm? So this is the 6 months follow-up. So I don't know how you do it, but some do 1 year, some do maybe even later. In this case, you can see that already at 6 months there is a recurrence, and we are proceeding to the next question: how to treat this? Are we going to treat the lesion and the lesion alone, which now is the growing base remnant? Are we going to treat the artery, or are we going to treat the AVM? When are we going to do this? What will be the timing? Do you have a comment, Uday? Option 3 is from Uday, okay, to treat the AVM. Yeah, so this AVM is similar to what Minchilki was treating earlier today. It's maybe a little bit more, maybe a little bit simpler. It's a callosal AVM with the usual supply from both ACAs and from the posterior. And this was treated with a pressure cooker system, transarterially, 1 session. Posteriors were embolized with glue, and you can see at the end of the embolization of the AVM how the base of the aneurysm no more fills, and this is the 6 months follow-up. So the recurrence is completely healed, so there's no need to further treat the artery bearing the aneurysm. This is another case. This is a left-sided AVM and a male 40 years old, and he has a hemodynamically connected aneurysm on his ACOM. It was clipped after a subarachnoid hemorrhage in 2004. He proceeded to have an intraventricular hemorrhage in 2022 when embolization was done as a first partial treatment. And the question is now, so if we treat a hemodynamically connected ACOM with a very definitive method, with double clipping, is that a permanent solution? Okay, now he comes again. Look at the ACOM. There's another aneurysm here. and it ruptures. So now, what is the recurrence rate? Well, the aneurysm that was clipped has not recurred, but the situation for the ACOM complex is the same. It is under significant hemodynamical stress. So now the situation is like so. And of course, the final treatment for the ACOM complex, having 2 subarachnoidal bleeds from aneurysm from the ACOM to survive, that is a miracle in itself. Surviving 3 is not maybe an option. So treatment of the AVM must be done. The hemodynamically related aneurysms, if they are ruptured, treat as a regular bifurcation aneurysm rupture in the acute setting. Do not touch the AVM, and for follow-ups, recommend to have a close follow-up. Recurrence risk is likely to have significantly higher. We don't have any data on this, but this is what we see in our everyday practice. And the final treatment is curing the AVM. Here's another example. It's a male, 65 years. It's unruptured occipital AVM. If you look at the media bifurcation, there is a quite ugly aneurysm here. It's a big bifurcation aneurysm with a large daughter sac. What is the rupture risk for this AVM, or for this aneurysm, sorry? No data on that, really. Maybe 7% per year. So what is the management now? Treat aneurysm, treat AVM, treat both, and what is the timing? So what do you say now for this? What do you do, Uday? Number 1, treat aneurysm.
Treat the aneurysm and then AVM.
Treat the aneurysm and then treat the AVM. Okay. I think this is the way it is done. Most often this time the AVM is treated by complete embolization with a transarterial plus transvenous technique. You can see at the final imaging that the aneurysm starts looking a little bit different. And at 1 week's follow-up, the aneurysm is already shrunk. The daughter sac is gone. And do you believe now that the aneurysm is easier to treat than previous, and that the treatment that you do will have a better chance of lasting? I think so. So I don't have the follow-up for this patient, but let's see how the aneurysm looks when he comes back in 6 months, and we will treat him. And I'm sure that the aneurysm will be smaller and that the result of the treatment will be better. But this is I would say that, do we have any straightforward management principles here? No. Why? Because treatment of AVM is not the same as before. It's progressing. We have the risk-benefit scenarios are new. Then we have different ways of managing. Okay, so if you have unruptured remote feeder aneurysms, what is the rupture risk? We don't know, maybe 7% per year. If you have smaller aneurysms, I would say that they usually heal when the AV shunt closes. If you have large ones, like this one I showed, maybe we should consider to downstage them by treating the AVM first, because the aneurysm treatment will have a better chance to be definitive. So the paradigms are treat the lesion and the lesion only. I would say I totally agree, and this is an important way of working, but if not, it's conflicting with curing the other lesion. And remote hemodynamically connected aneurysms has equal recurrence risk as aneurysm without AVM. I'm not at all convinced about this. We need data. So the next, we move in to the more aneurysm more proximal to the feeders, to the nidus. These are non-bifurcation aneurysms, and the treatment can interfere with AVM. This is the first case. It's a straightforward case. Female, 50 years old. She has a large infra-arterial ICH. The decompression is done, and the posterior fossa is completely closed out. And so here, treat the lesion and the lesion only. And you see here that we have an AVM, and the rupture is clearly defined here, okay? So there is an aneurysm on the feeder that's not exclusive. The feeder is not essential for curing AVM at a later stage, so this is what we do. We treat the lesion and the lesion only, simple by NBCA injection. This lady unfortunately did not make it through the ICU because of extensive stress on the posterior fossa. And here we know that we did not contribute to that stress. This is important. Going for it can be sometimes tempting to treat the AVM in itself, but the ICU, having a posterior fossa under stress, having extra impact from even small infarcts, edema, can make the difference for the patient. So in this case, it's easy. So rationale here is aneurysm rupture on feeder, non-essential for curing AVM. We occlude the artery and the aneurysm, and we wait for patient recovery. And this is another question. We can also wait for AVM recovery. In some cases, we see that parts of the AVM is compressed, maybe thrombosed, and that the AVM is, if we can let time, expose the whole AVM so we can treat all of it. The patient needs to be in condition for embo cure. What is the timing for this? It depends, 6 months to 1 year. This is a similar case, but it's not the same. Treat the lesion and the other lesion a little bit. So this is also posterior fossa bleed. You can see that there is a shunt, it's a mixed malformation on the tentorium, and there is the bleeding point is a proximal feeder aneurysm on the pica. So what we do here is we coil that aneurysm, and we also put some NBCA at the end of the artery to reduce the shunting and the flow over this aneurysm. Still, at 6 months, you can see now the patient has recovered. We schedule an embo, but we can see that the aneurysm on the pica has already recurred and grown. So it's important not to leave these patients too long. This is a third scenario. It's similar, but it's not the same. So here again we have a lesion on the tentorium, a malformation fed by the pica and the SCA. The rupture point you can see easily here. It's on the SCA. It's a clearly defined aneurysm. The hematoma is around this. And the problem here now is it's on the feeder that you would use as the main treatment for the AVM. So treat the lesion, okay. So in this case, there's a sonic catheter placed with the tip close to the shunt. Here's some flow coils injected through the magic, filling also the aneurysm. And to make sure that we don't break our principles, we also put some glue inside here, so the lesion is treated. But in this case, I would say that the rationale is to treat the AVM also, which was done. Breaking the rules. Okay, so this is all rules are rules because they have exceptions, and this is a rupture on a feeder essential for the AVM embo. So apparent artery occlusion only will be only counterproductive for final cure. But still, you have to think about what is the complication risk? Is there a lot of AVM that we're not seeing because of expansive hematoma? Is the patient really in condition to take the risks that are with also small AVMs? So we hear it more and more. This is an easy AVM. I would say there are no easy AVMs. So then we move on to the nidal aneurysms. Do we have a definition for nidal aneurysms? If we have a ruptured nidal aneurysm, we can embolize them selectively, and we can give the patient a full treatment when the patient is in best condition to handle potential complications from the treatment. Sometimes it's not possible to target the nidal aneurysm. Should we then treating the whole AVM in the acute setting? Also, there are no data supporting partial treatment of nidal AVMs, but I think this is with today's tools and understanding, we can definitely see clearly where on a larger AVM a nidal aneurysm sits, how it connects, and we are definitely able with the tools to exclude them partially. So this is the paradigm. There's no data supporting partial treatment in nidal aneurysm rupture. Okay, give you some examples. Here again, we're back in the posterior fossa. We have a bleed from this aneurysm. You have a high frame rate, you have a good injection, you can see the aneurysm here inside this lesion. Okay, AVM is not big, but the patient is under severe stress, so treating this AVM could have potential complications for the treatment of the patient as a whole. So how to do it is always about exploring. With the magic 1.2 catheter, you can go virtually anywhere. And here we can see that there are two main feeders to this AVM, of which one carries this aneurysm. And it's possible to just gently put your magic where it's inside this aneurysm and obliterate it with glue. Okay. And then, of course, we need to check to see that we have not interfered with the AVM drainage. So the rationale here is aneurysm rupture on a nidal aneurysm. It is possible, of course, to selectively target them, and we can do it without conflicting with the AVM drainage, and we can do it as long as the treatment of the aneurysm does not significantly affect the long-term goal of curing the AVM. Here, use the small magic 1.25, use NBCA, maybe a high concentration to avoid excessive distal migration. And again, important things here are letting the patient recover, also to let the AVM re-expand and recover. And when to cure it? Well, it depends on the patient's condition. 6 months, 1 year, somewhere in between. This is another case. This is a female 60 years old. You can see this is a large temporo-occipital AVM with a rupture from a nidal aneurysm. You can actually see the rupture here. Can we see the pointer? Oh, it's moved. Here it is. Okay, see here? This is the angiogram showing the aneurysm is on the back end here. And at the first look, you would say, oh, this is not, we will not be able to reach this. But again, taking your catheter, searching, you suddenly you can see it. It's a very high flow, so injections with a small catheter is not good, but okay, there is a way. And of course, transnidal navigation is becoming more and more practice, and we're able to address and access this aneurysm separately. We do cone beam CT 3D to see exactly how this connects into the rest of the AVM. Here we can see the rupture. Here, it's a small pseudo-sac on this large nidal aneurysm. And for this case, use a pressure cooker technique to, this is, you can see the curve of the nidal thick artery or nidal vessel here. You can see the nidal aneurysm and the rupture. So the rupture is now completely secured. And we do a run to see that the venous drainage, there's no stasis, and we can leave the patient to come back for treatment. And again, helping us with this is to do virtual dissections with photon counting CT, with the 3D rotational angios, with CBCT. We can have transnidal navigation with the smaller catheters and tools that we have. We can even do a pressure cooker inside an AVM. And again, important aspects. Patients needs to recover, and also sometimes the AVM, to condition the patient to cure. Now, moving on to the next, to the outflow of the nidus. This is murky waters. This is not addressed in classifications that I've seen previously. These are more difficult to treat separately because of you are naturally will be in conflict with, or in potential conflict with the drainage of the AVM. There are anecdotal stories about transvenous coiling of aneurysms and maybe doing partial treatment upstream to minimize the stress on these aneurysms. But the other option is to treat the AVM in the acute phase. To be pedagogically correct, I used the same patient as before because she bled again before treatment. Now, this time the bleeding is from this huge venous aneurysm that sits just on the main collecting vein. Here is it's not only an ICH, but it's also a quite large subarachnoid hemorrhage. Question is how to manage this. There's a large venous aneurysm at the junction of the nidus and the main collector. There's an ICH and a SAH. Patient is, despite this image, she's GCS 15, 14, 15. There's no hydrocephalus. She's doing well. So what to do now? To wait, to do some kind of partial embolization, try to stage this. Looking at this, and the patient was in a good condition. There was no EVD. She was doing well. We waited for her to recover a little bit in the hospital to see that everything was stable. And then she was treated with a one-step embolization with the complete obliteration of the AVM, including all veins. You can see one large vein coming here on the back, and it's a little bit difficult to see, but the main vein, as you can see, is also occluded. And this is the post-MR. And interestingly, you can see that this large aneurysm, and this is the main collector, which is completely filled with the squid. The aneurysm is completely gone. It's completely collapsed. And the patient is doing very well, discharged, and the clinical outcome so far is very good. This is another case. It's a male 48-year-old, previously healthy. He comes in comatose with a very large hematoma with a mass effect. You can see that there are some aneurysms in play here. And this is also two large venous aneurysms at the junction of the nidus and the main collector. And there is also a rupture with a large ICH medial to the AVM that neurosurgery is not really comfortable of evacuating hematoma when there is a large AVM in between. So how to manage this? Patient has a bad GCS declining, but EVD is in place and the ICP is stable initially. So how to do this? So we can do hematoma evacuation, but necessitating also AVM resection. This is deemed to be with high risk, and it's a very, very invasive procedure, messy and difficult. So we decide to do AVM, emergent AVM embo before the patient deteriorates more, and to do a hemicraniectomy. And then you ask, do we do partial embo? Do we embo everything? Because this is what we have to do to secure the rupture. Now, this is the AVM. You can see these two aneurysms sitting on the outflow of the AVM. And this is the initial cast before before diffusing to the aneurysms. And here you can see at the end of the embolization here how the diffusion is out through the rupture into the hematoma. Okay, this is good. Rupture is secure. And the image here is a large hematoma, craniectomy is done. The AVM is secured on the lateral side of the hematoma. And there's a lot of images here. Now we have a 3-month follow-up. Patient is MRS 3 going towards 2. He walks with a cane. The CT 3 months afterwards. The skull is back. The brain looks good. So what is the rationale here? Well, there's a big rupture on a venous aneurysm at the junction of the main vein. To isolate this, to exclude this selectively is not possible. So we have to start thinking, are we able to treat the whole AVM? Because this is what needs to be done to secure the rupture. I'm not sure about that this is a strategy that is to be applied generically on all cases. I don't think so, but I think now with the situation of technique and visualization, we should be considering this because this is more minimally invasive, and we may, by doing this, expose the patient to less trauma in both the short and in the long run. But when the AVMs are large, the risk-benefit is difficult. So also, what is the risk of rebleeding if we have venous bleeds? I mean, in my center, the paradigm has been, the bleeding is from the vein, so we don't need to treat it now. Is it really true? Well, sometimes you have a bleeding from the vein downstream. Having a bleeding from a venous aneurysm sitting immediately after the nidus in high flow AVM, it's not the same. So to conclude, patients with both, with the coexisting AVM and aneurysms, I strongly believe that they have higher hemorrhage rates and higher rehemorrhage rates. The higher hemorrhage rates, there are some studies, some say 7% per year, maybe not unreasonable to think that. Aneurysms on feeder closer to AVM and nidulars, they may have higher risk. No data, but it's not, it's intuitive to think that way anyway. Maybe it's even logical. Treat the symptomatic lesion, almost always the aneurysm. If it does not conflict with a long-term curative treatment, then the risk-benefit reasoning is more complex, but should be done. And there's no data to support partial treatment in nidal aneurysm rupture. I'm not sure. This, in our experience, we are definitely doing this as an everyday practice and should be considered more. Aneurysms at the nidal vein interface, we have no address on this previously in literature. Is it difficult, dangerous to treat aneurysm separately? Yes, because if you try to treat this separately, you may compromise the vein. So consider treating both lesions. That is, treating the whole AVM. Thank you.
Questions, comments?
Beautiful cases, number one. And number two, you summarized each scenario so well. And absolutely brilliant, loved it. So I have two comments and a question. The first comment is much before the present generation, Pierre Legenius presented more than 2 or 3 cases of an aneurysm which was on the artery, feeder artery, and downstream high flow situation, either a fistula or an AVM. And he told us for the first time that by treating the AVM or the fistula, the aneurysm actually shrinks. And one of his cases, a large MC aneurysm vanished completely. So you also said, and you showed it beautifully. The second comment is about one of our cases, which we also learned the hard way. It was a ruptured ACOM aneurysm, which was pyramid in shape, not very large in height, but very large in the base, with a downstream AVM on ACS supplying. And because we could not do much with the aneurysm, we placed two Leo stents. That time it was Leo, not even babies, one inside the other, and that controlled the aneurysm beautifully. The problem was that the patient was with antiplatelets, and we did the control angio on the aneurysm 6 months later, and we didn't know what to do with the AVMs. And unfortunately, a year after that, the AVM ruptured, and the patient was on antiplatelet, and we lost him. So I think, you know, your classification of aneurysm at each site was really apt, along with the guidelines that you said. The question I have is that all the aneurysms you have, venous aneurysm, nodal, arterial, what if there is an aneurysm on the vein which is not at the interface, but it's on its course, and that aneurysm ruptures, and what are you going to do?
I mean, thank you for, when I was preparing the talk, I was going to include that too, but I realized that I was doing too many slides. But as you can see in the schematic, was to be included. And I think this is a very difficult question. I don't know, but I believe that a partial treatment of the AVM may be started, but still you have to consider how is the patient doing, because the worst thing you can do is to have a patient with an intracranial situation under severe stress. This is not a good situation to do AVM embolization. Even if we do a good embolization, we can induce edema, and we can make the situation worse. So I think from our center's experience, the distal venous bleedings, it has been quite okay to take them back after a while. But I don't think you should wait too long. Make sure that the patient is in a good condition, and when the patient is conditioned to start AVM embo, start. But treating it with coils and target it transvenously, I've seen such cases. I know one with a devastating outcome because the coiling induced a thrombosis of somehow. I don't know if the coiling did it, but the vein thrombosed and the AVM ruptured. But I don't think. What do you think, Uday?
Yeah, I mean, you already said that whenever possible, you try and cure the AVM so that that aneurysm shrinks, if not vanishes completely. Many times it's not possible because the AVM is really large and diffuse. So at least we have been going and trying to reduce the size and flow as much as we can. Because, as you rightly said, that coming in transvenous and coiling the aneurysm can be disastrous, even though it's acutely ruptured. So this is what we do, and try and do as much as we can on the AVM side and hope that that aneurysm in the interim shrinks and doesn't rupture again.
I would say if the patient is in okay condition in the acute setting, you could start with, if in a large AVM, to do some arterial side work, not compromising the venous. But as you saw, as in the Mingil's case today, that sometimes it's difficult to know when you're starting to come in conflict with the vein. So.
Fabian, fantastic talk. Thank you so much. I have one question. How is it? Is it easy? It isn't easy to pick out which venous dilatation has ruptured. It's very difficult, isn't it? So how is it that we can be sure that that is the target? You showed us a nice case. We had a similar situation a month ago, but that was a pile AVF in a young girl. But trying to find out the exact venous pouch which is given way can be very difficult, and we're really not sure if that's the target. So that's my first question to you. How do you, fix, that's one.
Yes, I think this is a very good comment, because in the nidal and the feeder aneurysm, it's often quite straightforward, and sometimes, as in the case with a nice CT angiogram, you can even see the hole and the surrounding hematoma compressing the rupture. In this case, it was the location of the ICH. You can see that it sits, there's nothing else there. So, but I agree, there is no direct evidence. In this case, it was just, there's a ICH localized, and there's nothing else there but a huge venous aneurysm and the main collector. So, but indeed, otherwise it can be hard. But but if you have do an angiogram and you cannot see, because in nidal, in aneurysm, you often see stagnation in the arterial rupture ones. So if you have no stagnation in any, but I think it's a difficult. It's difficult. Yeah, I completely agree.
Second thing, just wanted to make a comment that it was really nice to see the intranidal navigation of the magic to find the weak spot. Mm-hmm. Again, so many bubbles. What exactly is an aneurysm? What is a nidus? We don't know. It just looks like blobs there.
Yes, yes, exactly. And this is why the prevalence of aneurysm, AVM related with aneurysm is so different. I mean, it was between 10 or 60%, and what is really a nidal aneurysm? And I would say that's, we just have to, if it looks like an aneurysm, it's an aneurysm. But I completely agree, and the transnidal, I mean, today it's even possible in a lot of large AVMs, you navigate through, and sometimes you even enter the vein, and you're allowed to treat the vein from the arterial side. So yeah, but I think that importantly, because there are in literature strong recommendation that there's nothing. Even some say that avoid to treat nidal aneurysms separately, because it has no support but I think our experience in our centers says something else, that we can definitely exclude these to let the patient recover for a more safe AVM treatment further along down the road.
Any more questions or comments? Okay, thank you very much, Fabian. We now move to Kadir's lecture. So Khairul, Azmi will now present his talk.
Good afternoon, everybody. Thank you for keep listening for this meeting before we break for the lunch. Thank you, Manzil, for inviting us for this interesting meeting with all the members and also those who are online. My topic today is talking about low profile stick vista baby for intracranial aneurysm treatment. For the past quarter of century, we have seen tremendous development of aneurysm treatment. If you ask me which method treatment that we use to treat aneurysm is possible, we try to get the treatment which have a good quality, less risk, and also less complication, and have a durable effect. And the first indication for fluorodeviator developed for very large aneurysm, mainly to reduce the risk of complication, cure, and also preserve the vessel. But now we have something new with flow diverter with low profile, can be treated for the smaller vessel distal to the ICA. The most important thing when this development is this flow diverter can deliver in very small vessel, the visibility is almost clear, reachable, then we can reposition the stand as we want during the treatment. So this is the design of the Siva baby. This homogeneous surface is 48 braided wire and have grounded flare end. When, if you can see here, there's a very clear, because the DFT technology, you can see the whole segment of the stand compared to the SIG or also Leo. And this is a pusher design which have a very good control, and when you deploy, they have ability to reach it up to 90%. And this is the only flow diverter that we can deliver in the 017 coiling catheter, which is very good to navigate and also to cannulate a vessel distal to the ICA, with sometime when you use 012 or catheter that will distort the anatomy of the vessel, which can cause spasm, and also we cannot get the proper landing zone after the change of the our roadmap images or smart mass images. So you see, this is the property that I like. This is the only flow diverter that can deliver to microcatheter. You can reshift. You can see the whole delivery system repositioning is very easy in this kind of the technology. And if we have properly choose the indication and also patient is in proper anticoagulation, in my center we like to use ticagrelor and aspirin because in our population there's increased resistance of pelvic. Another thing, when we are using this flow diverter for low profile, usually we dealing vessel which is small, 2 mm beyond the ICA, that we need to have a good this indication and also good antiplatelet therapy to prevent complication. So again, when we want to treat the aneurysm, we must consider the other option like coiling stenting. When we decide before the treatment, it's better to get the pre-diagnostic different from the treatment per se. So you have an idea what is diameter you want to use, what is the landing zone, what is other material that you want to consider this treatment. Maybe you need to put coil or additional stent. And the most important thing in the positioning of this flow diverter sleep with baby is about the landing zone. We cannot get the too long or too short. Too long will interfere with the opening maybe, and also too short they can have fist mounting. So it's better you have the separate session for the treatment, because most of the time this aneurysm is pre-planned treatment for unruptured. Even for ruptured small aneurysm, we can always stage the treatment by put certain coil and can be back the patient after the acute phase, so that we will reduce its overall spasm and also to put patient on dual antiplatelet. So in these cases that I will show you, I want to prove that this stick with a baby can be used in any segment of the vessel beyond the ICA. For the first two cases, I will show you how it used in bacillar and also PCA. For example, this is 40 years old man presented with a headache, and it's noted they have this headache with visual disturbance. Initially, this patient seen the ophthalmologist, and when they request MRI, they shows actually is acute, subacute hematoma at the right posterior region. And if you can see from MRI here, there is a dissecting aneurysm at this distal P2 segment. So when we perform the angiogram, you can see this is aneurysm. The important thing in this case is to preserve the vessel. If you want to put coil, it's quite difficult because the aneurysm neck is quite complex. That's our plan to put this Vista baby to the larger branch. And this is the measurement for the aneurysm in terms of the distal landing zone, aneurysm size. As we mentioned here, that the vessel is quite small, 1.2 mm. If we use larger flow diverter or other system, they can interfere with distortion images, and also you can induce vasospasm, and you may not get the good images. But you see here, with this low profile, it doesn't really change the configuration of this vessel, and we can see clearly and deliver the stent very nice in this image projection. This very you can see this is a segment of the stent in the distal tip, and it's very easy to deploy because it's more like to unsheath and less pushing. And of course, we know when we are dealing with the smaller vessel, we are dealing with the small aneurysm, not like complex aneurysm at the ICA. You have to very wide neck, very tortuous vessel, and this aneurysm beyond ICA, usually they are very small, and the neck is less complex and easy to deliver. So this is what we call point of no return. Very nice accommodate. You can see clearly on the fluoro image. And of course, they have very good flow diversity effect with stasis order contrast, with preservation of distal vessel. And after 6 months, the aneurysm is excluded from the system. That shows that the important to get the very low profile flow diverter to treat this complex aneurysm. This another case is 22 years old man who had a ruptured dissecting mid-basilar aneurysm. He's treated in other hospital first. I think they use maybe thread here, but I think the distal landing zone too short, then they become fish mounting. And as you know, distal thread, they don't have they have space here. Then you can note that the aneurysm is this is how, when you have very short landing zone, you can have the fish mounting. And this is the configuration of the thread. Distal is no flow diverter. And when we repeat angiogram again, they see that this is their angiogram. So there's already have prolapse into the aneurysm. So when again patient referred to us when they have re-ruptured, the aneurysm is enlarging, and if you noted here, the thread already in this aneurysm. So the strategy of this treatment, we decided to put coil into the sac, and the next is telescoping the distal part of this aneurysm with baby. So again, this is very easy to use, very soft, and opens spontaneously, and they have a very good flow diverter effect. And this is follow-up MRI, so the vessel pattern and the aneurysm getting smaller. Another case is a gentleman who had history of stroke, and also noted in MRI have distal pericallosal aneurysm. Distal pericallosal aneurysm. The distal diameter of vessel is quite small, it's 1.62. After discussing the patient, we think we need to treat the patient because the patient has history of uncontrolled hypertension and also have evidence of stroke in the MRI. We deploy the sick baby. Again, it's not very difficult, and because of these low profile properties, it doesn't really change the angioarchitecture and anatomy of the aneurysm, and the vessel is open. Of course, we need to, in this case, the colossal marginal vigil. This is after post-deployment. But this patient, I think after 3 months, he decided by himself to stop the ticagrelor. What was happened? They suddenly presented the weakness, and the CT scan shows there is no flow at this distal part of the stent, and the repeat shows a restricted diffusion. Because this is, I think, more than 24 hours, we bring back patient to our angiogram, and we noted that's a filling defect in the stent. Even though you can see that the aneurysm already at this point is remodeled, we decided not to do anything intervention to remove the clot because the vessel is very distal, and also this beyond the therapeutic time. We recontinue back the patient with dual antiplatelet with ticagrelor. You can see this maybe a clot inside, and the aneurysm already remodeled after 3 months. See this maybe heart clot. The stent is patterned. We restart back, and after another 6 months, we repeat, aneurysm is disappear. Even though that's the callosum marginal filling very late, but they still remain patterned and patient is asymptomatic. So this is repeat angio after 6 months. Another case, this is ECOM aneurysm. If we do treatment of aneurysm, the risk of recurrence by coiling maybe 10 or 15%. And like in this case, after 6 months, we can see the recurrence of the aneurysm. In this case, we decided to use a flow diverter. We put one coil at the neck and deliver 6 crystal baby. And this is follow-up after 6 months. The aneurysm is again excluded to the system, and the patient, if we off the dual antiplatelet and continue aspirin for life. This lady, he had large aneurysm, dissecting aneurysm at the left A1, compressing the optic chiasm. This is a large aneurysm, dissecting aneurysm. We deploy again the 6 Vista baby. In 6 month follow-up, the aneurysm is excluded from the system, that's secure. This is another case. This gentleman presented with acute hemorrhage and very large MCA bifurcation aneurysm. When they refer to us, this very large aneurysm. And also you can see this superior branch also incorporated small vessel at the aneurysm neck. After thinking and also this treatment strategy for this patient, we deploy one large coil and flow divert into the larger inferior trunk, slightly longer here. And this is after 6 month follow-up. The aneurysm is cured and this vessel also preserved. But sometimes we have other difficulty also. For like example, this is bilobe basellative aneurysm. That is, the vessel is very small, less than 1 mm. We try to put coil, also quite difficult. Stat assisted, I think quite tough, not flow diverter. But we just decided to put a babylio, and you can see in this case, even though we just have this babylio, because this already changed the direction of the aneurysm geometry after 6 months, and this aneurysm also occurred. So this is not very good for the industry because Leo is slightly cheaper for the aneurysm. For on all the discussion that I will show, that the system with baby is effective treatment for aneurysm beyond the ICA, but most importantly, when you decide to use the baby, we have to think other option for the treatment aneurysm, and the most important also, the use of dual antiplatelet have to be very strict and choose appropriately to prevent and to reduce the risk complication. So this is, I think, this ideal flow diverter, even though we know that they have like sideband occlusion. Majority is asymptomatic. And this baby have these features to show that it's a very good device for aneurysm treatment. And if you have tried the sector baby, you won't use the other product because it's very easy to use and very gentle to the vessel. That's why I like it so much. And I can always reposition the device if I want to. Thank you very much for your attention.
Thank you. Nice talk.
Yes.
Any questions or comments? If there are none,
Yes.
thank you, Khairul. We now move for lunch.
Yes, thank you.
And we reconvene for Andrey's talk after lunch. Good afternoon, everyone. We are back after lunch, so may I request Vitaly to give his talk.
Все. Так, это работает, да? Ага. Окей. Okay. Hello to everyone. First of all, I want to say that I don't know the answer for this question. It's truth, and I think that nobody knows the answer for this question. Let me show my small presentation. Maybe somebody then can tell me what to do. Oops. Работает? Нет? Тогда так. Okay, my disclosure. So, the development of neuroimages method, here the wider application in the clinical practice had led to increase the detection of unruptured aneurysm. So today we have a lot of unruptured aneurysm because we have a lot of imaging machine. So the diagnosis of intracranial aneurysm is a source of significant stress for the patient because the mortality is 30% and the risk of disability is 50%. So today we need to understand which unruptured aneurysm we need to treat. So when we have a very small unruptured aneurysm, we need to understand three big points. First of all, risk of growth of this aneurysm. So the second one is risk of rupture and risk of surgical intervention. Risk of surgical intervention, of course, depends from the experience of physician. And I don't know how can I calculate this risk correctly, because in different clinics, in different departments, it will be different. So, risk of rupture. The big trial, which we can find in literature, in Lancet journal published in 2003, is ISA, unruptured intracranial aneurysm. So, the main results of this article is that aneurysm less than 7 millimeters, we don't need to treat because the risk of rupture is 0.18%. So big, very huge, serious. 2,686 aneurysm. So this is, we can see that risk of bleeding of very small aneurysm less than 7 millimeters is very low. So, but we can find in journals another publication, this publication of meta-analysis, not meta-analysis, this is a single institution study, 25 years experience. So what we can find here, that 41% of patients had aneurysm less than 5 millimeters. And if you are looking to the this graphic, sorry, you may see that year to year the amount of small aneurysm grows. So today the amount of aneurysm in this in a lot of studies are more than 50%. So if you are looking to this table, we can see that aneurysm less than 5 millimeters in most serious, which we can find in literature, is approximately 15%. It's a very huge amount. So risk of growth, another publication which we can find in literature, that rate of growth of aneurysm less than 3 millimeters, approximately from 5 till 12%. So, and we need to plus it with aneurysm less than 5 millimeters. So this is plus 5%. It's very high, high percent of growth. So treatment. We have some options to treat patients. First of all is conservative therapy. So we don't want to operate this patient, and we need to look for the age, physical activity, hypertension, smoking, drinking. So, and that's why we choose how we will continue our treatment with this patient. If we don't want to treat, to operate this patient, so we need to do MRI control 1 time per year to control regrowth of aneurysm. So another option is microsurgical clipping. A few meta-analyses show that mortality approximately from 1 till 3%, and so morbidity rate is from 4 till 17.5%. If we look into another publication where we compare microsurgical clipping with endovascular coiling, so we can see that mortality rate is higher when we clip aneurysm than coil. And this is, we can find the answer here in these publications. So endovascular treatment, we have 3 main options to treat very small aneurysm. This is coils with any assistant techniques, and cell flow diverter stents. There are a lot of publications in literature which show that most of physicians are still operate very small aneurysm. Despite the ISA showed to us that we don't need to treat them. This is a meta-analysis which I found in literature. So the result of this meta-analysis, when we use coils, the technical success was in 92%, complete occlusion rate was 85%, follow-up showed that occlusion rate is 91%, recanalization 6%, and reoperation 7%. If we compare it with aneurysm more than 3, 5, 7 millimeters, I think we can find the same results in literature. So no difference between small aneurysm and higher aneurysm, so there's the same results. Complications. Good clinical results was in 82%. Follow-up shows 79%. Complications was in 7% of cases. Thromboembolic 4%, and intraoperative rupture is 9%. Mortality 3, morbidity 2. I think this is not bad result, and I think that they are the same if we take the group with the patients with the higher size of aneurysms. So, but well, here we can see that intraoperative rupture is 9%. I think as a problem of very small aneurysm during the treatment that we have the high rate of intraoperative rupture. So when we can use coils? Of course, we can use coils in the good geometry of aneurysm where I have a ratio between dome and neck 3:1. So in that cases we can use coils. When we use stent assisted coiling where we have not good geometry of aneurysm, so but looking this is data from this meta-analysis. So the immediate complete occlusion rate is 70%, but after 6 months we can see that occlusion rate is 93%. It's very good for my opinion. Intraoperative rupture 6%, and here in this group we can see that thromboembolic complication is 13%. Of course, because we use stents, it's normal, I think. Recanalization rate is higher than when we use coils, is 14%, but look, the reoperation, only 3%. We have 14% of recanalization and only 3% of patients needed to be retreated. So it's too low. If we compare unruptured and ruptured aneurysm, so we can see that results look the same. In ruptured case, we have more higher recanalization. So I understand, because most of physicians afraid to completely occlude aneurysm during the acute stage. So they prefer sometimes to put less coils that we need, because they're afraid the rupture during the procedure, and this patient can be retreated in the cold period with using any assistant technique. So that's, I understand why recanalization rate is higher. But all other results look the same. So this is example, stent assistant coiling. This is aneurysm of junction of vertebral artery. So we put coils with stent assistant, good angiography results. This is another example. Of course, the higher aneurysm we needed to treat, but the smaller one, we used the same technique. We put 2 stents in telescopic stenting and put coils, and you see that we can see the black point. I think, for my opinion, all aneurysm must be occluded with the same method when we see the black point of coils. So another case, this is small aneurysm of SCA. Initially, we didn't want to treat this aneurysm, so we observed this patient. And after 2 years, the aneurysm started regrowth. So, and we treated this patient with SCA aneurysm. So we used a transcircular approach. In this case, first we see the carotid artery and vertebral artery. So we see the very good posterior communicants artery. So we catheterized from the carotid artery SCA and put the stent from SCA to PCA before the place of posterior communicants artery arising. So, and from another side we put the microcatheter into aneurysm. So we put 1 coil with stent assistant and good clinical result with any technical problems. So here in this publication, this is new publication 2023, so we can find the rate of intra-procedural complication, and we can see that the main problem during the operation for aneurysms less than 3 millimeters is rupture. So thromboembolism, I think that is the common complication for all neurovascular procedures. It depends from many factors, but rupture, I think this is the main problem for this small aneurysm. So in this case, balloon assistant technique can help us, because it helps to control the bleeding in the case of aneurysm rupture, ensuring stability of microcatheter in aneurysm and parent vessel, a tighter packing of aneurysm with coils. So this is example small aneurysm of basilar tip, and during the implantation of coils, we can see the rupture of aneurysm with the extravasation in this case. And of course, we inflated the balloon, continued embolization without any problems, and after procedure on CT, we can see that we have very minor bleeding. This is a very good clinical result for patient. Another example, aneurysm of ophthalmic segment, balloon assistant technique, put a few coils, so with good angiography results. The small aneurysm of ICA with balloon assistant technique, we see that aneurysm too small and the marker of microcatheter is higher than the size of aneurysm. So, and put coils with balloon assistant technique with a good angiography and clinical result. Another option which we have, this is flow diverter stents. So the small aneurysm, so put flow diverter stents. It's very easy to put stent in the straight artery. So if we are looking to literature when we have in complete occlusion after flow diverter stent, we can find the three main causes. First one is the time period, because nobody today told when we must to do control angiograms. After 6 months, 12, 18, when we think that we have a complete result. So, and if you are looking at rate, complete occlusion rate, is grows time to time. So when we have the size more than 10 millimeters, and when we have the aneurysm with incorporated vessel. So this is three main causes which can lead to incomplete occlusion after flow diverter stents. So this is small aneurysm of pericallosal artery. So and we have incorporated branch. So I saw a few cases when we used flow diverter stent, such cases. So, but I prefer, when I have incorporated branch, I prefer to use coils with a flow diverter stents. For example, this is too high length of flow diverter stent because I had no shorter stent that I need in this case, and put few coils. And in this result, I think that, and I don't see the reduced flow in incorporated branch. So I think here is a very, very good result. This is our time for implantation of flow diverter stent. So the time usually from 40 to 60 minutes to implantation. It's very easy. It's very easy procedure. So, and in conclusion, I want to say that should miliary and small aneurysm be operated on, so far no study has been able to answer this question. In addition, it's necessary to define what we consider small aneurysm. It is my opinion. We don't operate on a ruptured aneurysm less than 3 millimeters because, of course, it's so difficult to put some coils or put stents. We may have a lot of complication in this. We operate an aneurysm over 3 millimeters, both openly and endovascular. It depends who operate this patient. Aneurysm with a history of rupture are operated regardless of their size. So if we have a rupture of aneurysm less than 3 millimeters or 3 millimeters, so we will operate this patient. The use of isolated coils in the treatment of small aneurysm has significant limitation in their use. In most cases, due to the unfavorable geometry, we require and the use assistant techniques. Balloon and stent assistant allows expanding the possibility of endovascular treatment of small aneurysm. The use of flow diverter stent in the treatment of small aneurysm of ICA is highly effective technique, while the use of bifurcation is a debatable topic. It's necessary to take into account the inexperience of surgeon when performing interventional on aneurysm, especially on small ones. Thank you for your attention.
Thank you for a great talk. So, if I understand correctly, the measure of 3 millimeters is chosen because, and why not 4?
Why not 4?
Yeah.
Because I can put coils in 3 millimeters. Aneurysm, this is enough for me to put coils. When I start to put it inside, if I have aneurysm size less than 3 millimeters, usually they fall from aneurysm, and I need a different assistant technique. So if I have aneurysm 3 or more millimeters, so I can put coils. So I can use some techniques with 1 catheter, 2 catheter. So, but I can make I can put coils inside this aneurysm sac. So that's why.
Yeah, I completely agree. I mean, when you go into the game of or the medicine of treating aneurysms, you have the notion that the difficult are the big ones, and this is what you think about.
Yeah.
But in real practice, over the years, you realize that sometimes what you struggle most with are the small ones, and they are frequent, no? So more than half of your aneurysms that you treat are maybe really small. Any questions from the audience or comments? I think it's a very important topic, because if you look at the data and the frequency of rupture, I mean, half or a third are smaller than 5. So
yes. And question, in your clinic, how frequent do you see the aneurysm less than 5 millimeters when they rupture?
well,
How
that's-
frequent?
Yeah, it's very frequent.
Very frequent.
Yes, yes. I think there are retrospective cohort studies. I think one from Hopkins. I think they had almost half was more than 5 or 7. So
Because in my clinic today we have approximately 40% of ruptured aneurysm smaller than 5 millimeters.
yes,
So
and this is indeed a very. When you look at it, I think many junior interventionists, they don't maybe appreciate how difficult it is to treat when it's ruptured. I mean, perforation, when you do balloon assist, perforation of the coil is maybe mandatory in some situations, and I have a very big respect for ruptured small aneurysms.
I think I agree with you. My experience, I saw a lot of small aneurysm ruptures, even 3 millimeters rupture. So I think it has to be dealt case by case. If you see a young patient with a small aneurysm, and even if the patient wants, sometimes patient says, I don't want you to touch my aneurysm, and some patients, they cannot live knowing that they have an aneurysm. So you have to deal case by case.
Yeah.
And morphology of the aneurysm also is important. If you have a very regular aneurysm in the location that it's not very frequent to rupture, I think you can leave it. But some in ACOM, young patient, irregular aneurysm, 3 millimeter, I think you have to treat it.
Yes, indeed, I completely agree. But I think the community, because my feeling is that sometimes in discussions we are discussing small aneurysms, ruptured and unruptured, the same regarding technique. I would say it's very, very far from the same. I mean, Jilke, you have a great experience.
I think it's a question for the future, yes?
Yes.
If there is a new generation of stents with no need of dual antiplatelet therapy, I think all these recommendations will be sent to the past, and the only question how much stent and how it's safe to place, and if it will become safer to place, and then the question will be unreasonable.
I think the device is just one point of this treatment, because for my opinion, the first position of treatment of any aneurysm, so this is experience of surgeon. If you are looking to the literature, you can find that the same situation, the same aneurysm, same localization, same size, but in one center, they have a complication rate 15%, in another 2%. What's going on? What's happened? So this is only experience. I don't know. This is a big problem of meta-analysis and publication. So I don't know these guys who operated this patient. I don't know their experience. And I don't know, can I believe them? So if, for example, the most publications of treatment of AVM, which we can find in literature, tell us that complete occlusion rate is less than 30%, right? Yesterday, we saw a great presentation of Artura where the complete occlusion rate was 92%. So what I need to tell to the lector? So you don't need to operate because meta-analysis showed that the rate is less 30%. So stop operate because look to the literature, look to what to do in another clinic. So he showed me, okay, I have an excellent result, 92% complete occlusion. I will continue to treat this patient. So, and I don't know how to separate the articles, and I don't know how to separate this meta-analysis to find the truth. What is a real complication rate, which depends from the geometry of aneurysm, of size, localization, shape, vessels, and others. So I don't know how to do, how to separate it. Maybe I'm incorrect, but this is my opinion.
Yes, the key point is experience. And even the experience, there is a human factor, and the patient forgot to take medication, and it's another disaster, and it's a life. Eh? And one notice from our practice, the aneurysm less than 4 millimeter, if you place the flow diverter, it's 100% occlusion in follow-up in 6 months and 1 year. It's not a 10 millimeter aneurysm, 15 millimeter, yes, which need a second stent or something in addition.
But you may have some problems with the blood problems. Patient. Some patients have resistance to double antiplatal therapy, so you may have occlusion stent after the stop of double antiplate therapy. So we saw a lot of cases, different cases. It's very simple to put the flow diverter stent inside the ICA, but we don't know what's going on with patient. Maybe patient stopped the take the drugs, so, or maybe something happened with the stent, or stenosis inside stent will be, I don't know what will be this patient.
Hi, congratulations for your presentation. I think we live in a schizophrenic moment. So we have the only one good study that was at Isuria, yes, done 20 years ago that said that small aneurysm in anterior circulation less than 7 millimeters should not be treated probably. Yeah. And we work with new devices. We work with probably less complications, or less complication in big centers and not in every center. And we are doing whatever we want. We do what we want at the end, because so you said something about that. The problem is that we should accept something over us that control and certify that our job is good. Mm-hmm. We have to. It's very difficult in this moment because everyone does whatever 3 millimeters, 4 millimeters, 6 millimeters, 7 millimeters, which is the right. We should have been controlled probably by someone else that does. And we work with new devices. New techniques are easier. Intrasaccular devices are easier. The RTS is a great device, much easier than the web. Mm-hmm. So we don't know how it will work in years, because it came out in 1 year. So it's very difficult in this moment. But probably we need someone that controls every center and says, you have this complication rate. We should even to do a new study trying to understand which is the natural history of the aneurysm, depending on the location of the site, because anterior and posterior is not it's not enough, because a pericallosal aneurysm is different than a common aneurysm and then an ophthalmic, carotid ophthalmic aneurysm. So we should stop, we should review our job and not just meta-analysis done by people that want to treat aneurysm, because most of us want to treat aneurysm, me too. Thank you.
Vitaly, there is a clear message from the industry.
Yeah.
The web device and the others was designed for the unruptured aneurysms.
Yeah.
And it's available 2 millimeter and 3 millimeter web.
Yeah.
It's a clear message as the industry knows 2 millimeter is treatable and you should treat if it's unruptured.
Yeah.
Thank you and congratulations. What I want to say is that this is just the beginning. Your talk,
yeah,
maybe not now, but in future to come,
yes,
is just the beginning of a much larger picture. Like he talked about companies wanting us to treat small unruptured aneurysms. Eventually it will lead to something, maybe in a decade's time or maybe longer than that, is screening of populations for aneurysms.
Yeah.
And eventually, I'm sure that if not now, in a decade or later, we will be in a position to do this endovascularly without having the need for antiplatelet, local anesthesia, and the patient can come, unruptured aneurysms of course, can come, get treated, and get discharged from the hospital in a day. So this is just the beginning, I'm sure. And if you stop now that unruptured I'm not going to treat, then we are not going to build any experience.
Yes. Yes. I completely agree with you. Thank you.
Vitaly, good talk, thank you. You know, in India at least, a lot of us see aneurysms which are ruptured, like you said, 50% cohort, etc. Yeah. We see probably much more than that who are in that sub 5 millimeter, 6 millimeter range who have ruptured, right?
Yes, right.
So we all do. So this subset of ruptured versus unruptured is one clear distinction, like you brought out. Mm-hmm. The issue is that now with improving hardware and imaging, it's becoming easier to treat technically.
Yeah.
It's also becoming easier to understand the morphology of the wall, which I think should be taken into account while deciding whether to treat this or not. Because that's something, this high-end imaging is something we should use to make that decision. But everyone said the rest. But it's a very important topic.
Yes,
so
yes,
congratulations.
Yes, I agree. Thank you. Sure.
Thank you for your presentation. I'd like to ask a question about physics or geometry of aneurysm. Do you have your own opinion about more complex aneurysm, more predictor for aneurysm rupture? For example, more complex, more geometry, complex geometry, is it a predictor for rupture in future? Even if it's small, doesn't matter the size.
If you have a bulb on aneurysm, so this is the prognostic factor for rupture of aneurysm. So if we can see it on aneurysms, so this is the one point. The second one, I looked to some publications which wanted to prognose the rupture of aneurysm. So they looked to localization, size, geometry of bifurcation. So, but as I know today, nobody found the answer for this question: which aneurysm can rupture, which cannot. So, but if you have a bubble on the aneurysm, so I think this aneurysm must be treated as soon as possible. Other one, for opinion of surgeon or team, so who wants?
You know, it may be a joke, but some friends, we made a classification called the ugly classification. The uglier the aneurysm looks, so we call it ugly 1, 2, 3. And the uglier it looked, we found that the indication for treatment was much higher, and nobody discusses it. Like you said, they talk about the location, they talk about the size, they talk about bifurcation, sidewall, but no one talks about the ugliness. I don't know how to put it scientifically, but
we have a scale phases. Yes, right. Phases. Yes, it's a scale when you can give some points to a patient, and calculate the risk of rupture of aneurysm. Under the scale, you can choose the treatment, treat or not treat. So, for example, have another scale, so you may find it in literature, so you may calculate. It depends from some races, for Finnish or Japanese race, or other European, and size, localization, rupture in anamnesis. So, a lot of factors which we need to calculate. So, but I don't know correct answer which aneurysm can rupture soon and which aneurysm I need to treat. So I don't know correct answer. A lot of publication of flow inside the aneurysm sac we can find from our US colleagues. So they do a lot of work in this way, but I think that they can prognose.
Yeah, I think the one thing that we have data on now is dynamic growing aneurysm. There was a big study in JAMA a couple of years ago, but still it takes an extremely low risk of rupture to somewhat higher.
But it's very difficult to integrate it in clinical practice because most of departments have no modern machines, so CT, some options or programs inside this machine. So to prognose, it's too difficult because, for example, in our country, only maybe in few centers we can do the prognostic CT scans. So, but in other they can do it. So we can publish it. We can tell that you need. How? Where? Where can I? It's the second problem of.
Yeah, and in our center we have access to advanced imaging, and we have been doing vessel wall imaging for aneurysms now for a long time. I think it was promising in the beginning, but unfortunately we're not seeing any clinical help from that modality, unfortunately. So, yes, super talk and great questions and discussion.
We'll have Roger's presentation now.
Hello,
Roger.
good afternoon.
Yeah.
Hello?
Hello, hello. Do we have
Hello, can you hear me? Can you hear and see me?
We can hear you. Now
Okay.
we can see you also. Welcome.
Okay, that's better then. And about from myself, the presentation, you're seeing it? Which is the best probably, better than myself.
Yeah, now we can see your presentation.
Okay, good. So I will start. I don't know what's in the program, but we discussed with Minzir to talk about intracranial arterial disease. So I'm Dr. Roger Barranco. First of all, I'm really sorry to not having been able to come to Astana and enjoy all the hospitality here. But yeah, I'll do this talk online. I am originally from Spain, from Barcelona, but I moved work to United Arab Emirates almost 3 years ago. While in Spain, and probably this is very common in Europe, in Western world, so I remember that the typical stroke patient normally are elderly patients, most of them, some of them have atrial fibrillation, and we are dealing with thromboembolic disease, meaning that most of the cases combining aspiration, stent trigger, balloon guiding catheters, we will be successful with thrombectomy. The challenge for an interventional point of view, especially with elderly patients, might be the difficult access and tortuosity of the vessels, and the ICAT, it's still just a few percentage of these patients. And many, at least what we did in Barcelona, I recall that 50% of the patients, more or less, had previous TPA. While in the United Arab Emirates, my experience, the cases I will show you are cases from the northern Arab Emirates and also from Al Ain, which is in the eastern part. So in this part of the world, we are not dealing just with Arab population. We are dealing for population for all the world. So the surprise that most of the cases we are having for strokes and ICATs, there are some Arabs, but we have a lot of people, of patients coming from living in UAE, United Arab Emirates, from Pakistan, Afghanistan, Sri Lanka, Bangladesh, Philippines, and also from different parts of Africa. So this kind of population, the strokes we are having are very young. Most of them are male. Many of them have diabetes with very poor control, and also some of them smoke. And the technical challenge is that it's not the tortuosity. These are young patients. But the technical interventional challenge we are encountering is ICAT. And here, meaning that the technicals we will use is angioplasty, stenting, and the use of antiplatelets. And this is about 30% of the cases, but I still don't have the exact number for this at this country. So before I moved to UAE, Barcelona, it was clear to me we are doing stroke thrombectomy. But after just working a few years in this part of the world, I tend to think more about we are doing stroke revascularization. We are not doing just for thrombus, because in many cases, we have to have in our mind that we find intracranial stenosis. So about the knowledge and data of intracranial stenosis, if we compare to thrombectomy, it's much more poor. It's difficult to have a clear guidelines, and many operators and many of us may have different ideas. So what I will do, I will go through different questions. I try to answer at least from my personal point of view, which of course can be mistaken. Regarding which antiplatelets to use, we started, there's a problem with the presentation. In case that happens, I have a backup computer. Okay, hold here, sorry for this. I have another computer, I can share the screen. Give me 1 second.
Roger, we cannot hear you. Is he lecturing now? It looks like. Can we communicate with him in some way? Roger, can you hear us? We cannot hear you. Connecting from Kazakhstan to Spain. You have good slides, so it helps now, but I think we need your voice. So we're not able to get in contact with Roger. At least he's taking his time exercising on his presentation. It will be great. Has anyone tried? Yeah, I think we have him on neuroaddicts. Maybe I can call him. You call? He's busy because he's having a presentation. Okay, so should we continue? And he will rehearse now, and he will. So the next will be Rajeev. Andrey. Okay. And let's see, which one is that? So we can have Andrey Petrov on stage, maybe. So welcome.
Dear colleagues, I will try to add some noise. Once again, thank you very much for having a good chance, the opportunity to share with you all good friends, of our experience with benign tumors embolization, and the topic for today, endovascular embolization of paragangliomas. This is a very, very rare kind of tumors, and the third of paragangliomas at all. This is a head and neck localization. The aim of our presentation, our work, was assess the prospects and advantages of endovascular embolization of highly vascularized tumors like paragangliomas with non-adhesive embolic materials. For last 9 years, we operated 26 patients, 6 male. Yes, majority of them was female. 51 operations were performed in average 2 stages, but more than half was embolized in 1 stage. Which tools we used? Scepter balloon, DMSO compatible balloon at all. This was the normal tool for embolization of paragangliomas. We used, in some cases, René-Chapot Copernic balloon. This is a very unusual tool for this point, but this was idea to protect ICA, and I will show you the cases when we use it. And Apollo or Sonic, this was catheters for embolization, paragangliomas via leptomeningeal anastomosis. Analyzing literature, analyzing articles, we can see that there is the only one points what to do with paragangliomas. In one cases, a lot of articles describe that pre-embolization, this is the best way for paragangliomas treatment before resection. In some articles, we can see that embolization of skull-based paragangliomas is a very good opinion, combination of transvenous or transarterial approach, but finally this is no only one rule what to do with them endovascularly or generally. Talking about classification, the same thing, because of some authors fixed on the cervical localization, and they created types of described subtypes of paragangliomas. Some classification divide, this is for several group with neck localization, jugular foramen or beyond jugular foramen paragangliomas. Also tumor localized in middle ear also divided for some groups, and for us was also very important class D, group D with intracranial expansion. Because of this, paragangliomas are very extremely difficult to treat. We divided our cohort of patients for 4 groups: carotid body or carotid paragangliomas, jugular paragangliomas, tympanical, and tympanical with intracranial expansion. Carotid body, carotid type, very adequate for endovascular embolization, and 2 key points what we got for this embolization: using a DMSO compatible balloon via pharyngeal ascendal artery, and we use Copernic balloon, René Chapeau Copernic balloon, for prevent expansion non-adhesive embolic material via anastomosis with vas vasorum of internal carotid artery and carotid communis. Here you can see the first stage, inflate the balloon, and after that you can rapidly enough inject in the non-adhesive embolic material via the DMSO compatible balloon up till total filling of the paraganglioma. And what is more important, you can see here at the borderline of the black and white area filled the small arteries which have been connected via vas vasorum of ICA with the paraganglioma. The same technique, the same strategy will be useful in cases like this, when you see very big paraganglioma, which will be very difficult target for the open surgery removal. Pre-embolization also will not organize to you totally dry resection or removal, and here ICA protection with the René Chapeau Copernic balloon and DMSO compatible balloon via pharyngeal ascending artery will give you very adequate conditions. What is important also to analyze by using bifemoral or alternative radial approach to control anastomosis with vertebrobasilar artery. And here also with a rapidly injection, using all the connections inside the paraganglioma, you can totally cover all the vascular space inside the paraganglioma. Jugular tympanical localization. This means that you need to control all this area of dangerous anastomosis. You can see here angio when you start injecting the contrast via pharyngeal ascendal artery, and in the middle all the vessels are connecting in the very huge network, and if you will not control injecting the non-adhesive embolic material, you will finally lost almost all the vessels connected with this area, because of you can see here right vertebral artery, left ICA and MCA, and if you will continue the injection, we will also see left vertebral artery and right ICA and MCA. So, bifemoral approach, control vertebral artery by angio and ICA and external carotid artery, and here also very wise to use René Chapeau Copernic balloon, because of thus you will protect some connections with ICA. Paraganglioma of the middle ear, tympanic paragangliomas, very rare and very difficult tumors, because of this is no adequate vessels, because of a lot of branches which will be connected with useful arteries, and here is better stop earlier, not to cover all the vessels which can be reachable to the non-adhesive material. Finally, if you will perform wise embolization, you will rather to close the paraganglioma tissue and save all the necessary vessels and branches. Tympanical paraganglioma with the intracranial expansion. So this is maximally difficult. This is a maximally dangerous target because of here. There is no direct protocols. Neurosurgeons really didn't like to do something with that because of this is a very hypervascularization tumor. And here you can use stage type of embolization like we are performing in AVM embolization, analyzing all the previous vessels, all the previous stages will be started from one to the next and to the finishing. And here you can see stage by stage. On CT you can see how we expand our non-adhesive embolic material right inside the tissue paraganglioma, and also it's better not to inflate or not to overfill with non-adhesive embolic material para-brainstem part of paraganglioma because of this is the DMSO which are not neutral to the brainstem at all. So one more stage and one more, and finally we got 70% of embolization and not worsening of the station of the patient. So next fourth stage or radial surgery we can decide. So absolutely incredible cases like this, huge paraganglioma. So the Neurosurgical Society decided it's better not to touch. And you can see here the big volume which are localized in posterior fossa. What to do first? Analyze all the possible vessels which are supplying paraganglioma, including leptomeningeal anastomosis, all the vessels from the external carotid artery, all the vessels which can be possibly used from the vertebral artery, and after that start one by one, stage by stage. Not to be aggressive, but finally you can see here the total number of the non-adhesive embolic material will close to 65 cc of onyx and squid. But what is more important, when we stabilized this paraganglioma, we didn't remove embolized part of paraganglioma. The station of the patient was adequate, modified Rankin scale, and this person is still alive and well, and they living without some restrictions. And also unusual case like this with some interesting features, external carotid artery for sure, vertebral artery, but what is more interesting here, you can see the dystopia of MMA, which arise from ophthalmic artery and absolutely not reachable for catheterization because of you don't need to go via MMA in this case. You can use just the all alternative ways. What is important to say, when you embolize the paraganglioma like this, you can expecting that non-adhesive embolic material will will penetrating by the law of the AVM. If the AVM not divided by acrylates or some partial embolization like a puzzle type, the non-adhesive embolic material potentially can go from one pole to the other, from one lobe to the other. And here you just need to count when it's better to stop, which artery still potentially will reachable for the next embolization, and also how many glucocorticoids will be needed after embolization just to stabilize the brainstem. What to do with the waist part, like you can see here at the skull base. It's very nice to to send the patient to gamma knife, for example, because of here it will be less dangerous, talking about the dangerous anastomosis at the skull base level, and paraganglioma will still very good react on the radiosurgery. So combine embolization with radiosurgery is also adequate way to get the good result and to give the patient a normal life without worsening or neurological decreasing. So you can see the cost of non-adhesive embolic material similar to AVM embolization. Talking about the results, 13 paragangliomas was totally embolized. Totally embolized means that all the reachable vessels of paraganglioma was totally penetrated with non-adhesive embolic material. After that, we found that the paraganglioma partially shrinking and in majority cases just stabilizing and not increasing, not getting a recidive. 11, this is a subtotal partial embolization, and here some patients can be embolized again or can be moved to the radiosurgery. And yes, we try to perform curable-like embolization. Yes, this is not a rule, but this is our idea to all those difficult to removal subjects. And in 2 cases, we performed classical pre-embolization before the surgical removal. In 2 cases, we got 5 and 9 cranial nerves worsening, but not severe, not ruin the life of our patients. And we also try to control by follow-up our patients as reachable as possible. From 12 till 72 months, we try to control our GORD. And follow-up was obtained in more than 85%. No regrowing, no worsening or decreasing quality of life was found. So, talking about the conclusion, balloons, the MSO-compatible balloons, this is the way to reduce the time of embolization, to organize very rapidly tempo of embolization, and also by these we are increasing the volume and wideness of that penetration. In case of large paraganglioma, it's better to count all the possible ways of embolization and just to create something like a plan. Which vessel will be used for the first stage, which vessel will be useful for the second one, and what to avoid, and which vessels even don't catheterize. Also, control of vertebrobasilar region. This is important. This is a very extremely important because of the dangerous anastomosis. Non-adhesive embolic material, when you push it very rapidly, when you push it very with high speed, can reach it faster than you even will be able to stop. So, devil hidden in details, the God in the smallest thing. St. Petersburg is always inviting you. And thank you for your attention.
Thank you. A fantastic presentation. In my country, all this is concentrated to another hospital, and I always thought that I'm not missing out on anything special, but I have to change this, I think. So, any questions? Yeah, Guillermo?
Congratulations. I love this presentation. And I have a lot of questions or a lot of consideration, because I think this argument is very important for us neuroradiologists. I'm a neuroradiologist, not a neurosurgeon. One, do you have experience with direct puncture of the tumor?
Yeah, this is a very nice question, and our Italian colleagues used this approach a lot, and I saw the publications. we found that if you will cauterize optimal branch from the ascended pharyngeal artery, you will got finally the same result. Because of paraganglioma, it looks like a whole space which are totally connected, and even if you start from the lateral part, some part, you will finally go right inside, right in the middle, like with the needle direct punching. By this, when we see the good vessel for cauterization, we go in endovascularly. Last month we got absolutely incredible case for embolization, and here we plan in direct punction, and this will be our initial experience with this technique because of no adequate feeders, no adequate branch for cauterization using DMSO compatible balloon or Sonic or Apollo, doesn't matter what exactly.
Because it can be a good option if you have the dangerous collaterals, because you'd go directly there and you do not have the risk of reflux. Okay, it's one part of my consideration. The second, the mechanism of action of the embolization of tumors, that means paraganglioma or meningioma or whatever, is inducing an ischemic lesion of the tumor, like we see in the brain when we have when the patient has, we hope just the patient and not us, the patient has an embolic cardioembolic stroke. So at the end we will not see the brain because so we induce an ischemic injury of the tumor, and it will shrink. So you didn't show any case, any follow-up of cases not operated where the tumor was not operated, but you said that the tumor do not grow again. So do you think it could be the choice to do not operate the tumors we are going to embolize? It means not just for paragangliomas, but even for meningiomas. I know that most of neurosurgeons will kill me, but I think I think that endovascular or direct puncture embolization of tumors or of benign tumors, not malignant tumors, can be a very good solution to avoid surgery even. Do you? What's your opinion about that?
First, before 2015, we started with paraganglioma, rather like meningioma embolization. The majority of vessels was obliterated, stroma or the heart of the tumor of paraganglioma from time to time was off of the good distribution, and loose situation will give us a recidive or maybe growing because of this situation can be stable. After embolization like AVM like embolization like we performed gave us the situation when the majority of vessel close to totally obliterated and stopped. When you working with squid 12, for example, you can reach drainage in vein, and here we get in the situation like AVM embolization, vessels which are feeding obliterated, nidus or the body of the paraganglioma obliterated too, and even drainage in vein, initial pedicle of drainage in vein obliterated too. In this case, for sure, we expecting for shrinking, but in paraganglioma case, we fixed not more than 20 or 30% of shrinking. It can't shrinking so severely like meningioma, for example, because of real benign meningioma will decrease in more than 40 or from time to time more than 55 or 60%. Here, paraganglioma looks more or less the same, or maybe shrinking in a little up till 20 or 30%. But in case when paraganglioma localized like this, localized like jugular, tympanical, and intracranial, this will be more than enough not to remove this. And here we will continue to control this cohort of patients, and here we will try to organize something like an optimal regime of curation of these patients. Embolization first, maybe radiosurgery as a level which are off of embolization because of the dangerous anastomosis, for example, or risk of cranial nerve palsy. And after that, after years of observation, we will get more or less honest results. Because of now, this is a promising idea. We are talking about the direct punction. Okay, it's a way to decrease the risk of embolism. But if you're using alone René-Chapot Copernic balloon, you also totally decrease the risk of embolism in the main arteries like ICA and carotid communis. If you use DMSO compatible balloons, you don't need to expect for stabilizing the reflux. You just intensively and rapidly injecting the non-adhesive embolic material and also changing the viscosity, combining 18 and 12 or maybe 34 just to a little bit stabilizing the movement of the non-adhesive embolic material inside, especially in case when you not feel the body of the paraganglioma, but you already reach the drainage veins. So here is better to also use in combination. So after that, the technology will be born. Today, yes, we try to fight with neurosurgeons. The majority of these cases was discharged from neurosurgical department and sent to embolization. So in synergy, I think we will rather get the final perfect result.
Yeah, thank you. You pointed two things that I think are very important. One, we need very good penetration of the embolic material, and Squid 12 is very good, or I don't know if Optura will do it the same. But
if necessary,
Onyx 18 is not the same, but Squid 12 goes inside the tumor very, very well. And the other thing is that a reduction of a 20% reduction and stabilization of the tumor, in my opinion, is enough. So you give space to the brain that it's already used to have less space. So
yes, it's true. In these three intracranial cases, the situation was unstable, and after embolization, it's totally cold. No signs of worsening, and these patients are really living their lives and have no severe restrictions or loss. So this is more important. Despite that we not decrease severely the volume of the paraganglioma. Just stabilization, this is already decision for these patients, because of what else can we do? Direct removal, impossible. And this was a lot of consiliums from the very gifted and skilled open neurosurgeons that decided, okay, it's rather ventricular peritoneal shunting, and after that just radiosurgery or embolization, whatever. But we can do something good by open surgery. And here we should be a good alternative and a positive way how to avoid severe complication and severe worsening of the status of the patients.
Thank you. Compliment.
Thank you.
Thank you, presentation. My question is, you implied about 2 excision after embolization. Why you performed excision, and what type excision, and after what time of period you perform the excision?
Thank you for your question. This was a carotid body type, not huge, which was finally endovascularly dissected from ICA. In this case, we decided that the result will be predictable and optimally just to remove and forget about this problem. In all the other complicated cases, when it was very, very close to the ICA, for example, or to jugular foramen or Ohio, we decided not to resect him.
And after what period you performed?
After 1 week. After 1 week, not longer. But this is just 2 cases. This is statistically not so important.
Thank you.
Андрей Евгеньевич, спасибо за лекцию, очень интересно. Вопрос про использование баллона Коперник. Длительность инфляции внутренней сонной артерии и были ли осложнения в связи с воздействием на синокаротидную зону?
Thank you for your question. The question about duration of the RNA Copernic balloon inflating inside the ICA and carotid communis. Up till 15 minutes of duration, but before we always using 5,000 of heparinization, and also before when we deflate the balloon, we try to deflate. This is not rapidly. We decreasing the pressure first. After that, we flushing inside the external carotid artery potential thrombus if they arise, but actually we never detected something like embolism at this maneuver. And for sure, first of all, we analyzing the Willis circle. If we have a good ACOM or PCOM also, you can close this artery for longer than 15 minutes. But we tried to use this period as an optimal, more or less safe and adequate. Sometimes in huge or giant paragangliomas, we use two times of inflating the balloons by 15 minutes, and this was enough for the total embolization. The one stage embolization takes 22 or 24 cc of non-adhesive material without severe intoxication after.
Another question, sorry. When you use bilateral bifemoral approach, so do you inflate the balloon and check from the other side from collateral circulation or not?
No, we just use the compression test just to analyze the ACOM, and we work in at the site of the paraganglioma at the same place.
Okay, thank you.
So, thank you for a beautiful and very impressive presentation. No doubt, this is medicine at its highest point, and very good questions from the audience also. Thank you very much. So I think we will be able to reconnect with Roger in Spain.
Hello?
Hello, Roger. Welcome back.
Okay. Sorry, apologize. I think for some minutes I was speaking alone. Sorry for the inconvenience. So I will continue. I think the slide I had, and correct me, I should start here, talking about antiplatelets. Is that correct?
That is correct. Thank you.
Okay, so I will take it from here. Okay. So I was saying about intracranial stenosis that, as we all know, the data for thrombectomy, it's huge. but still for intracranial stenosis, guidelines, it's not still there. And maybe everyone has its own ideas. So all these topics I will take into consideration during the presentation. You can criticize me, but at least this is the personal experience and opinion that, of course, we can discuss later. Regarding antiplatelets. So before, at the beginning, every time we encountered during thrombectomy, mainly for ICAT, intracranial stenosis, we used endovenous aspirin. But when we started to use more and more endovenous agents, rapidly effective and with shorter half-life, we like this in acute cases or any complication, any hemorrhagic transformation, we can stop them. Mainly integralin in Agrastat, this is the ones I have personally used. Regarding these 2B3A drugs, for the P2I12, the advantage of Candelor, I have not used it in stroke. I just use it in some cases of acute stenting for aneurysm. So has the advantage to be even very short half-life and very rapid onset. And regarding the guidelines still not clear. This is the updated guidelines for the SNIS. And there is any recommendation specific for intracranial stenosis. Just for carotid artery stenting, they recommend that it might be reasonable to use these drugs as a loading dose and then do a intravenous infusion maintenance. In the stroke guidelines, still the use of these drugs, it's not clearly recommended. It's uncertain. But there are also some papers of thrombectomy, not stenosis specifically, thrombectomy, that they combine, it's a match control analysis, they combine thrombectomy and thrombectomy plus integralin, and seems to have some benefit for this. Regarding what to use, should we use a balloon, a medicated balloon, or stent? In case we use stent, which kind of stent? Most of us, I think we try to still use a balloon, if that is enough. This is a young patient, comes with a stroke. So just for the age, we suspect there might be an ICAT, but we don't know. So we do a thrombectomy pass with the stent retriever and aspiration. We open the artery, M1 occlusion. We also, after the thrombectomy, looks good. Artery is open. There might be some vasospasm, or maybe there is some stenosis. We are not sure. So at this moment, we wait. It gets worse. So we decide to do an angioplasty. On this case, this is a recent case that we changed our strategy. Instead of doing bare angioplasty, we decided to give the antiplatelets, give some time to the antiplatelets to get the effect. And once the patient has the effect on antiplatelets, then we did the angioplasty. We did the angioplasty, we waited 20 minutes, stent ready just in case, but in this case it was not required and the artery maintained open. This is a case of balloon mounted states, as most of us, I think we take them from the cardiologist, very severe peripheral vascular disease, difficult femoral access, we went radial, we see a focal mid-basilar stenosis, so in this case, balloon mounted stent will give us a proper radial force. This patient did well, we were very happy, but a very similar case, very tight stenosis, mid-basilar, same strategy, we go radial, very nice picture before and after, but clinically we created a medullary infarct in this patient. So clinically it was a disaster. So probably we used a too big stent, maybe we should not have opened that much, I don't know. So in these locations, personally, we avoid using balloon mounted stents. What about self-expandable stents? Some years before in the market, we moved to use this balloon, aerospeed balloon, that we can do angioplasty, and then if there is a requirement for stenting, we don't need to do any exchange. Through the same balloon itself, we can place the stent. These stents might be great, but radial force is low compared to the balloon-mounted stents. So this is a case. And again, a young patient, we see acute case of stroke, we see stenosis or ICAT or dissection or thrombus, we are not sure, in the carotid distal carotid. We did one, try to aspirate, use stent retriever. It improved. We think we are done, but we wait for some time and it gets worse. At this moment, we suspect there is an ICAT, and we decide first to put the balloon. It's not working, so we place the stent. In this case, we use this type of credo stent. After the stent, it was not great. Probably this stent had not enough radial force. This is not, personally, I think it's not a good location for this stent. Also, during the stent, we created an M1 occlusion that was not there. So we tried to cross the stent. It was not possible from the inside. We had to finally do a thrombectomy maneuver, also with the help of a snare. And we took out the clot. And also, this is the credo stent you can see here. So I'm just showing this case because I think it's not a good idea to use this stent in this location. And this is the final result after the stentectomy. The carotid maintained open, luckily. Okay, another example. Typical young patient, hypertensive, diabetic, non-compliant to medication, and just for the clinical history, we know that the symptoms started 1 week before. The patient is getting worse, so we just for the clinical symptoms, we suspect we might deal with an ICAT. There is a basilar occlusion. If there's acute thrombus, we don't know. If there's an ICAT underlying, we don't know. We go, there is some mismatch. We are not liking the brainstem a lot, so before going to the cath lab, we decide to do a diffusion. Brainstem is spare, so we decide to go to thrombectomy. This is the thrombectomy. There is an occlusion. We close with a microcatheter. There might be some thrombus. We are not sure. So we do a conventional, use a small stent retriever, a Catch Mini or Solitaire 3. Honestly, I don't remember. We open the artery. We think we are done. Underlying stenosis might be vasospasm, but again, we wait some time. This is getting worse. So we use a balloon. And with the balloon, we start with a 2 millimeter balloon. It's not working. At this moment, on this case, we were not still giving antiplatelets, so we were doing balloon without antiplatelets. So even with the balloon, it improved for some time, but this was coming back. So at the end, we decided to put the stent, and before putting the stent, we had to give the antiplatelets. This patient had a good imaging and also clinical outcome. This was the CT after and just the previous infarction seen on the MRI. So the strategy that I was talking, we tended to change to do angioplasty without any antiplatelets. And then if this didn't work, to give the antiplatelets, tirofiban or integralin, and then put the stent. But every time, I think personally, and we can discuss later, that if we have to give a chance before putting the stent, especially in acute case, do angioplasty with antiplatelets on place. And once we keep the integralin and tirofiban, and when we think the stroke, the risk of hemorrhagic transformation, it's okay, then we switch to oral antiplatelets, aspirin or ticagrelor. It might be in 24, 48, and in some case, we even take more days to this. And why we do it with ticagrelor? Probably as many of you have switched the use of clopidogrel to ticagrelor, even it's more expensive. But we have some data. There is not a lot of data, but there is a cardiology paper from Saudi Arabia, and they see that the resistance for Arab people might be very high. So in this case, 2 out of 66%, they are talking about clopidogrel resistance. So we don't want to risk it. Those stents are small, so we prefer to give ticagrelor instead of clopidogrel. This is another case, progressive symptoms, young patient again, and comes with low GCS. We have a basilar occlusion, we are not seeing anything, but also the anterior circulation doesn't look good at all. We are not sure if everything is occluded. There are some collaterals, we are not really sure. Even the mismatch, it shows some mismatch on both hemispheres. So we are confused on this case because it might be the underlying stenosis. So we start to the vertebral arteries. There is a pike occlusion, basilar occlusion. So at the beginning, we don't know if there is acute occlusion. There should be clinically acute worsening. So we do one thrombectomy maneuver, stent retriever, and for some time it looks good, but after some times it comes back. So we are suspecting an stenosis. So at this time, we decided to do an angioplasty, small balloon, arteries are very small, it seems to be okay. We wait some time. While we are giving some time to this, we decide to perform a pica recanalization, mainly because this pica also might help to the superior as a collateral to the superior cerebral hemisphere. That's why we do it. And once we're done with this, this is worsening, we decide to give the antiplatelets. Within the risky maneuver, without antiplatelets, now we give it because this is not working well. While giving the antiplatelets, we check the left hemisphere. There is a left M1 occlusion. This seems to be quite chronic with a lot of collaterals. But checking the obliques, we see also this PCA, PCOM, has a very tight stenosis. So this PCOM is really not helping the posterior circulation at all. We check the right side, also some ICAT, some carotid stenosis. Just to give some more flow, we decide to put a carotid stent just to give more flow to the posterior circulation. And we go back to posterior circulation. Even the antiplatelets are given, everything has reoccluded. So at this time we used a balloon again, but this time antiplatelets are there. Antiplatelets have been there more than 30 minutes. The bolus is finished, so probably the effect is better. So in this case, we just waited with the balloon angioplasty. We waited with the stent ready, but it was okay. And a stent was not needed, but the medication again was on place. And this is the result after. So it had a decent clinical result with some just this infarction. This is another case, again, young patient. This patient has a diabetic, has an A2, right A2 occlusion with a clear mismatch, NIH4, but together with neurologists, we decide to go for it as it's a young patient. So we expect to have a thrombus. So we take a catch mini, distal navigation, we do one pass, and here you see after the procedure it looks well. I hope this to be Johnson vasospasm, but we wait some times and it recloses again. We decide to give another chance. In this case, with the catch mini in place, with the balloon guided catheter, we just advance a 3-max. I'm just showing this video to show you how a 3-max it's navigating quite well just through the guide wire of the catch mini to perform another thrombectomy pass, but this is not working. We did another pass that didn't work. So we decide to use the neurospeed balloon. The neurospeed balloon, the navigation is more difficult than a microcatheter, it's more difficult than the Neuromax, so the 3-max, So in this case, we use a balloon inflation to give some support in order to put the neurospeed in the A2. We do angioplasty, we wait some time, antiplatelets are there on this patient again, but unfortunately the results were not good and all this territory was infarcted, and even at discharge, the network was just 4, this meant to be MRS 4 at discharge. Another case, similar story as before, 50-year-old Pakistan diabetic. He has progressive symptoms with imbalance. The patient worsens very quick to have a low GCS. And this, I'm not showing the CTA, but when I saw the CTA, I had a lot of doubts. What artery should we go, right or left or right vertebral? Both look very bad. So we checked the right. There seems to be something acute on this side. On the left, there is a focal stenosis, so we like to focus on the right side. Again, there is some stenosis, there is ICAT, there is some thrombus, we don't know, we decide to prefer first a thrombectomy pass, and it improves. It improves a little, it shows the underlying stenosis, and we wait some time, but this is not improving. So we take a small balloon and try with the balloon. We wait again. But this finally, it recloses again, even the antiplatelets are on table. And finally, on this location, as we are not expecting perforators before it's below pica, we used a cardiologist self-expandable stent. for this artery, and then we moved to the other side, to the left side. Antiplatelets again were there. We used the balloon, wait, it doesn't work, and finally also we used the credo stent through the balloon in this case. What about, which is the real, going back to the main ideas of intracranial stenosis, what is the real lesion size? We rely on the 2D angio imaging, but sometimes the diameter of the lesions, we are not really sure which type of plaque are we dealing with. It's a soft plaque or there is an underlying dissections. Are there perforators there? Most of the time we know anatomically, but one thing personally, and probably most of us understand, it might be very helpful in the future, it's optic coherence tomography, OCT. Cardiologists nowadays, they are using this a lot, and there are some studies also showing that there is an impact in survival by using OCT, having a good understanding of the plaque. Also, this helps a lot to choose the proper balloon and stent for every case. But hope this on the next years, we might have access to this for selected cases, and I think in ICAT might be very useful in some cases. What about the location of the stenosis? Which anatomy has this specific patient? Does this patient has potential collaterals? And this might be very important in non-acute cases. This is an example of a case with a minor stroke that has bilateral vertebral stenosis. I'm showing on these pictures, minor stroke, basilar open, but patient goes home, best medical treatment, and 2 weeks later, the patient comes back with a very severe symptoms. And this patient, you see here, where we're supposed to be the both vertebral stenosis. This patient had not PCOMs, and the MRI diffusion I'm showing you, it was a huge infarct. So this patient, we were conservative, best medical treatment, but maybe due to the anatomy, we should have been more aggressive just for the anatomy. Similar case, this is a patient that we did a diagnostic angiography after stroke progression, after best medical treatment. We do the angio, and this patient had no PCOMs. So we do it as an elective case. So this patient has no PCOMs and has no right vertebra, and it has a very tight vertebral stenosis. So even bad medical treatment, we decide, we think this patient might benefit from this. So this patient is elective. We have has already dual oral antiplatelets, but we try with the balloon first. Just with the balloon, it doesn't work, and finally, through the balloon itself, we place the credo stent and showing you in both AP and lateral view how we deploy and open the stent through the neurospeed balloon. And as I told you before, this might be a very tight stenosis. It stands radial force is not compared to the ones we are achieving with the balloon mounted stent. It is after SPET-10 deployment, but then through the balloon, it is 8 millimeter length balloon, the neurospeed balloon, we do inflation, and this is the result after. And you can see before and after, very tight stenosis, combining pre-angioplasty, stent, and post-angioplasty of the stent. What about, I think, in acute setting, when you have a stroke and the patient has symptoms, it's very clear we need to treat this patient. But what about when we are not in the acute setting, in a stroke? This is a case that had a minor stroke, it had a carotid, very tight stenosis on the left side, best medical treatment, and 1 week later comes with more symptoms and more watershed infarction. So we decide to go for it. We do the angio, the artery is occluded, but we get another access, we check the right side, and we see it's a very short occlusion. We think this patient is not improving despite this medical treatment, so we decide to go for it. We consider going transcirculation, but the ACOM is very small. So finally, directly with the smaller neurospeed balloon, 1.5, we crossed with the bended wire the lesion directly. You see here the bended wire, and finally, just with the angioplasty, this patient was, again, the stent was ready. We waited a long time, maybe half an hour. It was stable. Patient was antiplated for some days, so we left it like that. So as a conclusion, finishing, ICAR might be a challenging technical procedure, and when we have these technical good results, we need to do our best to translate to good clinical results. It's very important that proper antiplatelet protocol, in my opinion, anti-2B3A, it's a great medication for its safety, but of course we need much more data, more studies. Neurospeed balloons combined with cretostent is a great technical tool, but when we have in territories out of basilar or M1 that we don't have perforators, balloon mounted stents also might be very good. OCT imaging might improve our understanding and hopefully also by a better understanding the outcomes of these patients. And for each specific patient, we need to have a very good anatomical location and understanding of the lesions. Thank you very much. And again, I hope that I could make it to Astana, but here, Dr. Nale, my colleague, I hope he enjoyed the huge hospitality of Kazakh people. Thank you very much.
Thank you, Roger. Fantastic talk. I cannot agree more with what you have to say, and I think this is one of the most inspirational and best talks on this topic I've seen. So thank you for that. Any comments from the audience? I have one question. So for the 2B3As, how do you dose? Do you give the cardiology dose, or do you think it's reasonable to lower the dose?
Yes. So for this, to be honest, initially I was very confident, and still very confident with tirofiban. For tirofiban, we use the cardiology dose. That is we give the half an hour dose, which is 0.5 micrograms kg per minute, half an hour, and then we do the maintenance. This is very clear. And we always use it the same way, and I think we have good results. I didn't find any hemorrhage so far. Regarding integrin, which I was forced to use at the beginning when I moved to the country in one of the hospitals, so even the it's not clear. The recommendation is very wide. So there I tried different doses. They talk about a loading dose of 180 micro EG, that's clear. But the maintenance, they say between 1 and 2 mLs minute per hour. So it's a huge difference. So I never got very confident on that. So, and the other option, as I told you before, but I don't have the experience, I think Cangrelor might also be a great tool. But again, we need a lot of data to have the best dosing.
Yes, I think Integralin is now off the market because of manufacturing issues. So we're set with tirofiban now. And, and for the tirofiban, you can do it two ways. You can do it as you do. You give the loading dose for a half an hour infusion, right?
Yes.
So we had some problems initially with if you connect the loading dose to a long tube, and there is saline in the tube, and there is also a question on when do you think we have effect of the drug after starting the injection? Do you think it's important to start giving the drug a little bit before stenting, or?
So I think this is a very good question, and I have the same doubt. Again, I'm not a hematologist expert, but when I changed the protocol in Barcelona some years back, this is the question I made to the hematologist.
Yeah.
I said, okay, we give tirofiban, when should I expect that we reach we are safe, right? So we are doing the loading dose for half an hour. He told me in 15 minutes you should be fine.
Yeah.
So that's on my mind. I don't have the exact data for this, but on my mind I try to do this. So if I'm doing an angioplasty for an ICAR, at least, and I think it makes a change, that the mortar, if we do it too fast, maybe the antiplatelets are not there yet. So waiting 50 minutes, and also we use the same protocol. I like using this protocol. Any kind of stenting for aneurysm on the table, give the same protocol, wait 15 minutes before we deploy the stent. So we are on the safe side.
Yes, I think these are really important details or issues that we need to clarify. Because of some issues, we switched to giving a reduced IV bolus immediately to be able to have the effect, and try to give it as early. The moment you decide that you're going to put a stent, you give it. I think that's, yeah. Any questions?
Okay. So we thank you.
Thank you very much.
Yes, fantastic talk, and hope to see you sometime and discuss more. This is really on the level that we are working on also, so thank you.
Thank you very much.
So what is the next step? I think it's a coffee break. It has been it was 4 o'clock, but we have one more. Yes. Or should we have a quick coffee and have your talk after? What do you think? Yeah. I think because Adnan and Pascal is going on at 5 o'clock, no? So, yeah, let's have a short coffee break and then return for the interesting tumor. So let's continue. The next talks will be on embolization of tumors or brain tumors. First we have Kirill, Orlov, and then we have Adnan Siddiqui. So let's see if we can get Kirill's presentation on the screen.
So I'm not Kirill Orlov. I will be him just for a few minutes. The lecture will be on Russian, so if you need phones.
Yeah. Okay.
I will try. 12. Do you need do you need phones? No?
No, it's okay.
The lecture will be on Russian, so.
Okay.
Oh yeah.
Do you have?
Добрый день. Сегодня уже обсуждалось лечение гиперваскулярных образований, такие как параганглиома в предыдущем докладе. Поговорим сейчас немного более подробно о всех образованиях головного мозга. Несмотря на развитие современных технологий, удаление гиперваскулярных опухолей головного мозга остается сложной задачей. До сегодняшних дней послеоперационной инвалидизации летальность составляет от 3 до 7%. При наличии гиперваскулярной опухоли увеличивается сложность, риск выполнения операции, особенно в сочетании со сложными топографо-анатомическими данными. Какие причины, ухудшающие исход оперативного лечения гиперваскулярных образований? Это прежде всего обильная интероперационная кровопотеря, снижение качества визуального контроля в условиях интенсивного кровотечения, а также увеличение травматичности операции. И в связи с ограничением визуального контроля возрастает риск повреждения сосудов, черепных нервов и функционально значимых зон. А также такие факторы, как большой размер опухоли, неблагоприятное расположение, инкапсуляция артерий и инвазия синуса. Решением данных проблем и улучшением клинических исходов является проведение предоперационной эмболизации. Надо сказать, что идея предоперационной эмболизации не нова. Впервые была проведена эмболизация питающих сосудов менингиома более 50 лет назад. В дальнейшем методика активно развивалась. Задачи предоперационной эмболизации указаны на слайде. Это уменьшение объема кровопотери во время операции, уменьшение травматичности операции и продолжительности, а также улучшение функциональных исходов. На данном слайде представлены основные виды новообразований, при которых возможно выполнение эндоваскулярной эмболизации. Наиболее часто данный метод применяется при менингиомах и при гломусных опухолях. За последние 20 лет появилось множество публикаций, которые подтверждают эффективность применения предоперационной эмболизации. Главным преимуществом в большинстве опубликованных статей является уменьшение интероперационной кровопотери при удалении образований. Здесь представлена работа 2020 года, включающая в себя 36 пациентов. Во всех случаях наблюдалась успешная деваскуляризация, подтвержденная отсутствием заполнения опухоли после эмболизации. Еще один из последних метаанализов, посвященный данной тематике, включающий в себя только менингиомы. По результатам метаанализа показано, что предоперационная эмболизация у пациента с менингиомой не увеличивает общую частоту осложнений и может значительно уменьшить интероперационную кровопотерю по сравнению с пациентами контрольной группы. И ретроспективные исследования, проведенные также недавно, авторы не обнаружили значительного улучшения хирургических результатов эмболизации, объеме кровопотери, времени операции и объеме переливания крови. Однако было отмечено значительно более низкие показатели хирургических осложнений и долгосрочной инвалидности у пациентов с менингиомой с предоперационной эмболизацией. Не все авторы согласны с необходимостью проведения предоперационной эмболизации. В результатах ретроспективного исследования, которое изображено на слайде, показано, что эмболизация не изменила хирургические результаты пациентов, но могла привести, тем не менее, к большей вероятности улучшения функциональных результатов. Следует отметить, что исследование включало в себя только внутричерепные менингиомы первой степени. Еще один недавний метаанализ, включая в себя 34 исследования, 1782 менингиомы, эмболизированы до операции. Авторы также сообщают о том, что сомнительный вывод, принесет ли предоперационная эмболизация пользу с точки зрения снижения кровопотери времени операции. Другое мнение озвучено в другом большом метаанализе, посвященном эмболизации параганглиом. В целом по параганглиому было обсуждение ранее, поэтому останавливаться подробно не будем. Несмотря на то, что чаще всего метод деваскуляризации рассматривается как первичный метод, первый этап предоперационной подготовки перед хирургическим удалением, в некоторых ситуациях может быть проведена паллиативная эмболизация в инкурабельных случаях. При этом происходит замедление роста опухоли и стабилизация клинической симптоматики. Ну и, наконец, эмболизацию доброкачественных опухолей можно рассматривать как единственный лечебный метод при невозможности проведения микрохирургического вмешательства, при небольших образованиях, также при высоком риске микрохирургической операции, но только при условии их субтотальной либо тотальной окклюзии. Чем эмболизировать? На слайде указаны в настоящее время используемые материалы. Подробно о материалах. Микрочастицы представляют из себя частицы поливинилалкоголя, биосовместимы, не абсорбируются, обеспечивают полную длительную механическую окклюзию, вводится с помощью микрокатетеров, достаточно широкая линейка размеров в зависимости от размеров сосудистой сети и необходимой цели эмболизации. Несмотря на некоторые преимущества, данный вид эмболизирующего материала не рассматривается в качестве лечебной эмболизации в связи с тем, что часто вызывает реканализацию. Микросфера обладает схожие преимущества, что и микрочастицы, имеет дополнительное преимущество в виде минимального слипания, отсутствия формирования комков. Чаще всего они не контрастны, необходимо смешивание с контрастным веществом. С целью снижения риска реканализации, как при эмболизации микросферами, так и при эмболизации частицами, возможна комбинация данных эмболизаторов с адгезивными композициями. Адгезивные композиции наиболее популярная NBTU2 цианокрилат. Химические свойства, я думаю, известны всем. При контакте с тканевой жидкостью быстро полимеризуются, в связи с чем для снижения скорости полимеризации их необходимо комбинировать с йодированным маслом. Чем выше объем добавляемого масла, тем медленнее скорость полимеризации смеси. Соотношение смеси зависит от цели эмболизации. Мы чаще всего применяем смесь 5-30%. Чем ниже концентрация смеси, тем более лучше проникновение эмболизатора в строма опухоли. Ну, наконец, неадгезивные композиции кополимера на основе этиленвинилалкоголя в различных вариантах и кополимер фил, который обеспечивает лучшую видимость, не осаждает, соответственно, обеспечивает однородную консистенцию. В отличие от адгезивных композиций, неадгезивные агенты способствуют более управляемой эмболизации. Микроспирали, скорее использовались чаще всего в прошлом, в данный момент используются как элемент pressure cookie техник. Общие данные по преимуществам эмболизатора подробно не будем. Методика эмболизации. Проведение вмешательства целесообразно начинать под местной анестезии с целью оценки ангиоархитектоники объемного образования. Поскольку чаще всего афференты образования из наружно-сонной артерии, обязательным условием является селективная катетеризация наружно-сонной артерии. При выявлении непосредственно сосудов краснообжающих опухолей, целесообразна селективная катетеризация отдельных ветвей наружной сонной артерии. После того, как выявили возможность проведения эмболизации, производится микрокатетером проводится катетеризация афферента и суперселективная ангиография. Мы предпочитаем использовать микрокатетеры с неотрывным кончиком при работе из ветвей наружной сонной артерии или баллоны микрокатетеры и катетеры с отрывным кончиком при эмболизации из ветвей внутренней сонной артерии. После катетеризации анализируется сосудистая сеть, наличие шунтов, анастомозов, а также состояние дренирующих вен. Возможно проведение провокационных медикаментозных тестов при подозрении на вовлечение в кровоснабжение опухолей ветвей краснообразующих черепно-мозговых нервов. Однако специфичность тестов достаточно низкая. Далее производится непосредственно эмболизация, собственно, и ангиографический контроль. Интраоперационно мы всегда применяем системную гиперонизацию с целью снижения риска тромбоэмболических осложнений. Методы, повышающие радикальность эмболизации, безусловно, это дистальная катетеризация, если так можно выразиться, по аналогии с мальформациями интранидальная, использование баллонных катетеров и pressure cookie техник с целью уменьшения рефлекса, улучшения проникновения эмболизата в стромы опухоли. Также возможна комбинация различных эмболизирующих агентов, например, комбинация кополимеров различной вязкости. Какой вид анестезии выбрать? На данный момент однозначного ответа на этот вопрос нет, зависит от множества факторов, собственно, как и от предпочтения хирургической бригады. Наше мнение, что общая анестезия показана при использовании адгезивных композиций в связи с тем, что введение воздействия ДМСО вызывает болевой эффект. Также при работе на интеркраниальных сегментах артерий, манипуляциях в синокаротидной зоне и при эмболизации крупных гигантских образований в связи с тем, что необходимо обеспечить длительную неподвижность пациента, и операции занимают много времени. Не следует забывать и об исходно-соматическом статусе пациента, особенно это относится к пациентам старшего возраста, которым порой даже сложно находиться в неподвижном состоянии при выполнении ангиографии. Местная анестезия также возможна, чаще всего применяется при использовании частиц, микросфер, с тем, что эмболизация данными материалами безболезненна. Осложнения эмболизации также всем известны, как от порезов черепно-мозговых нервов, так, собственно, кожный некроз и эмболии в нецелевой бассейн. Здесь указано кровоснабжение черепных нервов. Обязательно необходимо знать перед проведением эмболизации. Также необходимо знать наличие опасных анастомозов. Здесь указаны анастомозы передней циркуляции между ветвями наружной сонной артерии и внутренней сонной артерии, а также анастомозы задней циркуляции между ветвями наружной сонной артерии и позвоночной артерии. Отдельно следует отметить наличие анастомозов, выраженных с офтальмической артерией, в связи с возможным вовлечением офтальмической артерии в кровоснабжение, образование основания черепа. Какие сроки оптимальны для эмболизации? В данном вопросе также есть несколько мнений. Некоторые авторы придерживаются сроков 7-9 дней после эмболизации. С нашей точки зрения наиболее оптимально это 3-7 дней до хирургической резекции с учетом максимальной индукции некроза и ее размягчения. Короткий промежуток между эндоваскулярным вмешательством и хирургическим предотвращает возможную реканализацию. Далее хотелось бы продемонстрировать клинические примеры. Назофарингеальная ангиофиброма у ребенка 9 лет. Представлена селективная катетеризация наружной сонной артерии. Видна обширная гиперваскулярная сеть, и с помощью цианокрилатной композиции проведена тотальная эмболизация. Менингиома крыла основной кости с выраженным кровоснабжением из ветвей наружной сонной артерии. Проведена эмболизация неадгезивной композиции с последующим ее удалением. Петроклевальная менингиома с афферентами из ветвей внутренней сонной артерии, ветви менингогипофизарного ствола. Проведена баллон-ассистенция, катетеризирован афферент и эмболизация с помощью микрочастиц. Еще одна менингиома основания черепа, то, о чем говорил ранее. В кровоснабжении участвует офтальмическая артерия, здесь проведена ее селективная катетеризация. и эмболизация с помощью цианокрилатной композиции. Еще один менингиома основания крыла основной кости, афференты, также внутренней сонной артерии, проведена парциальная эмболизация с последующим ее удалением. Здесь использовалась смесь гистокрил-липиодол 20%. В случае лечебной эмболизации маленькой менингиомы височной области проведена эмболизация гистокрил-липиодол 10% смесью, и пациент оставлен под динамическое наблюдение. Метастаз ганглии нейробластомы, ребенок 9 лет, обширная сеть как из внутренней, так и из наружной сонной артерии. Выполнена эмболизация неадгезивной композиции Оникс. В дальнейшем образование частично удалено. Сейчас планируется второй этап удаления. Наконец, финальный случай – это лечебная эмболизация менингиомы без ее последующего удаления. Пациент также находится под наблюдением. И в заключение хотел бы сказать, что несмотря на отсутствие единого мнения по поводу необходимости эмболизации и на противоречивые данные об уменьшении интервенционной кровопотери, эмболизация опухоли является безопасным, эффективным методом как предоперационной подготовки, так и самостоятельным методом лечения. При наличии тяжелой сопутствующей патологии, высоком риске оперативного пособия, возможно использование метода эмболизации как единственного метода с целью стабилизации состояния и регресса опухолевого процесса. Спасибо за внимание. 15 minutes.
Perfect. Thank you for this great speech, and thank you also for the very good translation. I understood everything, I think. Any questions from the audience? I think this is a super interesting concept of embolized standalone treatment of meningiomas. Do you think this is possible to progress to a reality in the future?
Да, я думаю, в дальнейшем будет уменьшение количества микрохирургических резекций в связи с тем, что техника совершенствуется, поэтому уменьшение процента открытых вмешательств. Поэтому. Но, к сожалению, не всегда возможно ограничиться только эмболизацией, поэтому не стоит забывать и открытую нейрохирургию.
Do you think are there any certain meningiomas in certain locations that you think would benefit from standalone, will be the primary targets for standalone therapy?
Да, скорее всего.
Yeah, are there any certain locations like skull base or convexity?
Для эндоваскулярного лечения?
Yes, for standalone, yes.
Наиболее оптимально все-таки конвекситальные менингиомы. Да. Если я правильно понял вопрос.
Could you repeat your answer?
Конвекситальные менингиомы.
Convex, okay, thank you.
Not skull-based.
Not skull-based, perfect. Any more questions? Okay, thank you very much. So I think hopefully we have Adnan Siddiqui from the US online.
Yes, you do, Fabian.
Perfect. Nice hearing your voice, Adnan. I guess you are fully prepared to show us what you got.
I am ready whenever you are.
Okay, let's go.
All right, great. Well, firstly, I am really jealous of all of you for having such a great time. And to Minjal and his team, congratulations for putting together another fantastic meeting. I think this one might be surpassing all the other prior ones, but I wish I was there with you to enjoy the talks, the cases, and the festivities. So hopefully next year, I'll be there in person to really enjoy this incredible fellowship which has become NeuroAddicts. With that, the title that I was given to talk about is intra-arterial chemotherapy, and I think what was just presented by Kirill is a fantastic way to get the process started. So I'm going to talk a little bit about intervention, and I'll skip over many of the things that were nicely talked about by Kirill, including particularly meningiomas and such, and then start moving into areas where we want to go, which is invasive intrinsic gliomas. And so, as Kirill mentioned, endovascular embolization has been done for a very, very long time, and it's highly neurosurgeon dependent. So there are people who are dogmatic about always embolizing, and the other who are dogmatic about never embolizing, and then there are others who kind of do it on a case-by-case basis. I am more in the form, in the category of case-by-case. I look at the risks and benefits. If it's a straightforward surgical case, without really a major concern about issue with vascular plane, and you can see these kinds of things on MRIs pretty well. There's a nice T2 cleft between the brain and the tumor. Maybe you don't need a whole lot of embolization. On the other hand, if it is, looks like it's invading and it's very, very vascular, then I think embolization absolutely helps improve the planes that are visible during surgery. And obviously, this has been quite controversial in terms of what is the right thing to do. This was done, a meta-analysis that suggested that there was poor level of evidence for recommending always embolization. So advantages, you want to reduce blood loss, you want a better visualization, maybe reduced operative time, and the biggest risk to consider is the ECIC collaterals are the most important ones to really be careful about inadvertent embolization. We know about embolization agents. People have used coils for proximal occlusion, gel foam, PVA, microspheres. All of these are great if you're planning to go for surgery pretty quickly after embolization, because they tend to resorb. And then you have the permanent ones, NBCA, and most recently Onyx in squid have been used, as well as FIL, which are more DMSO-based embolic agents. The big thing here is that you have to understand how deep of a capillary fill can you get. With Onyx, you get almost no capillary fill. With NBCA, if it's adequately diluted, it can give you capillary fill. And then there are newer embolic agents which are being developed, which may be better suited for tumor embolization, especially if we plan to not perform surgical resection. So this is sort of our series where we looked at these tumors, and really the key things that we have taken away from that is the arterial pedicles need to be amenable to microcatheterization, avoid embolization of internal carotid artery feeders, avoid the vasa nervorum and supply to eloquent structures such as cranial nerves, as very nicely mentioned by Kirill. Like, one of the things that I'm really concerned about is embolizing the neuromeningeal trunk of the ascending pharyngeal. That's a high-risk area. When you have concerns for anastomoses, use coils, occlude the collaterals before going to embolization as well. So I think you always need to sort of keep all of these things in mind. Here's an example of a very large olfactory groove meningioma with its ethmoidal supply. Here's another one with a sphenoid wing meningioma. Again, when you embolize many of these, you realize that sometimes you get really good penetration, other times you don't. Like the case that was shown, I will show you quickly a case here of middle meningeal embolization for a patient to have a large parietal convexity meningioma. I think these are the easiest cases for us. And here you can see we are embolizing through multiple branches. And once we have completed embolization, then what happens is this is your final result, pre and post. There's still a little bit of filling, but this is considered adequate. You can see patchy necrosis. Again, if we had an embolic agent that permeated capillaries, maybe it would be better. Here you can see the onyx on the open dura before resection. You can see almost no vascularity to the underlying meningioma. You can see it can be taken out with a fairly straightforward fashion. And once that is done, you know, it usually makes the operation a little easier. So, moving on, we look at from tumor embolization to chemotherapy via neurovascular route. So that's the other thing. And here, the greatest advances have been made in the form of treatment for intraocular retinoblastomas. And currently, it has now become both first and second line management for all intraocular unilateral retinoblastomas. And it's become a second line for recurrent persistent neuroblastomas. And here are some examples. The drug that is used is melphalan, which is the ideal agent for these. And you can sort of see pre and post intra-ophthalmic, intra-arterial chemotherapy development, and really has quite fantastical control. Look at these numbers, almost 100%, when you look at the improvement of the lifetime of survival, but not just survival. Look at globe salvage. Almost 66% of globes were salvaged for patients who underwent intra-arterial melphalan, which I think is a phenomenal progress. Obviously, there are complications with everything, particularly spasm, vitreous hemorrhage, chorioretinal atrophy, occlusive vasculopathy. However, this continues to evolve and now is standard therapy in the vast majority of institutions that treat these lesions, and almost always these are cases that are being performed by neurointerventionists. So this is something that we should all get familiar with, and it's quite useful. And then evolving from there into intra-arterial route for therapy for developing delivery to intracranial lesions, gliomas specifically. There are no standard guidelines here. This is still very much early on. There are no large cohorts. There's lack of clear benefit in the past. And most studies have just included recurrent aggressive gliomas refractory to surgery or radiotherapy. And so there really aren't good protocols or experimental the methodologies. As you are all aware, we started with the Stoop protocol for GBMs, with radiation protocols for GBM, including recurrent with radiosurgery, and chemotherapeutic agents, temozolomide and bevacizumab, which is the Avastin and Temodar that we routinely use in these people. However, there's been some evidence, primarily led by John Bookwar from Lenox Hill in New York City, where he injected Avastin. Avastin is an anti-angiogenic drug with pre-procedural preparation of the blood-brain barrier by injecting some mannitol, and suggested that there may be some encouraging improvement in lifetime, in life survival. And so, interestingly, I'm not quite sure if that is necessarily true. Again, another disease where we have no other options, such as diffuse intrinsic pontine glioma. There's a little phase 1 trial again, suggested that at least it was tolerated well. Not sure if it's going to be beneficial. And then there are others, like this is my dear friend Peter Kahn from Texas, who used intra-procedural perfusion mapping to identify the ideal pedicle to embolize a tumor, and he has done these in a few occasional cases. He has also looked at intra-arterial delivery of what are called oncolytic viruses. So what you do is you prepare immune cells by infecting them with these oncolytic viruses that kill the cells that they attack, and you target GBM cells, and that can be useful, and that can result in effective, again, very early protocols. I think at this point there are small cohorts of patients who are chosen for intra-arterial chemotherapy. Almost always these are not part of a systemic protocol. Additional agents have been used in the past with mixed results: cisplatin, carboplatin, methotrexate, 5-fluorouracil, Avastin, and cetuximab. The trials for phase 1 for Avastin are complete, but there's been no progress. Doesn't look like this has really worked out well. What seems to happen with Avastin is that you delay progression, but you don't abort progression. And now we're starting to look at oncolytic therapies as well. So moving on to the last part of my talk, which is where we are right now. We have developed an endovascular rat glioma model. It's a rat model for preclinical evaluation of intra-arterial therapeutics. So what we do is we get femoral access, and this is interesting. You need a microscope to do it, but you directly catheterize the femoral artery in the groin. It's done through a cut down, and then we can break the blood-brain barrier down, as seen in this colored drug. We give 25% intra-arterial mannitol, and you can see the breakdown of the blood-brain barrier along the left side of this case. And then what we do is we inject glioma cell lines. So here's an example. This is a 9 Tesla MRI and a rat brain, and you can see the original implant 3 days after implantation of glioma cells. This is 10 days later, and this is 21 days later. You can see these tumors grow just like they grow in GBM. Most of these animals are dead within 30 days. And so what we're doing here is we implant, we do an MRI, then we do IA chemotherapy, and then we follow these. And we have used carboplatin and Avastin in this model. And here are some examples. This is just a rat treated only with the IA mannitol, which is the blood-brain barrier disruptor, and you can see progressive increase. By day 35, it's fatal. This is with bevacizumab. What happens here is that the tumor grows, then slows down the growth, but then does recur. And the most interesting thing we found was with carboplatin, we were able to see the original growth at the time of implantation, but then progressive resorption of the tumor with no evidence of tumor at 30 days. Again, this is rat, this is cell lines, not GBMs. But what you can clearly see is that there seems to be a benefit. This is with progression of tumor with just mannitol, improvement in delay with Avastin, and actually complete cure with no cells which are cancerous with carboplatin. And here's some distant radiomic signatures of tumor control versus time. Again, you can see mannitol not helping, Avastin helping some, delaying progression, and the curative heat map as demonstrated here. And so we are really looking at the blood supply, recruitment, and radiomic signatures of these lesions. And that really is starting to allow us to see, can we provide an alternate methodology to characterize GBMs radiographically and measure treatment response? So, in conclusion, what is next on our agenda? What we are trying to do now is switch from the glioma cell lines to actual GBM. So we have a brain tumor lab where we harvest GBMs, and we have started doing these experiments with human GBM cell lines. And what we have done is we have gotten a nude T cell deficient rat model so that we can implant human cell lines into rats to see their impact on a chemotherapy. This, we hope, will lead to actually taking individual GBMs from patients and implanting them in rats to see which chemotherapeutic agent may be best developed. And then we eventually want to build a high throughput translational model to test IA therapies against patient-derived specific GBMs. I think there is really an opportunity to consider IA chemotherapy. I completely agree with Kirill's observation that I foresee in the future that more and more and more and more of this would be done endovascularly. I don't believe there would be a need for biopsy either, because we should be able to catheterize veins and collect blood flow from the collecting venous system to identify the markers for the tumors, and then proceed transarterially or transvascularly to provide the therapies directly into GBMs and reduce the severe mortality associated with this disease. But for us to get there, we need models, and that's what we're working on. So I think preoperative embolization for neoplasms is a pretty good idea, especially with meningiomas, but I think we need different liquid embolic agents. I don't think the ones we have right now obviate the need for surgery in the vast majority of cases. I think the future, however, is going after GBMs, and thank you very much.
Thank you, Adnan. Super inspirational talk. This is the future. I'm completely as convinced as you are. I've been doing some of this stuff myself, and I totally agree. Do we have any questions from the audience? I think this is super interesting. So the next steps, I mean, the animal models are really important here, and you already applied the mouse model, but to be able to even more do the intra-arterial injections, you need to progress to the rat, right?
Yeah, no, we actually are in the rat, because in the mouse, it's very hard to catheterize the ICA. But in the rat, we are successfully able to catheterize the ICA. And so these models have been developed in rats specifically because the intra-arterial route is only available in the rat. And what you can do is we use a Magique 1.2 French, and we are able to catheterize the proximal ICA and do a selective intra-arterial injection in a rat without destroying the artery, like ligating it like you have to do with mice.
Yeah, it's a fantastic method. Have you seen my paper on it? No, maybe not. I'll send it to you.
You gotta send it to me.
Yeah. So
I've seen Fernando Gonzalez has done really good work. He actually showed all the way catheterization into the MCA in a rat.
Oh, yeah.
I haven't done that myself because we end up never making it there without hurting the rat. So we stop in the proximal internal.
Yeah, that's my experience too. To the MCA, you can get with a hybrid wire safely, but to get the Magic to the M1, I have the experience that you have. So getting these nude rats, you will be able to translate the U87 glioma model, and then when you have that, you will be able to do a high volume testing of all kinds of substances.
Yeah, so that is the proposition, is that we're working with a group here locally here in Buffalo that's creates these spheroids, they call them, which are a cluster of cancer cells. So they sort of break up the tumor sample that we have and break these cells into individual balls, and which are almost autonomous. And then our plan is to implant these spheroids into the brain rather than just a slurry of cells into the brain, which is what we have done with cell lines thus far. So we're trying to see if we can evolve our way of delivering these tumors. And if we had a model like this, you can imagine you can try different chemotherapies and then use that in the patient.
Absolutely, and then with this, I mean, you will be. All this makes sense, of course, because excising a glioma, you excise the tumor that you see, and we all know that there is tumor in many more places of the brain. So, an intra-arterial therapy makes absolute sense. And
you know, one other point I would make, Fabian, is that, again, talking about meningiomas, I have personally been disappointed with long-term control after transarterial embolization with Onyx itself. And I believe the fundamental reason for that is that we are not getting into the capillary bed, that Onyx tends to be more proximal And so there's always recruitment possibility for residual elements to gain blood supply from other sources. So I think there are newer agents which are coming up primarily in the peripheral space, where they just keep on going from artery to capillary to vein. I think if we had those kinds of agents, I think we might be able to make surgery less likely for even these surgical diseases as well.
Yes. Nader has a question.
Yes, Adnan, hi. How are
Hey,
you?
Nader.
Hey.
I am enjoying your photographs of dancing.
Oh my God. We needed you here. So, very nice talk. Just a small comment about meningiomas. We started to do meningiomas in La Pitié by embolizing with the particles, and then we shifted to glue and onyx, and the final result is that we found that, like you said, that the particles have a much better penetration if you use the small particles in the bed of the meningioma. And we had some in unreachable, I did some cases in unreachable surgical meningiomas with microparticles. We found a regression by necrosis of the meningiomas, like the clivus meningiomas or things like that. And I found that maybe we will find some, like you said, some other agent that have a better penetration of the bed of the meningiomas, because onyx and glue, honestly, we only have a proximal devascularization. So the meningioma recruits again, and we do not really get the meningioma.
Yeah, I completely agree with you. I think smaller PVA particles are much more effective. So you want to use 50 micron or smaller particles. I think they give you the greatest penetration. The problem is there's always some element of meningioma that remains, and so long-term cure still is not a common event. I think that's the main reason we can't proceed further. I think we need better liquid embolic agents for these indications, which are not the ones we use for AVMs or fistulae.
Thank you. Excellent. So thank you again, Adnan. Appreciate this fantastic talk, and we'll proceed here with the program, and enjoy the rest of your weekend.
All right, my friend. Thank you very much, everybody. Have a great party tonight, I hope, again.
Yeah,
all right.
Hope to see you soon.
Share pictures. All right, bye-bye.
Bye. So the next, we will have Pascal Mosimann from Canada, Toronto. He has recorded a video for us, which I think is going to be super exciting. Experience with new generations of neuroguidewires that can enhance navigation.
It's a pleasure for me to be virtually present this year in the Neuroetics Forum. I wish I could have been there in person, obviously, and I hope to be there next time. Let me share. Okay, so today I want to talk to you about some new technologies that are pretty exciting coming out on the market that I've been involved in. First disclosure, I'm a minor co-founder of Arterial Medical that some of you may have already met. They have created the Smart Guide 14-wire, which I will be talking about today. It has FDA clearance as well as Swissmedic and CE approval since last year. Some of you may remember the Columbus 14-wire from Rapid Medical. It had some interesting features, but a very bad torque, and so it wasn't widely adopted, and they've refocused that technology on bigger wires. The drive wire 24, something I may touch upon some other time, but the 14 wire didn't perform as expected. I started a research collaboration with the postdoc engineers that who then became Rapid Medical in 2015. Last year, Pavamaki did the first in-man safety study with the team. Finished this year, and I had Canada Health approval this year, and I've been doing a couple of cases. I anticipate to have done a good dozen by the end of the year, I suppose. A couple have been done also in Stanford. This is a small video just to show you what can be achieved using this wire. Sorry about the quality, but as you can see, the objective is to try to avoid going around the world. And so, yeah, I'm sorry that the quality of the video is kind of poor, but in between the green stuff, you'll be able to see that you can shape the microcatheter, and by shaping it, push the microcatheter in the different branches without having to lead with the wire. So it's an interesting feature. I'll probably move to the next slide because otherwise it'll become a bit more too annoying for you. If we come back to the sheeping technique that you published with René Chapeau in 2013, this was one of the illustrations of that article. And you can see that in this MCA aneurysm, we demonstrate that by placing one microcatheter, you can catheterize the branch, so to put a balloon, for example. But oftentimes what is also needed is the ability to create these micro pigtails and to push them through the circulation from the carotid to the MCA generally, which isn't necessarily that easy to do for those who don't have the experience. And so with the arterial guide wire, this is something that you can create, which is pretty interesting. So this is an example of a superior cerebellar aneurysm that we treated not too long ago. You can see these are just the initial images. We've catheterized the right PCA, and now we've created a small shape. Then we use this to kind of catheterize the different branches. You can see that the torque is pretty good, whether with the microcatheter or the wire. We still had to do a little, I guess, maneuver close to the dome in this case, followed by partial deployment of the stent, then coiling the aneurysm. Wire. This is another example of an intraorbital hypervascular tumor. So I want to show you this case. You'll see that, you know, with the locked wire mechanism in place, here you can see a bit more of a selective view of the tumor vascularized by the atomic. You can see that we've created this S-shaped catheter, and we can, from the ostium here, catheterize, and using this lock mechanism, catheterize pretty distally the ophthalmic artery without having to use an adjunctive balloon or some other device. And you can see that this allowed us to put a headway duo pretty far into those vessels and include everything with optimal coils. So it tends to give a faster, safer, and cheaper procedure. This is another example just showing a hypoplastic right A1. And here an ACOM aneurysm fed by a dominant left A1. So again, here you can see the capacity for the wire to be locked into place and to kind of easily catheterize the first branch here, the A1. You can modulate the shape so that you can of the wire, so you can actually also modify the shape of the microcatheter. You can see the progression here through the contralateral A2, and here just an example to show that it was relatively easy to catheterize the ipsilateral A2. And again, starting over from below with as you can see here, a pretty sharp little mini pigtail on the wire, allowing you to really catheterize this branch relatively easily. The tip is quite soft and allows you to be atraumatic, but is strong enough if you lock the mechanism to help you guide the microcatheter. Here we're deploying a baby Leo, and obviously have a balloon in the upper branch, and now we're doing the shelf technique to make sure that we can nicely occlude the neck of the aneurysm, just maintaining some balloon inflation to avoid coil herniation into that branch. Final detachment here of the stent without any issue, and then recatheterization of that stent. Baby Leo stent, relatively straightforward. Just the case. The most important thing in this case, I think, was to demonstrate the capacity of the wire to really achieve different angles in a very interesting fashion. Final control showing everything was fine. These are just the measurements, of the aneurysm that I probably should have shown you before. Also, the parent vessels. Anyway, let's move on. So, I don't want to waste too much of your time. So the take-home message basically is, this wire allows you to create in situ tip shaping. It has a great torque, and as you saw, it can create an anti-herniation mechanism to lock the microcatheter and avoid it from herniating into the bigger parent vessel. It allows you to form any microcatheter, the tip of any microcatheter into some kind of bended. So it's very versatile, allowing you to have different shapes. The Headway Duo 1.6 seems to be probably one of the best ones so far. It also works with balloons. We tried it with the Eclipse. Seems to be a little better than with the Scepter. And these new haptics, allow you to create some wireless type of microcatheter leading the way to catheterize branches without necessarily having to put the wire forward. Also allows you to find new angles and avoid going around the world looping, as well as the micro pigtail technique and the sheeping technique that obviously are great. But if you can now forego this by having these new types of wire, I think it really creates new options that are very interesting. There's a robotic version that will soon appear with the deflection mode, which will be independent from the torque, because currently there's a mechanism whereby it also has a dial that you turn to get the deflection. But this seems to be a little counterintuitive for those who are not very experienced with it. So to simplify this aspect, the next version will be a bit more simple, where you can actually choose from 1 to 9 the deflection of your tip, and then just use the torque as you usually use it. I just want to switch gears now and go to another type of technology, which is a flow-guided, magnetically steerable nanocatheter that we've been developing with another group of engineers. You can see on this figure that the objective is to actually harness the hydrokinetic energy of the blood flow, and so as soon as you pop this little flat tube into the circulation, it wants to just follow the blood flow. So we're actually in a type of kite technology, whereby you hold this catheter that has a tendency to go forward, instead of the usual technology that we now know, where you push with a wire, you lead with a wire, and then over that you generally push your microcatheter. The magnetic head is pretty small. It can go technically down to 40 microns and up to 350 microns. So as you can imagine, this allows potentially to reach arteries that are currently not easily accessible. Just giving you here a scale of the arterioles and or human hair, and you can see that we're really along those dimensions. A capillary, just for reference, is still beyond the I guess the capacity of those probes, but
Did we lose the sound? I'm afraid that this is too...
having a role to play in epilepsy or movement disorders. Also, maybe interesting for robotics, because the need for haptic feedback will be virtually inexistent with this technology. This is again just to remind people that the conventional approach is generally to push, whereas in catheters, which tend to obviously cause a lot of friction around the outer curves, and obviously the more distal you go, the more this friction increases and the less torque you have on your material, and the more dangerous it becomes, especially in terms of perforation. And so at some point, as we know, it becomes difficult or impossible to go further. Whereas this flow-driven technology just follows the central vector of the blood flow. So in case of stenosis, we'll just fly like a red blood cell and go as long as we allow it to. We've done initially some bench testing, and we moved on to the in vivo test. So if you're interested, you can read about the ex vivo and in silico phases that we published in 2020 in Nature Communication. And now we've moved on to animal experimentation in pigs. So this is usually the setup. As you can see here, we generally have a guide catheter. Within that guide catheter, we'll generally otherwise, the probe will collapse because it's so thin and flexible that you need obviously the flow for it to go forward. So it needs to be perfused here, and once it gets into the artery, then the blood flow carries it. But until then, we need to perfuse that in order to release it in the artery, and then to be able to steer it is a robotic arm that has been created, pretty flexible. It doesn't have yet the capacity to kind of know where the other components may be, the patient or the detectors, but that's obviously something that will come with it next iterations, and the control. Of the magnets that has an influence here on the tip of our probe here. You can see the radiopaque tip, and through the different modifications of this magnet, you can see that we're capable of selecting all the different branches that we need by attracting or repulsing this head. To safely get into virtually any branch. So here we just demonstrated we could go in all of these. I'll just accelerate this just to show that we could go in all of them. Right. So yes. So this is a. I think this was an AP view. Yeah, you can see here the ophthalmic. The ophthalmic artery here and the choroidal blush here. This is another more selective view. Pretty nice depiction here of the whole globe and the iris and the long ciliary and choroidal arteries here. And so this was to show basically the navigation of our probe. This was a 150 micron probe. Which is 0.006 French, so it's smaller than the Hybrid 7. and it is hollow, which allows you to inject contrast or embolic agents, as I'll show you. And here you can see the progression of that little probe pretty far into those arteries. The next slide is to show you the embolization, actually. So again, here you briefly see the probe getting into that ophthalmic artery, and we're going to place it here in one of the long ciliary arteries. I'll just accelerate that a little bit. But it was pretty straightforward, as you can see. There's a bit, maybe some difficulties to really follow the tip here. That's why we added this red square, because depending on the speed of progression, you kind of lose the radiopacity. And here's the plug formation injecting some SQUID12. Obviously, we can't do pressure cooker techniques with this probe, so it's still kind of the classic way to form plugs, which we know is more difficult with SQUID12. So once we form the plug, you can see that now the embolic agent is progressing pretty well. Now you can really see that it's going as expected into the different branches. And this is the final cast obtained through this little probe. Demonstrating the proof of concept. Take-home message for this technology is that it's pretty impressive how small the engineers have been able to create this. Capable now of navigating and demonstrating the concept of truly flow-guided navigation of micro ribbons, these so-called nanocatheters. We were able to demonstrate the capacity to inject contrast as well as embolic agents, so it's the DMSO compatible. In this case, it was SQUID. There's virtually no risk of perforation with this technology, so it makes it pretty impressive. And it has the potential to reach arteries that are currently unreachable, and even arterioles. So you can imagine that the basal ganglia, the perforating vessels, maybe we'll be capable of seeing these Bouchard aneurysms in hypertensive patients who present with spontaneous hemorrhage. Maybe inject a little drug there or do something about that. The anterior and posterior spinal arteries and So with that, I'll end my presentation and I'll stop sharing the screen. I want to thank, obviously, Minjil and all the organizers for having invited me to talk about this subject. I hope that I soon, if you have any, text me or just send me an email. And I look forward to seeing you all very, very soon. Take care, everyone, and it was a pleasure to present to you today. See you soon, hopefully.
Yeah, that was a fantastic talk. No, it's like Pascal he has also invented a time machine, and he's speaking to us from the future. That's why this transmission was a little bit bad. So, do we have Mikhail Kondratiev or Bubur Mahmudov? Would you like to? Can you hold your? So, was it Mikhail? Bobor. Okay, yes, because your talk is perfect. You will talk about intra-arterial chemotherapy and the modern treatment of neuroectodermal tumors. From Tashkent, Uzbekistan. Yes. And is Mikhail here today, or
maybe not. So if Mikhail is not here, maybe we can do your recorded live, this pseudo live case. Yeah, perfect. So we will have Rajeev's case after Buber. So while Buber is setting up, any thoughts about the steerable wires? I think they will probably become significant in the near future.
Just a minute.
Yeah. So I have myself already explored the steerable microcatheters, and they work surprisingly well, and I think that's also something that we'll develop and put to use in practice. Okay. Perfect.
Can I start? Okay. My greetings, and I'm very thankful from committee organizers that given to me the chance to show to you our results, our center's results, and especially I'm very thankful from the Mujil Kisovich, Rahmet, for the chance to show our results and to show what we do and what we did. I'm very thankful from the Professor Siddiq, Adnan Siddiqui, that he the presentation was for me the very helpful presentation, and I'm distant from to saying something about the technique, about the indication, contraindication, because the Professor Adnan Siddiqui said and showed, and it's easy for me to say, and I plan to only focus on our results, to show the case series. We know what's intra-arterial chemotherapy, and what's the super selective intra-arterial chemotherapy, which used in the middle of the previous century, first in the Hepar tumor. And today it's used for as Professor Siddiqui mentioned, for the retinoblastomas, for the brain gliomas, and the other human tumors. It's mentioned protocol, stock protocol, which produced in the 2005, which indicates the treatment of the brain gliomas, and it's in a different shape. Please give the attention. There is no indications. There is no any words about the intra-arterial chemotherapy, and because of this, I think not widely spread this kind of methods for the treatment for the brain gliomas. It's all the things. It's mentioned. It's said from previous our presentators, and let me only focus on our center's work, our results. We did the intra-arterial chemotherapy in the 12 patients in the brain gliomas, which is classified as a from the World Health Organization classification G3 and G4, and we have 41 patients with the retinoblastomas. And it's a first case, it's a first example from our center, a patient 61 years old with a recurrent brain gliomas, right parietal occipital lobe since May of 2022, histology GBM. He underwent the radiotherapy and plus 6 course of the classically chemotherapy with the temozolomide, and first the surgery was done in the November of 2021. After 6 courses of chemotherapy, despite of this temozolomide, despite of the despite of the radiotherapy, as you can see, the signs of recurrence. And it's after first course of super-selective intra-arterial chemotherapy with bevacizumab with 15 milligrams per kilograms, you can see the reducing of this size as a response of this tumor to the bevacizumab. And after the third course of the super-selective intra-arterial chemotherapy, you can see the size almost reduced and in the stable size. But I strongly agree with Professor Adnan Siddiqui that it's not solving the problem, it's not treatment, but I think it's earning some time in order to get the radiation. It means that in order to escape from the overdose of radiation, after the 60 or the 56 milligray radiation, the patient even gets the 6 or 8 chemotherapy, but no change. The tumor will grow, and no way, because no way to the radiotherapy, no way to the chemotherapy, and I think even the situation such kind of this, I think it will be a good decision to get the intra-arterial chemotherapy to earn some time in order to get or to reach the radiation therapy. It says second hour, the patient, 21 years old, with the tumor in the right frontal lobe, histology anaplastic gastrostom, post-op series from the September 20 and 22. You can see that after the radiation plus 7 course of chemotherapy, the result. And after the second surgery from the September 20 and 23, and I can mention that she hates this September, the month of September. Then every September she was operated in the 20 and 22 and 20 and 23. Even the January of the beginning of this year, she asked it from me that I hate the September. I will operate in the September again because of this recurrent glioma. But we did, as you see, in the November of 20 and 23, the signs of recurrence. We did 3 courses of super-selective intra-arterial chemotherapy with bevacizumab, 15 milligrams per kilogram. It's September now, it's 20 and 24, but no signs of recurrence. She feels herself very good. In the we planning that dynamic findings, and I think it's no signs of the recurrence, but I am distant from saying she is treated, but there is no signs. The other group about retinoblastomas, really, the Professor Adnan Siddiqui mentioned that it's a really good works with the retinoblastomas, and I strongly agree with it's my patients. And the first step, when we did the first intra-arterial chemotherapy for the retinoblastomas in the 19th of October 20 and 22, and the first case with bilateral retinoblastoma class D underwent 6 courses of system chemotherapy with vincristine, etapazide, and you can see the signs of the retinoblastoma. It's almost get the retina fully. And after 3 courses of these chemotherapy results, with some calcification, no signs of the growing. And the second patient with bilateral retinoblastoma class D underwent 7 courses of system chemotherapy. You can see the big, huge retinoblastoma. And ultrasound signs of the retinoblastoma, which means the hypervascular signs. And you can see the results after the 3 course of superselective intra-arterial chemotherapy with melphalan plus topotecan. The signs of calcification and the size of the tumor reduced, and she now in our dynamic findings. It was challenging. It's not so far. It was 3 months ago. The newborn baby, bilateral retinoblastoma. You can see in the right ocular that it's not so big, but it's a class D, and in the left eye, it's a class U. It was a direct indication for the enucleation, but the relatives, parents, they was not agree with the enucleation, and we did 2 courses of melphalan in superselective intra-arterial chemotherapy. You can see in the right, its size was reduced to the signs of calcification. You can see the tumor calcified and in the stable size. But in the left side, there is a reducing of this tumor, and you can see in this place tumor was died, but still there is a tumor alive. We're planning to do 3rd course, or even if need, we plan to do the 4th course. And thank you for your attention.
Thank you for a great talk. Do we have any questions? So seeing this, you are doing something that many centers are dreaming of being able to do a super selective treatment in this way. It makes a lot of sense, and I hope that we also at some point will be able to join studies on this. Fantastic to hear that you have a good result in your first patients, and indeed this is a devastating diseases, and we have to do everything that is possible to help these patients, and no doubt that you are doing it. And for the retinoblastoma, we have more than over 10 years experience with the treatment, and I can only agree, it's a very, very strong effect on the tumors. There are some complications to the treatments. They have maybe not been so frequently discussed, but the children can experience trigeminal cardiorespiratory reflexes. Usually they are mild, but it can be a bradycardia and bronchospasm that can complicate the procedure a little bit. And also, of course, you have to think about that you are setting a treatment up against a treatment that is 100% curative, 100% without complications, which is enucleation. But still, I think this is a very good treatment that we can offer with a very low complication rate. And I think there are some groups that are finding that also the children are able to regain some vision, and being able to distinguish what is night, what is day, crude movements. It can, of course, be of great benefit to the individual.
Yeah. Yeah, it's true that the complications, like ophthalmopulmonary reflex,
yes,
it's very devastating. When we start, as I mentioned, in the October of 1992, with our team, we spent approximately 3 or 4 hours, and in the beginning, we had the ophthalmopulmonary reflex all time. All time, and you know, it means that in the first case, it's not reflex. In the second course, we noticed the ophthalmopulmonary reflex as a bronchospasm, as a reducing of the rate of heart rate, and after it, I don't know, it's not proven, but it's our opinion. We did the, firstly, the catheterization only the C1 segment of the internal carotid artery, and the gate catheterization, only the gate catheterization of the ophthalmic artery, not the entering to the ophthalmic artery. Even after it, this reflex, this reflex was reduced in the rate. Yeah, there were 1 or 2 cases we noticed again this reflex, but after the gate catheterization, no such kind of reflexes.
Oh, thank you.
And I have the one little the result. The main how to say main the complication, it's a local complication, is edema, and is as a the changing of color of the skin.
Yeah. Yeah, so what we do there, we give them some vasoconstrictor, like a nasal spray, and also put some gauze with a vasoconstrictor to prevent the melphalan and topotecan to migrate in the periorbital soft tissue. I don't know if it's a significant help, but thank you so much for sharing your experience with the reflex, because it's always a discussion for us, and we don't understand why it happens, but I will bring that home to the team, your experience. Yeah. So let's see if we can modify a little bit to reduce the frequency. Okay, perfect.
Thank you very much. And thank you very much. And again, I'm very thankful from the Minjuk Salvage. We want to offer to Uzbekistan, all of you, and if it's possible, we can offer you being a guest and to organize the next neuroedics in the Uzbekistan, in the famous and modern historical cities like Bukhara or the Samarkand. It will be beneficial for us, and we have the results to show you, and we have many things to learn from you, and it will be beneficial not for the not only for the auditor, for our neurosurgeons, our neuroradiologists, and it's an offer.
I think it sounds like a fantastic opportunity. Let's do it.
Thank you, Babur. Thank you. Great presentation, and we will count this recommendation about Uzbekistan. We already discussed with our Neuradic team, and Valid Brinjiki is dreaming to visit Uzbekistan. Maybe next Neuradic we can organize there. Yes, we need to set the day, and then you can start the organization. Let's see. It's also the visa-free country. You need to look for the countries visa-free, because with Egypt, it took us more than 2 months, Ahmed. Yes, it's very important. Yes. It's good, Fabian.
It's fantastic.
Next time, pilaf and Uzbek dance.
Yes, I already learned something important from Uzbekistan with catheterization and complications, so I want to learn more.
Yes.
Thank you.
And on this Neuradict, we had nearly 20 participants from Uzbekistan. Also, Shafkat is working in a Republican Neurosurgical Center. And Mahkam, he already left. And there are several big teams, and I hope we can do it. Let's see.
Thank you very much. Thank you. I hope to see you.
Okay, so
Now I think if Mikhail is not, he's not coming. So let's finish the today's session with an exciting live case from Rajeev. Sivasankar from Mumbai. You have something recorded for us.
So at the outset, Minjil, big thank you for organizing yet another fantastic ADX meeting. So I think I'm the last man standing between you and freedom. So I'm going to keep this as quick as we can. So Minjil said, there was a case which was a little odd. So he said, okay, let's do a live case. Unfortunately, in India, the laws are pretty stringent. They do not allow us to do anything really live. So I've recorded this last week. So we'll see how this goes. How do I move this? Can you help me with this? Oh, okay. Okay. All right. So this was a 62-year-old man. He about 2 years ago he presented with a bleed, and this was a left tectal bleed. So this is midbrain on the left side, the little bit of IVH that you see here. He lost consciousness, had a headache obviously. He was managed conservatively for this. After which, this is the MR angiography. Obviously we don't see the AVM out here, but this is just to show you that the rest of it also looks good on MR angiography. This was the angio in 22. You see some steady feeders from the tectal branches, which actually were coming from the choroidal branch. And you can see the draining vein here, tectal vein, straight sinus, same here. This is an image of the veins, which makes sense as to why we've put it here as we go along the presentation. This is 2022. Just keep a watch on the transverse sigmoid jugular foramen out here. Looks okay. Similarly out here, there is just these projections here, these diverticuli, but otherwise the veins look okay. This was during the transvenous catheterization, and we were going in for a reverse pressure cooker technique, but unfortunately the anatomy was really bad, so I had to forego the plan of a pressure cooker technique and go ahead with a standard transvenous embolization. This was the control from the tectal branches, and this was a 5 French Cobra glide, which was finally, I could navigate this up. After which this was the cast after our embolization, and I don't know if this will play. How do I play this video? Can you play that video for me, please? No. Just put your mouse, yeah, just play that. No? Okay. Okay, fine. So we'll go ahead, and this was the presentation 2 years ago when he developed paresthesias at the right half of his face and severe occasional right-sided headaches. So we did an MRI and we found this. So if you remember the previous MRI, the MRA, it did not show anything, and now he developed a dural AVF on the what looked like the jugular foramen with reflux. This is a twist dynamic contrast enhanced MR angiography, which shows us that there is a type 2 dural AVF at the jugular foramen with reflux. These are the angiography images, and the ECA angiogram shows us that there is a component which is supplied by the posterior auricular artery, and that supplies this part of the dural AVF. And the anatomy of the vein looks a little weird out here. It looks segmented. There seems to be a pouch which is posterior, and there seems to be some kind of narrowing here at the distal sigmoid jugular junction. There is reflux into the temporal veins in addition. This is the component which is supplied by the posterior auricular. This is the component which is supplied by the neuromeningeal trunk on the lateral angiograms. This is the occipital. So if you look at the pouch which is here, that seems to be the one which is the culprit on which the fistula is developed. This is a AP picture of the same. This component is from the posterior auricular, and this component here is from the neuromeningeal trunk, which is supplying the fistula. So in this presentation, you'll see that we are breaking some rules, and we are swimming against the tide. So we'll discuss that later. This is the posterior circulation. There are some thready feeders which are coming from the V4 segment, and there's a lateral angiogram of the same. So this is a fused image just to show us that how close it is, which means that we have to protect this area with a balloon. A lateral of the same, which shows that, okay, this is the fused image, which shows that we need to protect the vertebral and how far we are or how close we are to the area of the target. So this was the strategy. Before we go to the video, we wanted an arterial axis, a venous axis from the femoral root, a radial axis to control the posterior circulation, to protect the posterior circulation, and the plan was to take a posterior auricular axis first with a balloon, short nose, and then go ahead with a balloon protection with a copper neck RC in the sinus and a 4x15 hyperglide for the right V4, and do an EVO embolization. So this was the standard axis. We took the artery, the femoral artery, we took the femoral vein, and now we're going with the radial axis. And what we're placing here, you can see the artery, the vein, and now we're going with an envoy 6 French guiding for the vertebral. We keep the envoy up. And once the aim was that to put the hyperglide up there, which you'll see in a minute, I guess. So these were 2 more envoys, one in the vein. This is the vein now, the copper neck coming up into the vein. This was a 10x80 copper neck RC, which is going up across the sinus to protect this. And we get the balloon across. There was some tightness here at the foramen. Then this is our axis, the posterior auricular, and we are getting a 6x7 eclipse short nose over a 14 wire. And the aim was there were 2 branches which are coming from the posterior auricular, and we thought with balloon inflation we should be able to penetrate and get this. Obviously we didn't want to do the neuromeningeal trunk. So this is the navigation into the branch which we thought was probably better. We were having some difficulty in getting the short nose up. And then finally we could kind of go there. This was the injection through the balloon, and we thought that's good. Inflated the copper neck and started the EVO embolization. And we started the embolization, and then it was going okay. And then after the initial, we went on. It was going more lateral initially, so we did the standard. It was a cocktail. This was initially with squid 18. Inflated the balloon a little more. I was having problems with this, with the inflation. It kept deflating for some reason, so I had to keep reinflating that. I don't know why. And we continued with the embolization from the eclipse. It went up took some time, switched to squid 12 somewhere in between, and was alternating between, I think, squid 12, 18, and going ahead. So as you can see at the balloon, I had to inflate it a little more time and again. And I thought at this point in time, after getting these kind of branches, it will start penetrating. And this was just about maybe 3 or 4 minutes into the injection. So we just waited a little bit here. It still wasn't going to our target area, which is around here. And the pouch is somewhere around here, which is what we wanted. And then it kind of started going to the area that we wanted it to go. So it started going here. And it was getting the area, inflated the balloon a little more. And this was the part that we wanted to penetrate and get everything else. So I think we inflated the balloon some more here. Here. So that we preserve most of the sinus and just get the pouch, which was separate from the vein. As you saw, it was almost like a separate part of the sinus. And inflated the balloon some more, got some reflux. I wasn't happy with that. But I wasn't having, after that initial penetration to the area of the target, I wasn't really getting. It was just refluxing, even with inflating this more and more. So we went ahead with more injection, but it still wasn't doing any great stuff into penetrating the target area which we wanted to go to. So more inflation of the balloon, thinking that it will help to cook it, but so inflated the balloon some more, but it wasn't really happening. It was just out here. It never went forward after that initial part, and then it started refluxing a little more. And we were somewhere around, I think, 15 odd minutes from the injection, and then it started going to the region of the stylomyostoid, etc. And I didn't want to go there because of the facial. And then it started refluxing here. At which point in time I wasn't too keen anymore on this axis because I didn't want the balloon getting stuck. So we gave one more try. I removed some slack, changed the angulation, and inflated some more here, but it was just refluxing back. So you can see it was just coming back. So at this point in time, this was the angiogram, and the balloon is still undersized for this sinus, but that's fine. But the component from the posterior auricular is not seen. The fistula is really filling well from the aggressively from the neuromeningeal trunk, and this was the time that we knew that if we wanted a cure for this, we had to take the neuromeningeal trunk, which is what I did. So we bit the bullet, and this is something which we have done quite a few times before. It isn't new. In fact, this was a headweight duo that we took in. I didn't cook this. I don't like cooking in the neuromeningeal trunk for reasons I'll explain later. I took a headway duo in, gotten as distal to the jugular division of the NMT. This was the microcatheter angiogram. And like I was telling Pero yesterday, I first inflate the balloon a bit because I like the flow to be towards the pathological part of the fistula. And in my opinion, I want some shunts to be open for me to penetrate. As we got closer, I inflated the balloon to protect the V4 segment. and we continued with the EVO injection. So this is the balloon. And you can see the stenosis here. It was really tight at the jugular bulb. It was very, very narrow. There was something going on in this region, I don't know what. Injected, there was some reflux coming back, had to hold. Change projections, inflated the balloon more now because it was beginning to go to the areas that we wanted to. So now we knew that we probably needed to just be patient with this whole thing. And this was the injection. A part was going to the needle side. We didn't want too much of that, so we waited. We waited a little more, and it was coming back to the part that we wanted to. So one of the principles you can see in this, the way I'm injecting, in fact, coincidentally, Nadir was there, the 23 Bald Prime talks, and given a talk on the use of neuromeningeal trunk for dural AVFs. So you can see here that I do not inject hard. I inject rapidly when it's going to the target area, and the target in this case is pouch. I don't increase the force of injection when using the neuromeningeal trunk, because that I feel will push it to anastomosis, which I don't want it to go, but I increase the rate of injection. So which means now there is a philosophy to this, which is the use of something called Darcy's law and Poiseuille's law, which means that there has to be a gradient of flow which helps us guide. So there is a scientific principle to this, that we can use this without getting it to go, pushing it hard. Increase the pressure and you'll have anastomosis that goes into which we don't want it to. And now it starts going into exactly the parts that we want to fill. It goes into all the arteries that we want to fill while keeping the sinus open. And this is the part that is the abnormal part, which is here. So it slowly is getting all the vessels which are part of the AVF. So there is this component which is the main culprit, which we know that we need to get. And that component on the AP projection is this, which is filling now. And this is the part now which starts penetrating. We are like about 20 minutes into injection, and it's going pretty well here. And this is the part, exact part, which I want to fill intentionally, because if I inflate the balloon more and I don't get this, I always feel there's going to be a chance for a recurrence. So I want to get this. If you remember, in the old times, we used to always fill the sinus, and that's a permanent cure. But here we can get the permanent part of an isolated part of the fistula, which is separate from the sinus. Just changing this a little bit, doing a control out here. Injecting some more to get the superior part of that. So it was a very funny AVF. It wasn't exactly at the jugular foramen either. It was somewhere out here. So I don't know what this was. This was a control which showed some steady supply here. Went ahead, I think, with some injection here. So this was more, I think this was squid 12 which is getting injected now. I was switching between 18, Onyx 18, squid 18, squid 12. And we were about 25 minutes now into injection, and this is the exact part around this which was good. The moment this was filling, we knew that the job was like almost done. We were just doing the top-ups. And we are around the balloon right now. So it's looking markedly better. Go ahead with the injection. Injecting more, always keeping an eye whether this is what on the medial side we don't like, because that could go towards the ICA, and a lot of it can come down towards the odontoid. We won't know that. Now here's the pouch. On the lateral you can see that absolutely separate from the sinus, and this is the pouch. The moment this was done, we knew that it's cured for sure. But if we're doing the top-ups just to be sure, and this is taking stuff from the occipitals. And at this point in time, it's cured. We know that there's no more fistula which is seen. This was the previous transvenous embolization. This is a posterior run. After deflating the balloon here, and you can see the sinus is now being used, which was not being used earlier. This is the right common carotid run. Now the brain's using this all antegrade, and you can see that the sinus is well used, and the fistula is obviously gone. This is the lateral common carotid angiogram. So brain is good now, fistula is gone. The brain is using the sinus well antegradally. So this was the CT scan at the end of the procedure, and this was the cast from the previous transvenous embolization of the tectal AVM. And if you look at this part now, we are coming up to this was the pouch, and this was the AVF. So nothing in the sinus, everything else is protected. This is what it looked like on the MIP, and this was the separate segmented aspect of the sinus on which the fistula developed. Clinically, he was extubated, he was fine. We kept him on LMWH. This is a protocol for all dural AVFs. We keep them on LMWH and dexamethasone, and on day 3 we discharged him. So thank you for this presentation. And the questions which were on my mind as to why did the dural AVF develop in these past 1.5 years, I think it was a traumatic AVF following the transvenous embolization, though there was no obvious trauma at that time. It was a neuron max that had taken up as a base camp and a 5 French Cobra. But it was a straightforward procedure, but I have no other explanation. I'll be happy to discuss the same. Thank you so much.
Thank you, Rajeev. This is a truly expert case. Being comfortable doing the injections here in the neuromeningeal trunk so extensively, finally getting the fistula, it's expert work, don't you think? So what did you? So what was the first lesion? It was an AVM, or was it a mixed malformation? As a pure
it was
AVM?
a pure tectal AVM, a
yeah.
deep AVM which had bled.
Yeah, and how often do we catheterize the sinuses, and how often do we see dural fistulas secondary to that?
So, whenever we do the IIH patients and stent them, we do this very commonly, not so uncommon. I've never seen one which is developed. And neither in our transvenous embolization series is the first one that, it's a short series, but I've never had this. So if you include all our cases, I'm talking about the non-CVT cases of venous catheterization, clean veins. This is the first case I'm seeing.
Yes, so I agree. Guillermo. So.
Rajeev,
yeah.
Beautiful case. Do you think they are correlated, the catheterization and following development of the fistula, or it's something that happens and...
I don't know. I really don't know. But I think, there was a separate segment to that posteriorly, as you saw. It was separate from the sinus. I think there must have been something that I have traumatized while taking up the neuron max, etc. I have inflamed it because in 1.5 years for a dural AVF to develop de novo, it had to be something that I had done.
Okay.
That's what I think.
Okay. I really think they are not correlated because, as you said, we do lots of venous catheterization. It may happen that someone develop a fistula. It's natural. Another consideration, in such situation where you had lots of feeders coming with dangerous anastomosis, if we find a pouch, a venous pouch that we think is the point of fistula, we try to put a microcatheter there and inject the squid or onyx or whatever with the balloon inflated, but from the venous part, and sometimes it's useful to avoid to embolize directly the feeders with the dangerous.
It's a good point. So, I thought the one consideration when I failed with the posterior auricular was, should I come from the opposite side and put in some coils into that pouch? But the problem was, I wasn't sure if I could A, come into that pouch separately, and B, I really wasn't sure. At that point in time, I was thinking of coils, if I could put in some coils into that part. But I never thought of putting squid into that pouch from the venous side.
Okay. Did you do, as I shown yesterday, we always do Vaso CT or Dyna CT to understand if there is the pouch and to better understand the anatomy and the architecture of the fistula of the region, and it's always very helpful in our experience.
Yes, so we did that in the diagnostic angiogram phase when we first did the DSA, which was about a week prior to the treatment.
Okay, we prefer to do it in general anesthesia because frequently patients move, and so it's, in our experience, is better with patients in general anesthesia because so you have better images.
Right.
Yeah, you mentioned the software that you use to fuse the images.
We use Philips.
Which one?
We use Philips.
The Philips system, yeah.
Yeah.
Because on the Azurion system, you have to have the old software to use the fusion feature.
Yeah, we can do it. We can do it. But just a suggestion: if you can't do it with your machine and you have an Apple, you can fuse the images with Toros, and you just export them, and you can do. And if you have a good computer, you can do with 3D slice, and you can fuse the number of volumes you want, and you can fuse them, and it's.
Yeah, this was the thing you mentioned, the 3D slicer, but of course you can push Philips to reinstall the old software on your new Azurion, so you can do it directly on the station.
Oh.
I didn't say this, but...
One last one, Rajeev. Well done. But on the recent one, last week, angiogram, and you also showed it in your balloon inflation, that there was some narrowing stenosis which was developing on the sigmoid and jugular. Was it there on the first one? One and a half years ago?
No, it wasn't.
Okay. So that was new?
New.
And that cannot be related to your venous catheter, right? How can it be?
Could.
So the images, it was the sinus appeared to be not so regular when during the treatment of the AVM.
There were diverticuli there, but we see only the flow on the 2D angiograms. Only when I inflated the balloon did I figure out that it's hard and tough. So, but the separate pouch as such, I knew that that's the area because when we studied the high frame rate angiogram, that was the first thing filling and then refluxing.
Other comments?
So I guess we conclude today's session. I must personally say that today was a very, very high level, and I'm super happy that to be part of this very high level discussion and cases and also future technologies. It's unusual to have so many interesting things in a short time.
I will give you your certificates.
Thank you very much. Very nice moderation.
Thank you.
I want to give microphone for the professors and friends came from abroad. Let's start from the, how to say in Spanish? Abuelo. Some words.
What? Some words? About yesterday night?
Yes.
With the vodka? Okay. No, this is my second participation with you. It's first time was like 1.5 years ago. We were in Almaty, and now in Astana. And honestly, I would not miss it for nothing in the world to just to come and to be with real good friends. And we enjoyed all the lectures and your live cases, your work, excellent. And it's always a pleasure to be here with you. So what else can I say? Nespresso? What else? So thank you very much.
Thank you.
Thank you, thank you.
Ahmed, you did it.
Minjal. It's my second time too in Kazakhstan visiting you. The first time was in Almaty in 2019. There is another one that I skipped and I regret skipping it. I'm happy I could acquire the visa the last minute. You helped me a lot to do it. It's a great meeting and you brought a lot of friends from East and West. And we also make new friends here. The level of science is high. The level of discussions, the presentations, everything was great. And the horse meat was great too. Thank you very much.
Thank you. Guillermo?
It's my second time again. And I'm always impressed how well you can. We know, everybody knows how good you are in your job, and it's something well done. But we are always impressed how well you organize what you do this meeting, and it's impressive. And I'm always happy because we are friends and we talk about. We like, so thank you very much and congratulations and keep on.
Thank you.
Thank you.
Thank you. Uday.
Yeah, you know, so I'm easily, maybe Khairul, but I'm easily like, amongst all of us, this is my third one. So, you know, I don't think, have you come 3 times? Yeah. So, you know, we have come maximum number of times over here. And I'm amazed. I mean, everyone knows about your hard work and how you bring people together. I think that's the most important part of your personality. And we are thankful as a group. You know, I don't think we thank you enough. But we are thankful that you do this fantastic meeting and still call it Neuro Addicts Forum. You could have called it anything else. And I think for that, the maximum, all of us, gratitude to you. Always a pleasure. And we meet often, so I hope that, again, we meet soon.
Fabian, your first time?
Yes, thank you. This is my first time, and I was so happy. I was talking to Pascal Mosimann in Marseille last year, and I always have a lot of opinions and discussion, and he said, "Hey, are you on neuroaddicts?" I was, "What is neuroaddicts?" He said, "Are you not on you must be on neuroaddicts." And since then, I have learned so much from this forum. I follow you and your live streams, learn a lot from your very skilled technique, and I introduce it into my own practice. It's not only a technique, it's only a mindset. Sometimes, some situations, I just think what Mijilki says, it's okay. Big fistula, what are we going to do? It's okay, we'll embrace. So it was, I think this met all my expectations, and I would be honored to be invited again. Thank you.
Rajeev?
Menjil, my compliments to you. I think organizing a meeting of this standard, which is growing by the year, is an amazing feat. You have obviously kept the international standards, and you're pushing the bar up each time. This time there was Optira, you were showing us cases, the new things to learn. So thank you very much for pushing the bar up. You're obviously not human, because you do cases 8 days a week, it's not 7 days a week. So there's something seriously wrong with you. But thank you for being abnormal. And you inspire us with your dedication to neurointervention. Thank you to Laura too for helping out with so much behind the scenes, and to your entire team. I think like people have said before, a lot of it comes from the heart. So that's something which binds everyone together. It's a meeting which we love to come, not only for the scientific content, but also we make lots of new friends which will help in our profession. So I really hope that this continues to grow bigger and bigger. And you're like an adopted son of India. You keep coming there, so it's fine. We'll keep meeting. So all the best.
Thank you, Menzil. I'm actually very glad to know him, because the first time when I was invited to neuroaddict, we don't know each other, but the criteria is why you invite me. And they said you are one of the active person in the group. Since then, we develop our respect, mutual respect, like brother, and also like this platform initially is very important for us, even for me, because I can get the world-class opinion, plan, suggestion for any cases that we share, and everybody sincerely give comment and also recommendation. Even the one that I cannot forget is when I encounter one difficult case decision, that bacillus dissecting aneurysm mid bacillus, which is the teenagers. The only one to respond is Simon Maimon to occlude that vessel. Then I have to make that decision, and the patient survived. I hope this is a very good platform. Then we are here, we are the same wavelength and same passion and same enthusiasm. And also have to congratulate Menzil. By this platform, I connected to everywhere in the world, from Russia, Brazil, Israel, Europe, West. We are the same. Thank you.
Okay. Thank you. It was a marvelous, beautiful 2 days, and it was in hybrid format again. And this is survived physicians in the room, and most of the friends. Yes, most of the friends now on the way back home, and I wish you too safe travels, and I hope we will enjoy the game of Arsenal with Manchester City in the evening. And this is a team job, like in operating room. Yes, I'm doing the case, and you can hear my voice, but near me all the time my assistant, maybe 2 assistants, anesthesiology nurse, anesthesiology doctor, physician, video support team. Igor is here, and Evgeny in other room, and other colleagues. It's all the time team job. And this time we are working together with Healthcare Ministry, Medical Center of the President's Affair, Medical Centers Hospital, Kaz Neuro, and the Kazan University from Russia. And the idea to do multidisciplinary all surgery conference came from Kazan University. The first conference was organized last year, and team from Kazakhstan went to Kazan, and it was a great conference. And this year we did small part in May because they bought the tickets and they came to Astana. We did one-day session, and yes, this time they couldn't join because they said to the director, we will go in May and we will stay online. And they did online presentations in surgery oncology session. Yes, it's a good collaboration. And every 2 years we have Neuroadict, and I said, okay, we will be part of this multidisciplinary team. And for me, your support, you came to Kazakhstan, to Astana, did great presentations and joined the scientific part, and a lot of innovations. And behind the innovations and the scientific job all the time is human being. Yes. And it's not only respect for me, and also for Kazakhstan and Kazakhstan's medicine, and not only for my family, also for my colleagues. And the big team of Kaznero, hospital, medical center, video support team, presidential centers staff is allowed to do the conference on high level. I hope it was on high level. And today, offline was nearly 1,000 participants. More than 350 participants was in nurses section. We did a joint section of nurses. It was half day. And 2 days, we had half day yesterday and half day today, the section of young scientists. It was more than 40 presentations from residents, interns, and young doctors below 35 years. And we choose 2 best presentations, and we'll give the presents on Tuesday to young doctors to support them, to give inspiration for the future scientific job. And online was 1,900 visitors on my YouTube channel. Maybe later the number will grow, and it's possible to go and to see the recorded as usual. We do Sunday cases, but it's also possible to go and look for the cases after. Once again, thank you. Thank you for coming, thank you for supporting, thank you for being. I hope next Neuroadict, maybe in Uzbekistan, maybe in any place. We discussed second Neuroadict in Istanbul, but Kubilay said, okay, it's very complex to do. Maybe in Mumbai. Why not? We'll see. I will talk in Kazakh. Барлықтарыңызға рахмет. 2 күн әдемі өтті. Осындай конференцияны ұйымдастыруда әрине бұл команданың жұмысы. Бұл жерде тек қана аурухана ғана емес, сонымен қатар Казнейра, Елена, Татьяна, Айдана, больницадан Алишер, бөлім меңгерушілері, Алматыдағы Саминнің нейрохирургиясы үлкен жұмыс атқарды. БМЦ-нің нейрохирургиясы жігіттер 2 күн бойы операцияда тұрды. Лайф кейстер болды. Қонақтарымыз келді, бірге осы конференцияны өткізуге атсалысты. Және шетелден келген қонақтарымыз, оның ішінде Өзбекстаннан, Тәжікстаннан, Қырғызстаннан келген достарымыз. Барлықтарыңызға рахмет айтамыз. Конференция өте жоғары деңгейде өтті деп ойлаймын. Кеше 3000-нан астам гибридтік форматта қатысушы болса, бүгін 3000-ға тарта қатысушы қатысты. Барлықтарыңызға рахмет. Аман болайық, бар болайық, осындай конференцияларда кездесіп жүре берейік. Рахмет. Thank you. And now, Ahmed, yes, we can say the conference is officially closed. Thank you.